తర్వాత డాక్టర్ సుబ్రహ్మణ్యం గారు, డాక్టర్ నందకిషోర్ గారు. సార్ ఇంకెవరైనా మాట్లాడతారు సార్? సుబ్రహ్మణ్యం గారు,
సుబ్రహ్మణ్యం గారు, నందకిషోర్ గారు ఉన్నారు సార్.
అదే సుబ్రహ్మణ్యం గారు, నందకిషోర్ గారు కాక ఇంకెవరైనా మాట్లాడాలా? డాక్టర్ సుబ్రహ్మణ్యం గారిని అడుగుతున్నా నేను.
ఇంకేం లేదు, మీరు ప్రెసిడెంట్, దెన్ సెక్రటరీ, ఎనీ రిపోర్ట్స్, దెన్ స్టేట్ ప్రెసిడెంట్, స్టేట్ సెక్రటరీ, దెన్ యూ కెన్ గో టు యువర్ CME program.
ఓకే. హ్యాండ్ ఓవర్ టు CME ప్రోగ్రామ్, అంతేగా?
సార్ లైవ్
సుబ్రహ్మణ్యం గారు, నందకిషోర్ గారు కాక ఇంకెవరైనా మాట్లాడాలా? డాక్టర్ సుబ్రహ్మణ్యం గారిని అడుగుతున్నాను.
ఇంకేం లేదు, మీరు ప్రెసిడెంట్, దెన్ సెక్రటరీ, ఎనీ రిపోర్ట్స్, దెన్ స్టేట్ ప్రెసిడెంట్, స్టేట్ సెక్రటరీ, దెన్ యూ కెన్ గో టు యువర్ CME program.
ఇంటర్నెట్ బందేగా?
హ్యాండ్ ఓవర్ టు CME ప్రోగ్రామ్, అంతేగా? సుబ్రహ్మణ్యం గారు, నందకిషోర్ గారు కాక ఇంకెవరైనా మాట్లాడాలా? డాక్టర్ సుబ్రహ్మణ్యం గారిని అడుగుతున్నాను.
ఏం లేదు, మీరు ప్రెసిడెంట్, దెన్ సెక్రటరీ, ఎనీ రిపోర్ట్స్, దెన్ స్టేట్ ప్రెసిడెంట్, స్టేట్ సెక్రటరీ, దెన్ యూ కెన్ గో టు యువర్ CME.
హ్యాండ్ ఓవర్ టు CME, అంతేగా?
Sir, it's live, sir.
Okay.
Unmuting. Good afternoon, everybody. All the doctors.
ఎంతమంది వచ్చారు లైవ్ మీద? ఎంతమంది అడగపోయారు ఒకసారి?
We are live, sir. We are live.
Okay.
Good afternoon, all doctors. Welcome to CME 2020. We, the doctors of IME Tenali and the executive committee, are organizing the virtual CME 2020 on today and tomorrow, 26th December and 27th December. We welcome you all for the scientific feast which will be happening for today and tomorrow. For this, I would like to request our president, Dr. Bhimvarapa Samireddy Garu, to enter, to call on to the dais. I also request Dr. Subramanian Garu, President AP chapter. I request Dr. Nandakishore Garu, Secretary of AP IMA, Andhra Pradesh IMA chapter. Sir, over to Dr. Samireddy Garu.
Okay, sir. We are very happy, sir, to conduct this CME meeting, and a lot of work has been done to do this. Okay, sir. We will go straight away into the meeting. First, the prayer will be read out by Dr. Srikanth. IME prayer.
May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lore. Completed.
Over.
Over.
respected Dr. Subramanian Garu, IMA State President, Dr. Nandakishore Garu, IMA State Secretary Garu, and Dr. Srikanth, our Secretary, and dignitaries of our executive members of our IMA, Dr. Akhilesh, Dr. A.V. Prasad, and others,
Rajarav.
and all the members who are enthusiastically joining this today's CME. A very good afternoon. Dear friends, let me first thank all the people who have been working hard for the last 2 weeks to make the program a great success. We, the Tenali IMA team, thank the senior colleagues, the APMC, the institutions who are sponsoring the unit, and all the people who worked for the success of this unit. Tenali, as you all know, is known as Paris of Andhra. It is because of the three canals that traverse across the town. It is known for many things. It used to be a cultural center famous for stage artists and both social and, as you all know, Pauranika Natakalu. It used to be a great literary center. Great writers like Chalam, Kodavatiganti Kutumbarao, Kaviraj Tripurnen Ramswamy, Gopi Chand are a few people worth naming. And senior artists like Savitri, Sarada, Bommadi, Jaggaya, AVS, Prabha, Krishna, Mahesh Babu belong to this place. An independence movement and in independence movement and during the Quit India movement, Tenali area played a great role. 7 people who have sacrificed their lives are remembered at the Ranaranga Chowk, situated near the overbridge. With this brief historical background, and Tenali is continuously playing a role of good medical center. Tenali is also continuously playing the role of a good medical center. Senior doctors like Dr. Chadravad Krishna Garu, Dr. Sundaramaya Garu, Dr. Dakshinamurthy Garu used to be good at academics also. So with this brief introduction, I take this opportunity to welcome you all for this virtual 2 days CME. I hope this will enrich our academic knowledge, which will be useful in our regular practice. Thank you all. Thanking you. Now, Dr. Subramanian Garu, our state president, will address us.
Esteemed members of the Tenali branch of IMA, President, Secretary, and the executive members of Tenali IMA branch. At the outset, I am very much thankful to you for inviting me to address this CME program. And as our president has told, the Tenali is of historical significance with lots of historical aspects are there. As he mentioned, lots of poets and then dancers and then actresses and so many people. They belong to this Tenali. Is a very good name, famous name in the state of Andhra Pradesh. Now, I am very happy the Tenali branch is conducting the CME program, which is very essential. Now, the knowledge is exploding. There is developments and both technologically and otherwise. There is exponential developments in the medical field. If you take both the diagnostic wise or the treatment aspects, everywhere there is a lot of developments. If you see diagnostically, in the olden days, it is only just an ordinary X-ray, which used to be done for most of the disease. Now you can see there are so many technology, CT scan, MRI scan, PET scan, and PSA, like that variety of latest developments have come. Similarly, in the treatment modalities also, if you take a large number of drugs have come for various diseases, and so many surgical procedures are implemented. Lots of surgical equipments like microscopes, endoscopes for operations and all are there, and even uh, so many of these developments in the medical knowledge. Now it is not possible for any single person to cope up with this latest development. More so a person who is practicing and who is busy with his private practice or otherwise. So it is always necessary to have a program like this, a continuing medical education program, which can enrich all the members in the day-to-day practice and all. I am very happy today the Tenali branch is organizing CME with a variety of topics, especially the cardiology topics, which are very important. Nowadays, when the infections are more controlled, we are getting more and more of metabolic disorders like diabetes, hypertension, stroke, and ischemic heart disease, and above all, the cancer. So all these things are adding up to our disease profile. So a detailed discussion of these things is very useful. I am sure that the learned speakers of today's CME program, they will enrich the knowledge in various subjects. We have seen today's CME, which is very much full of very interesting topics. Now, these CME programs, I don't know whether you got the AP Medical Council approval or not, but all of you know for the re-registration of our degrees, there is a need for some certain credit hours. 6 hours at present, 6 hours in a year. Like that, 5 years, 30 credit points or credit hours are needed for re-registration of our degrees. Every 5 years, all of us have to re-register our degrees. So CME is like this. You can, I don't know whether you got it or not. The AP Medical Council will give you the credit hours. That also you can utilize it. So both for our enrichment of knowledge and also for this credit hours for re-registration, you can get it in these CME programs. Now, coming to the IME AP state, I am a neurosurgeon, retired professor. So I am more interested in the academic atmosphere of this thing. I want to encourage the academic fields in the IME AP state. Uh, I should tell you, I think most of you are aware that there are two academic wings in our IMA. One is College of General Practitioners. Number two is Academy of Medical Specialties. Now, College of General Practitioner, any basic medical graduate of modern medicine, that is the MBBS and above, can join in this College of General Practitioner and become a member. And after certain programs, the a person who is registered as the member of a College of General Practitioners can get a fellowship called FCGP. FCGP. Now, the second academic wing is Academy of Medical Specialties. This is mostly for the postgraduates with a postgraduate degree or diploma. You can become a member of the Academy of Medical Specialties. Now, here also, basing on the experience and the research work and all those features, a person, a member registered with the Academy of Medical Specialties can get a fellowship called FIAMS. FIAMS. So, either College of General Practitioners for the basic medical doctors and Academy of Medical Specialties for all the specialists, both the things will get fellowships, either FCGP or FIAMS. So I request the President, Secretary, and the Executive of this Tenali branch to enroll as many as possible, both in the FCGP or AMS, depending on the eligibility of these things. These things we will get it from the state office, our General Secretary there, the applications for this thing, the rules and regulations, and also in course of time we would like to make these programs a very fruitful and CMEs and a large scale will be done. And IMA AP state is organizing so many CMEs. In the last 1 month, ever since I took over as the president, we have already organized a large mega CME at Visakhapatnam, where 1100 members have enrolled to enter to join in the CME program. And later on, there were CME programs, two at Tirupati and two at Nelluru and one at Kakinada. And now in Tenali also. I am very happy that so many of these CME programs are going on. I wish many more branches also will come forward, and you yourself also again and again conduct the CME programs. And next time you apply for this APMC recognition and get credit hours also, and then have this facility of pre-registration. I am once again very happy to be associated with the Tenali branch of IMA. I wish the CME grand success. I declare this CME open, and thank you very much. Thank you. Unmute. Unmute yourself. కామ్రేడ్ గారు మీది మ్యూట్ అయి ఉంది, అన్మ్యూట్ చేయండి. మీ దాంట్లో కింద నీ రెడ్ ఇది ఉంది ఒకటి సౌండ్, ఇది దాని మీద నొక్కండి.
శ్రీకాంత్ నువ్వు చేయి శ్రీకాంత్.
చేస్తున్నాను సార్.
Who is controlling that thing?
యా
శ్రీకాంత్ యూ కెన్ అన్మ్యూట్ హిమ్. సామిరెడ్డి గారిని అన్మ్యూట్ చేయండి. హోస్ట్ కదా మీరు.
అవునవును సార్. ఐఎమ్ జస్ట్ లుకింగ్ ఇంటు ఇట్.
పార్టిసిపెంట్స్ లోకి వెళ్ళి.
ఎస్ సార్, ఐఎమ్ డూయింగ్ ఇట్ బట్ ఇట్స్ నాట్. బషీర్
పార్టిసిపెంట్ లిస్ట్ చూడండి.
బషీర్ సార్ ని అన్మ్యూట్ చేయండి, సామిరెడ్డి గారిని.
ఓకే సార్, ఇప్పుడు చేస్తాను. సార్ అక్కడ ఒక పాపప్ వచ్చింది సార్. అక్కడ
ఎవరికి? సార్కి వచ్చిందా?
సార్కి.
అక్కడ ఇప్పుడు అన్మ్యూట్ చేయమని సార్.
డైరెక్ట్ గా ఆయన దాని మీద ల్యాప్టాప్ ఏంటి మొబైల్ ఫోన్ దాని మీద ప్రెస్ చేయమని చెప్పండి ఆయనకి. సాంబిరెడ్డి గారు మీది ఏంటి ల్యాప్టాపా? ఆయన వినపడదు మనకి. ప్రెస్ చేసి రెడ్ గా వస్తుంది, దాని మీద మళ్ళీ ప్రెస్ చేయండి, అన్లాక్ అవుతుంది. అయింది, మ్యూట్ అయి ఉంది. ఎవరు హోస్ట్? ఎవరు?
బట్ ఐఎమ్ నాట్ గెటింగ్ ఇట్. ఐఎమ్ ఆస్కింగ్.
యు షుడ్ బి ఏబుల్ టు అన్లాక్ హిమ్.
సార్ నేనే హోస్ట్, చెప్పండి సార్.
అతనే హోస్ట్. షబీర్, బషీర్, డాక్టర్ సామిరెడ్డి గారిని అన్మ్యూట్ చేయాలి.
నేను దానిలో చేయాలనుకుంటా సార్. చేసుకోవాలి
సార్. ఆల్రెడీ నేను అది ఇచ్చిన సార్. అది ఆస్క్ టు అన్మ్యూట్ అని ఒక ఆప్షన్ వచ్చింది పైన, ఓన్లీ క్లిక్ చేయండి సార్, అంతనే.
బషీర్ చెప్తాను సార్, చెప్తాను. ఎనీ ప్రాబ్లం? సార్ మీరు అన్మ్యూట్ చేయాలి సార్, సామిరెడ్డి గారు.
చెప్పండి ఆయన ప్రొసీజర్.
బషీర్
ఇప్పుడు అయింది.
సామిరెడ్డి గారిది అది సిస్టమ్ ప్రాబ్లం అనుకోండి, చూడు ఒకసారి. సాంబశివుడు గారు
వచ్చింది.
ఇప్పుడు వచ్చిందండి. థ్యాంక్ యూ సార్, డాక్టర్ సుబ్రహ్మణ్యం గారు, ఫర్ యువర్ గుడ్ అడ్వైస్ అండ్ for your information, we got the APMC credits also, sir, for this conference. We got 4 hours.
Very good.
And also your advice is well taken, sir, to register many of the as many people as possible from our branch. We will try definitely. Next, I request I invite Dr. Nandakishore Garu to give a few advices, sir.
Thank you, sir. Thank you. Am I audible, sir?
Yeah.
Yes.
Yeah. Good afternoon, everyone. Respected State President Dr. Subramanian garu, in Tenali Branch President Samreddy garu, and Young Secretary Srikanth, and all participants. Good afternoon from IME State side. As all of you know, it belongs to Guntur, so I am very happy that one of the branches of Guntur is conducting this program. Tenali is actually very active branch in our district. They conduct regularly gold medal orations and so many activities. They are even active during COVID time also with some of their charity work. And it is unfortunate to miss Dr. Laukusha garu, who was very senior physician. Recently expired because of COVID, and I pray God for his soul to rest in peace, sir. And I wish this program is going to be very successful, and I wish all of you work together and conduct many more programs like this, sir. Thank you very much for inviting me for this inauguration session, and happy to see that in CME, one of my students, Dr. Sandeep, is delivering his lecture. Also, and ENT surgeon and dynamic surgeon from Manipal. So, I wish once again wish this CMA should be grand success. Thank you, one and all. Thank you.
Thank you, sir. Thank you, Dr. Nandakishore garu, for your valuable words. I think we can now proceed to the CME straight away. Dr. Srikanth.
Thank you, Dr. Samreddy garu. I have got another CME running, and neuro conference is going on. So
Right,
I have to
thank
join.
you. Very nice of you, sir, to have come over, taking your time, busy time. Thank you very much, sir.
There is one AP State Neuro Conference is going on now, today and tomorrow.
Okay.
So I am one of the judges there. I have to join there.
Okay, sir. Thank you.
Thank you very much. Thank you all.
Thank you, sir.
Thank you, sir. Thank you, sir. Sir, program schedule.
Srikanth Samreddy garu, nenu kuda koncham.
Yes, sir. Sure, sir.
Kindly permit me to go.
Sure,
Yeah,
sir.
yeah. Thank you, Srikanth.
Thank you for taking
sir.
your
Right.
time and
Thank
coming.
you, sir. Thank you. No problem, sir. Thank you.
Okay, first we will go to the first session. The first session moderator will be Dr. T. Akhilesh. Akhilesh, are you there?
Akhilesh, they'll let it then, sir.
We'll let him మేము ఇన్ చేస్తా ఉన్నాం సార్ ఇనాగరేషన్ సెషన్ కి లేదు కాబట్టి ఇప్పుడు ఇన్ చేస్తా ఉన్నాం.
Okay.
Yes.
Akhilesh. Then the chairperson will be Dr. C.H. Samsivudu and Dr. Amarnath.
Madan, what happened to Dr. Samsivudu garu?
వాళ్ళు వెయిటింగ్ రూమ్ లో ఉన్నారు సార్, మేము ఇన్ చేస్తా ఉన్నాం సార్.
Sure. Go ahead.
Okay. Let them in. We will hand it over to the chairperson.
To all, sir, ఒకసారి ప్రోగ్రామ్ చెప్పేస్తాను సార్ డెలిగేట్స్ కి.
చెప్పండి. అందరూ వింటారా ఇది?
అందరూ వింటారు సార్. Good afternoon, everybody. This CME 2020 is organized on 26th and 27th December, and we have 16 speakers talking about different aspects of medicine. The session will start from 3 p.m. to today on 26th December, and the first session will go on up to 5 p.m. It will be moderated by Dr. T. Akhilesh. So each session will have one moderator and chairpersons and the speakers talking on different aspects, of medicine. The second session will start from 6 p.m. and go on till 8 p.m. That is for 26th of December. And for 27th of December, that is tomorrow, the sessions will start at 9 a.m. tomorrow and will go up to 11 a.m. for the session 3. And session 4 and 5 will go on from 12 to 2 p.m. So that's about different sessions, which we different scientific sessions, and all the I wish all the speakers best of luck, and we will meet at the closing ceremony. Thank you.
Akhilesh is there?
Akhilesh is there, sir. He'll take over, sir.
Okay.
Sir.
Madhav is ready, no? Ramsudu garu.
సాంబశివుడు, అమర్నాథ్.
ఇంకా రాలేదనుకుంటా సార్.
I request all the speakers, they would be having only 20 minutes for their presentation and 10 minutes for the questions. Delegates who want to ask questions can put your questions in the comment box. And the chairpersons will deliver your questions to the speaker.
సాంబశివుడు గారు, అమర్నాథ్ గారు.
డాక్టర్ మాధవ్ రెడ్డి గారు ఉన్నారా?
మాధవ్ ఇస్ రెడీ సార్. మాధవ్ గారు
రెడీ సార్.
అమర్నాథ్ గారు వచ్చారా? రాము, సాంబశివుడు గారు దేవారిని.
సాంబశివుడు రాలేదేంటి? ఓ, మదన్ ఆయన లైన్ లో ఉన్నారంట. దాన్ని ఆయన లోపలికి తీసుకొచ్చినట్టు లేరు. మదన్
సార్ ఏం చేస్తా ఉన్నాం సార్.
తొందర చేయండి. ఇంపార్టెంట్ వాళ్ళని వరుసలో మీరు ఫాలో అవ్వండి సార్. దే ఆర్ ట్రయింగ్ అండ్ సాంబశివుడు టు గెట్ యూ ఇన్. హీ ఈజ్ రెడీ.
So please rename this 8246357880, sir.
సార్ సార్ ఫోన్ నెంబర్ తో లాగిన్ అయి ఉన్నారు సార్. కొంచెం పేరు రీనేమ్ చేసి పెట్టండి సార్ ప్లీజ్.
పేరు డాక్టర్ సాంబశివుడు. ఏం చేయాలి
సార్? నేమ్ లేదు సార్ అక్కడ, అందుకోసం ఇన్ చేయలేదు. ఫోన్ నెంబర్ తో లాగిన్ అయి ఉన్నారు.
ఫోన్ నెంబర్ చెప్పమంటారా మీకు?
సార్
ఫోన్ నెంబర్ చెప్పంటారా?
చెప్పండి సార్.
9848212776.
ఓకే సార్.
మదన అయిందా?
సార్ లేరు సార్.
ఉన్నారు వెయిటింగ్ లో ఉన్నారని చెప్పారు.
యాక్చువల్లీ సారు
సార్ కింద పార్టిసిపేషన్ లిస్ట్ లో క్లిక్ చేస్తే కనిపిస్తాయి సార్ ఎవరెవరు అక్కడ వెయిటింగ్.
యాక్చువల్లీ సార్ జూమ్ లోకి రాలేదేమో సార్.
సార్ లైవ్ లోకి వెళ్ళలేమో సార్. నేను ఒకసారి కాల్ చేసి చెప్తాను సార్.
జూమ్ లోకి మామూలుది కాకుండా జూమ్ లోకి యాడ్ అవ్వాలి సార్.
అట్లయితే అందరినీ సెన్సిటైజ్ చేయండి మీరు. స్పీకర్స్ ని చైర్పర్సన్స్ ని అందరినీ సెన్సిటైజ్ చేయండి ఒకసారి. ముందు సాంబశివుడు గారికి చెప్పి
సార్ లైవ్ చూస్తా ఉన్నారంట. సో నేను జూమ్ ఇన్విటేషన్ మళ్ళీ పంపించాను సార్ కి. ఇప్పుడు జాయిన్ అవుతారు సార్ 2 minutes లో.
నీకు పంపించా చూడు, నేను కూడా పంపించాను. జూమ్ ఇది దాంట్లోకి రావాలి. అట్లాగే అలాగే. మదన్ గారు ఈ లోపల వేరే వాళ్ళని ఎవరితో చెప్పి మిగతా వాళ్ళందరినీ కూడా సెన్సిటైజ్ చేయండి.
ఓకే సార్. అంత
ముందు ఇచ్చిన లింక్ లోకి వస్తూ ఉంటారు కదా మిగతా వాళ్ళంతా.
సార్ కన్ఫ్యూజ్ అవుతా ఉన్నా సార్. నేను చేస్తాను.
తెలియదు కదా, మాకు కూడా తెలియదు. మీరు ఇందాక చెప్పిన దాకా నాకు కూడా తెలియదు కదా. నెక్స్ట్ వాళ్ళని లైన్లో పెట్టినప్పుడు మిగతా వాళ్ళు కూడా దీంట్లో పెట్టేసుకోండి ముందు.
షూర్ సార్.
టూ పీపుల్ వచ్చారంటే వెయిటింగ్ రూమ్ లోకి, చూసారా?
మదన్ వచ్చారా?
అమర్నాథ్ గారు ఇప్పుడు వచ్చారు, జాయిన్ అవుతున్నారు. సాంబశివుడు కనపడలేదే. అమర్నాథ్ వచ్చారు. అమర్నాథ్తో మొదలుపెట్టి వచ్చాం. అమర్నాథ్ ఉన్నారు లైన్లో, చూడండి. అమర్నాథ్ గారు,
అమర్నాథ్ సార్ ఉన్నారు సార్.
అమర్నాథ్ గారితో మొదలుపెట్టి ఇచ్చేస్తే బెటర్ ఏమో కదా.
సార్
నువ్వు అఖిలేష్, అఖిలేష్ మీరు మాట్లాడి అమర్నాథ్ మొదలుపెట్టేమనండి. సాంబశివుడు విల్ జాయిన్.
ఫస్ట్ టాపిక్ సార్, ఫస్ట్ సెషన్. I invite Chandu Samsivudu garu will join shortly, and Dr. P. Amarnath to act as chairperson for this session. The first topic, sir, for today's now session is ABC of bone marrow transplantation by Dr. D. Madhav garu, MD DM, Manipal Hospital. Madhav sir, kindly take over, sir. మాధవ్ గారు,
అమర్నాథ్ గారిని అడగండి, పిలవండి ముందు.
ఎస్ సార్, I invited sir Amarnath. మదన్
సార్. ఎస్ సార్.
అమర్నాథ్ గారిని ఏంటి ప్రాబ్లం? అమర్నాథ్ గారిని అడ్మిట్ చేశాము, ఆయన ఎందుకని రాలేదు దీంట్లోకి?
సార్ మళ్ళీ జస్ట్ లాగౌట్ అయినట్టున్నారు సార్. మాధవ్ గారితో స్టార్ట్ చేద్దాం సార్.
మొదలు పెట్టేసేయండి.
ఏ సార్, మదన్ మాధవ్ గారిది అన్మ్యూట్ చేయాల్సి వస్తుంది చూడు ఒకసారి. ఆయన అడుగుతున్నారు am I audible అని.
అన్మ్యూట్ మా సైడ్ నుంచి అయిపోయింది సార్, చేసేసాం సార్. సో సారే ఒకసారి సార్ సైడ్ నుంచి అన్మ్యూట్ చేయాలి సార్.
ఎవరు? మదన్ గారా? అమర్నాథ్ గారు, సాంబశివుడు గారు వచ్చారండి. మదన్ గారు,
అమర్నాథ్ సార్ వచ్చారు సార్, మళ్ళీ టెక్నికల్ ఇష్యూ వల్ల వెళ్ళిపోయారు సార్. అంటే
సాంబశివుడు గారికి ఎందుకని రాలేదు?
ఇంకా కనెక్ట్ అవ్వలేదు సార్. మరి ఇంకా నేను ఒకసారి మళ్ళీ ఇంకోసారి కాల్ చేసి
సాంబశివుడు ఎందుకని రావట్లేదా? హలో, ఎందుకని రావట్లేదా కనెక్షను? సాంబశివుడు వచ్చిందా? మేము కనపడుతున్నాం. మ్యూట్. మీరు నువ్వు జూమ్లోకి వచ్చావా? జూమ్లోకి వచ్చావా నువ్వు? ఓకే, మీరు ఓకే. మదన్ గారు, ఆయన వచ్చారంట, ఆయన మనం చూస్తున్నారంట. ఎట్లాగో ఏదో తేడా ఉంది చూడండి.
సార్ జూమ్ లింక్ ఓపెన్ చేయలేదు సార్. సార్ జూమ్ లింక్ లైవ్ లోకి వెళ్ళారు సార్. సార్కి మళ్ళీ నేను కూడా పంపించాను సార్ జూమ్ లింక్. సార్
ఒకసారి మీరు నెంబర్ ఉంది కదా, నెంబర్తో ఒకసారి కాల్ చేసి డైరెక్ట్ చేయండి ప్రాపర్గా.
చేశాను సార్, మళ్ళీ ఇంకోసారి చేస్తాను సార్.
అమర్నాథ్ గారు
లైన్ లో ఉన్నాను.
ఓకే
అమర్నాథ్ గారు స్టార్ట్ చేయండి. అమర్నాథ్ గారు,
I'm happy to be in this virtual CME of Tenali for the first time in Guntur and Vijayawada region. After my MD, just a brief introduction about me. Hello.
You are audible, sir.
Good sir, good sir.
ఉన్నాను సార్ నేను.
You are audible, sir. Go ahead.
Sir, go ahead, sir. Amarnath, sir.
Okay, okay.
Sir, we are running out of time, sir. We will start with Dr. Madan. మదన్ గారు, మాధవ్ గారు, డాక్టర్ మాధవ్. హలో హలో డాక్టర్ మాధవ్ గారు.
హలో.
యా నౌ యు ఆర్ ఆడిబుల్, సార్.
Am I audible?
Yeah, Amarnath, you are audible. Yes.
Okay, thank you.
మాధవ్ గారు, డాక్టర్ మాధవ్.
మాధవ్ సార్ ఉన్నారు సార్, కాకపోతే ఫోన్ చేస్తా ఉన్నా లిఫ్ట్ చేయడం లేదు సార్. ఇక్కడ
హలో
సాంశివుడు సార్.
హలో, వినపడుతుందండి? వినపడుతుందా?
yes sir.
ఓకే, థ్యాంక్ యూ. ఓకే.
హలో
స్టార్టింగ్. హలో, అఖిలేష్ సాంరెడ్డి.
సాంశివుడు సార్. We are starting the first session, sir. You are the chairperson, Dr. Samshudu garu and Amarnath garu.
I am able to. Are you able to see me? Talk?
Yeah. Yes.
Yeah.
Okay. Thank you. Hello. Can I start?
Yeah, sir. Yes, sir.
Start.
Okay, Samreddy. At the outset, let me thank all the IME executive and also all of our members for conducting a wonderful CME program. And I think many people, not only from Tenali and Guntur district and Krishna district, other places also have enrolled themselves for the CME program. And in the beginning, I invite I thank the moderator also. I think moderator has given the introduction part of the first speaker is Madhava.
Yes, sir.
Madhav. I think Madhav, I think you start the transplant, this bone marrow transplantation. Is it? Am I correct?
Yes. ABC of the bone marrow transplantation.
Bone marrow transplantation. ABC of the bone marrow transplantation. See,
Sir,
bone marrow transplantation nowadays is becoming very much important. And with this, many people, our doctors community, especially so hematologists, are able to save many lives. With this small introduction, I am inviting Madhav to give his lecture.
After my MD General Medicine in Manipal, then I have started searching for the department which is good. Hello. Okay.
అమర్నాథ్ గారు మాట్లాడుతున్నారు.
Okay.
ఇంకేమన్నా సరిగ్గా రాలేదా?
Later I joined DNB Super Specialty in Bangalore, Narayana. Hematology is a very great branch. Okay, it is like
అమర్నాథ్ గారు
sir, unmute. Amarnath sir, unmute. Okay.
Hello.
Start, sir.
Okay.
Sir, remaining, can you mute, sir, remaining members?
Dr. Amarnath, you can carry on.
Okay. With good number of transplant physician in our Guntur and Vijayawada, and with there is some lag period, sir. So there was some confusion.
Hello. Can I start my talk? Am I audible?
Yes, sir.
Okay, I've unmuted myself. Just give me a second. Hello.
Madhav sir, you are audible now. Please carry on, sir.
Hello.
Madhav sir, you are audible.
Hello.
Madhav sir, you are audible. You can carry on.
Sir, Madhav sir, please start.
Very good afternoon, everyone. Sorry for the technical snag. I'm Dr. Madhav Dantala, a consultant BMT physician at Manipal Hospitals, Vijayawada. Over the next half an hour, we shall discuss the ABCs of bone marrow transplantation or stem cell transplantation, or simply put, the basics of stem cell transplants. We'll start with a brief introduction to the field of stem cell transplants. We'll then have a look at the types of stem cell transplants and also the journey from diagnosis to long-term follow-up post-transplant. First, a bit of history. So the physical consequences of World War II precipitated research leading to stem cell transplants in the 1940s. The first human marrow transplants were conducted in the 1950s by E.D. Thomas at Fred Hutch. HLA typing became available in the 1960s, which led to bone marrow transplants taking off in the 1970s, once we had a better understanding of the biology of the process. We made significant progress ever since, resulting in improved outcomes. So what is a stem cell or a bone marrow transplant? One, it is a complex medical procedure. It's not a surgery. Two, what are we transplanting? We're infusing healthy blood-forming stem cells intravenously into the body to replace damaged or diseased bone marrow. So what's the basis for stem cell transplants? Now, when cancer cells are bombarded by standard doses of monthly chemotherapy or radiation, some cancer cells can effectively switch on protective shields against whatever is attacking them by changing their gene expression. In other words, they constantly evolve and adapt. This resistance can, however, be overcome by dose escalation. Stem cell transplants allow delivery of high doses of chemotherapy, like the equivalent of giving 6 months of chemotherapy crammed over a week. This would produce lethal bone marrow suppression if not rescued by stem cells. Transplants also allow introduction of a novel or a new immune system that can recognize and eliminate the remaining cancer cells. In the case of congenital blood or immune disorders, the goal of a transplant is to replace a defective system. But coming to the types of stem cell transplants, based on the donor, they're categorized as autologous. Auto is one's own. So in autologous transplants, the stem cells are sourced from the patient itself. Allogenic when they're from a related or an unrelated donor, or syngeneic when they're from an identical twin donor. Moving on to the types of stem cell transplants based on the source of stem cells. Now, stem cells can be collected by direct aspiration from the bone marrow with the donor under general or spinal anesthetic. This was the only way we could physically retrieve stem cells in the past, hence the term bone marrow transplants. They're seldom done these days because we found ways to harvest stem cells directly from the peripheral blood. This can be done by injecting granulocyte colony stimulating factor or GCSF to stimulate the stem cells to leave the bone marrow and enter the peripheral blood. There are other drugs such as plerixafor or cyclophosphamide that can be used for mobilization. The patient then undergoes 1 or 2 or sometimes 3 leukapheresis procedures, during which around 10 to 20 liters of blood are processed using a blood separator like the spectroptia. The patient is hooked to this giant centrifuge by an access line such as a HT catheter or a Hickman line, and the component containing stem cells are collected in a bag. And they're cryopreserved at sub-zero temperatures if required until it is needed for a reinfusion, and the blood is then returned to another line to complete the circuit. The other kind of transplants are umbilical cord blood transplants, and the placenta and cord is filled with fetal blood that is enriched for stem cells. This can be collected if provided by volunteer families, can be screened, tested, frozen, and then used later for stem cell transplants. The types of stem cell transplants based on the degree of match are matched sibling donor transplants, matched unrelated donor transplants, mismatched unrelated donor transplants, and haplo or half-match transplants. Only 20 to 25% of patients will have a matched sibling donor for transplants. And the probability of finding a matched unrelated donor in the worldwide registries varies with ethnicity and race of the recipient. It is as low as 10% for Asians and nearly 80% for white Europeans. The likelihood of finding an unrelated donor is highest within our race or ethnic group. HLA antigens, which we will talk about in the next few minutes, are inherited as a set from each of the parents. So it's easier to find donors for haploidentical transplants, about a 95% chance when children, siblings, and parents are tested. So what do you mean when we say that someone is a match? Now, unlike blood donations, which can be given to the millions and millions of people who share the same blood type, stem cell donors are carefully matched to their recipients and on a one-to-one basis. The key to finding a good match is a set of molecules called human leukocyte antigens, abbreviated HLA. These decorate the surface of peripheral blood stem cells and most other cells. So match means at 6 main loci, A, B, C, DP, DQ, DR on each set of chromosomes. So it's a total of 12. Out of these, 10 are important. So a 10 on 10 is a full match, an 8 on 10 or a 9 on 10 is a mismatch, and a 5 on 10 is a half match. Now for the remainder of the session, we will focus on the transplant journey itself. The first question you have to answer is, does my patient need a transplant? The indications for stem cell transplant are listed. So multiple myeloma is one of the most common indications for stem cell transplants. And the other indications for autologous transplants are lymphoma, either in the relapsed setting or in the refractory setting, with the exception of a mantle cell lymphoma. Some solid tumors such as germ cell tumors, a neuroblastoma, or Ewing sarcoma. Indications for allogeneic transplants are acute leukemias based on risk stratification, chronic leukemias if they're refractory or if there's a high-risk gene abnormality that's predictive of aggressive behavior or blast phase. Allogeneic transplants in aplastic anemia, myelodysplastic syndromes, and myeloproliferative neoplasms are for higher risk category patients. Benign conditions or non-malignant indications for allogeneic stem cell transplants are hemoglobinopathies, immune deficiencies, and some inborn metabolic disorders. Now, other disease-related factors affecting transplant outcome in addition to the diagnosis are molecular characteristics, prior therapy, a disease that is in remission versus a relapse, and if it is early as opposed to late in the disease course. You would also have to factor in the patient-related criteria such as age, performance status or general condition, comorbidities, and treatment-related factors such as choice of intensity of conditioning regimens and stem cell source. This whole pre-transplant testing and donor identification can take anywhere between 2 weeks to 2 months. Stem cell registries such as DKMS PMST, which is the German registry, Datri, and the Maradona Registry of India search on behalf of thousands of patients in need of life-saving transplants. To facilitate matchmaking, they curate lists of potential donors and doctors can check when the patient needs a stem cell transplant. Now moving on to the actual transplant process. So this image describes the 4 This image describes the 4 components of allogeneic stem cell transplant: conditioning, transplantation, engraftment, and immune reconstitution. By convention, pre-transplant conditioning days are numbered in a countdown fashion from day -7 to day 0, which is the actual date of transplantation. The days after transplantation are then numbered upward, such that 10 days after the transplant would be day +10. And from day 0 until engraftment, the patient's protective immunity is reduced and they're extremely vulnerable to infections. The first 3 phases of autologous transplantation are similar to those described above for allogenic transplants. The 4th phase differs in that the patient's immune recovery is more rapid and there is no potential for GVHD, which I'll touch upon later. In preparation for allogenic stem cell transplants, the recipient undergoes a conditioning regimen of high-dose chemotherapy and in some cases radiotherapy to eradicate the underlying malignant disease, to make room for donor cells, and to suppress the recipient's immune system so that it will not reject the donor stem cells. Regimens are classified as myeloablative, reduced intensity conditioning, and non-myeloablative. Throughout the neutropenic period, the patient is confined to a single room equipped to provide the safest possible environment. This is a positive pressure room equipped with HEPA filters, and the actual transplantation of the cells is a simple process involving intravenous infusion of the stem cell product through a large bore central venous catheter over 1 to 2 hours. The stem cells are then able to travel or home to the bone marrow cavity to start producing new blood cells over the next 2 weeks. It is the care of the patient after transplantation that can present much more of a challenge, especially in the setting of an allogenic transplant. Conditioning produces both hematologic and non-hematologic side effects or regimen-related toxicity. So if you look at the complications, this can affect many organ systems, but painful oropharyngeal mucositis is especially difficult for the patient. Another complication unique to allogenic stem cell transplants is graft versus host disease. It occurs when donor cells thrive in the patient's body, but reject or fight with the patient's normal cells. So the skin, the liver, lungs, and eyes are most affected, along with the GI. It can be either acute or chronic. And you have to understand that in allogenic transplants, substitution of another chronic medical disorder for the malignancy is common. So the patient might be cured of his malignancy, but he might end up having a chronic medical disorder such as an autoimmune disorder for the rest of his life. Coming to the GVHD versus GVT effect. So I've already alluded to the graft versus host disease. So this is the holy grail of allogenic stem cell transplants, where the patient is walking a thin line between GVHD and graft versus tumor effect. The presence of immunocompetent donor T cells can lead to recognition of the host tissue as foreign, and hence the development of GVHD. However, despite the morbidity and mortality associated with GVHD, its presence may be desirable in some situations because of its association with a lower risk of recurrence of the malignant disease. This is called the graft versus tumor or the graft versus leukemia effect. Engraftment is the process whereby the donor cells begin to produce new blood components within the recipient's bone marrow cavity. In practice, engraftment is said to have occurred when the ANC consistently exceeds 500. Platelet and red blood cell engraftment generally follows, and the patient is supported with blood products until this occurs. Engraftment usually occurs between day +10 and +20 and is earlier when blood stem cells rather than bone marrow stem cells are used. Failure to engraft or a primary graft failure or graft rejection, where the donor stem cells never really take in the patient's body, and subsequent irreversible decline of blood counts or secondary graft failure are serious complications. Fortunately, these complications develop in less than 5% of the recipients. In the immediate post-engraftment period or the first 3 months, 25% of patients require at least one readmission. After discharge, the patient's care is continued as an outpatient, where visits are required for blood work, to assess graft function, to look at late regimen-related toxicity, and monitor for graft versus host disease. And also for transfusion support and continuing administration of prophylactic antimicrobials, and also adjusting the dose of immune suppression. One big difference between solid organ transplants and stem cell transplants is most patients can be weaned off immune suppression at about the 3-month mark. If you look at the risks of stem cell transplants, the treatment-related mortality after autologous stem cell transplants is about 1 to 5%. Treatment-related mortality in the first 12 months after matched sibling stem cell transplants is about 20 to 30%. And this figure is higher among recipients of an allograft from an unrelated donor, reaching almost 50% at some transplant centers. Now, patients who do not succumb to a transplant-related complications may still have recurrence of their underlying disease, almost always within the first 2 years after the transplant. The risk of relapse depends on the status of the disease at the time of transplantation, but even acute leukemia and first complete remission recurs in 25% of patients. And also addressing the issue of cost of stem cell transplants, autologous transplants are now covered under the health scheme, so it shouldn't be a problem. Allogenic transplants, again, it depends on the donor status. So for matched sibling transplants, it can cost anywhere between 10 to 14 lakhs. And for unrelated donors, it can go up to 20 to 25 lakhs as, for haplo as well, it can go up to 20 to 25 lakhs. That brings us to the end of my presentation today. I'll be more than willing to answer your questions.
Thank you, Madhav garu. Now we are open questions. You can type the questions in the ask a question dialog box.
Chairpersons, please take over. Tamshudi garu మీరు unmute చేయాలి.
Okay.
Dr.
Hello.
Garu, you can add a few points.
Hello. Hello, am I audible now?
You are audible, Tamshudi, matlad.
Thank you, Dr. Madhav, for giving elaborate things regarding the transplants, bone marrow transplant. And one thing, what is meant by bone marrow transplant related mortality? That is it occurs very immediate period or late period? Hello. Otherwise, we'll go to next speaker, Sam Reddy.
Dr. Madhav garu, are you is Samshivudu audible to you?
Hello.
Dr. Madhav, is Samshivudu audible to you?
Sir, message చేశారు మాధవ్ గారు. Please text
message enter చేయండి.
Yeah.
Next speaker Chandrasekhar kada, Akhilesh.
Sharat Chandra garu, sir.
Sharat Chandra. Next we will go to second speaker in the same session.
1 minute, Dr. Samshivudu. Just sorry for the interruption. We invite Dr. Lingareddy, who has come here to act as an observer from APMC. Okay. We invite Dr. Lingareddy garu.
Okay.
Dr. Madan garu, please let Dr. Lingareddy garu to come in into the picture. Madan. Madan వినపడుతుందా?
చెప్పండి.
డాక్టర్ లింగారెడ్డి గారిని you let Dr. Lingareddy garu to come to.
చేస్తున్నాం సార్, చేస్తున్నాం.
Is important.
అమర్నాథ్ అనే అతను హెమటో ఆంకాలజిస్ట్, అతను మాట్లాడు.
ఓకే, రైట్.
ఫస్ట్ అతను సాంశివ్
మాట్లాడతాం. ఓకే
సార్, సాంశివ్ సార్, డాక్టర్ అమర్నాథ్ గారు ఉన్నారు సార్. Can I add a few points on bone marrow?
Okay. I request Dr. Amarnath, who is also a hematologist, to comment and give few important points. Dr. Amarnath garu. Dr. Amarnath Garu, are you able to hear me? Are you in line?
అన్మ్యూట్ చేయాలేమన్నా.
నేను పడుతుందిగా, నాది వినపడుతుంది.
సార్ మీరు ఒకసారి లాగిన్ అవ్వాలి సార్, స్పీకర్స్ దాంట్లోకి రావాలి అందరు. మరి మీరు అందులో మీరు అందులో నుంచి వెళ్ళిపోయి స్పీకర్స్ దాంట్లోకి వెళ్ళాలి. ఓకే ఓకే సార్. ఓకే ఓకే అగైన్ లెట్ యు ఓకే సరే. Dr. Amarnath, please speak. Yes, there's something problem with your headphones, I think. Yeah. Yes, you're audible, but I can't. We can't hear you, Amarnath. We can't hear you. Take out the headphones and talk otherwise. Unplug it and talk.
Dr. Amarnath.
Hello.
Dr. Amarnath.
వినబడుతుందా?
Yeah.
Okay. Thank you for inviting me to IME Tenali. Okay. Coming to transplant, with now few transplanters in Guntur and Vijayawada, and with Arogyasri packages and schemes, I think in next decade everyone will be seeing transplant patient in one way or other, because as transplant patient require multiple department interdisciplinary care. Okay, even dermatologist, ENT people, and dentist, everyone will be seeing. So I think this is a hot topic at the beginning of the new decade. And transplant is not so complicated as what we think. Many people has like the phobia is there. So there is a transplant means like a lot of morbidity and mortality is there. But with the newer techniques and treatment, autologous transplant is like so simple compared to any type of chemotherapy, acute myeloid leukemia, acute lymphoblastic leukemia. Compared to the treatment, autologous transplant has become very easy with the newer support. Now we have support with granulocytes also. So the neutropenia and sepsis is very much decreased. So I think all the people can think of transplant, and all the patients who require transplant can really suggest for transplant nowadays. Previously it is not available in our state, Andhra Pradesh. Now with Manipal and even HCG is going to start the transplant unit, and Vizag, AOI, everyone is having transplant setup. So not much to fear about transplant. As Madhav said, transplant is a simple process, except in few cases where allogenic and haplotransplants, which are sometimes really difficult. But in patients who require transplant, it is like mandatory thing, because aplastic anemia, you would be seeing patient will be receiving hundreds of transfusions. Even then there won't be cure. With the transplant there will be 100% cure in the patients who are successful. This is just a message I want to give to all the physicians whoever is online.
Thank you, Dr. Amarnath.
Okay.
Thank you. And Dr. Madhav is also there online.
Yes, sir. Yes.
And one more thing, Dr. Madhav, and with the in the near future, many people will accept the bone marrow transplants also. In other organ, just like in other organ transplants, you have already told that HLA typing is matching is necessary based on the requirements. And you see, after other transplants, we give immunosuppressants, heavy dose of immunosuppressants for lifelong in other organ transplants.
Yes, sir.
In the case of the autologous transplant, just you have told what is the indication correctly. See, in majority of the aplastic anemias or any leukemias, every organ, bone marrow and this erythropoietic system, all system is involved. Where from you take this? How do you know that this bone marrow is not involved to take the stem cells from it? Or this will some of the nowadays they are preserving the cards of the in a younger, just like in birth. are you taking
Yes, sir.
that bank? And one thing. Second thing is how much, what are the immunosuppressants you are using and what doses you are using?
Okay, sir. So to address your first question about autologous transplants, about being sure that you're not giving the patient his disease back by, transfusing the same stem cells. There've been several studies where they've looked at this. They've also attempted to purge the stem cell product to make sure that there's no disease relapses because of that. But they found out that manipulating, the autologous product doesn't have a big impact on outcomes. So as long as the patient is in morphological remission for myelomas or lymphomas, it's absolutely all right to be taking the stem cell product from the patient. No. And with regards to immune suppression, there's no need for immune suppression like solid organ transplants and autologous transplants. In allogenic transplants, it depends on the indication for which you're doing it. And there are a lot of factors like the disease status as well. So if you have high-risk disease, say in acute leukemias, you would want to start tapering off the immune suppression as early as even 60 days post-transplant. That's you would have to consider whether the patient has graft versus host disease, and if he doesn't, then you would start tapering it off quite early. In the average, I would say again is around 3 months. So you would start tapering off the immune suppression for most patients. Again, in benign implications, you don't want the patient to be having any graft versus host disease. You're not looking for a graft versus leukemia effect, so you would continue the immune suppression for a little longer. But that's one big difference between solid organ transplants, I would say. And also with immune suppression, most of the transplant centers use either one of the calcineurin inhibitors. They use cyclosporin or tacrolimus, or we also go with mycophenolate mofetil in some cases. And that's the most commonly used immune suppressants, I would say. And also the issue about what was have I answered your question, sir?
Yes, audible.
Okay, are there any questions? Have I answered all your questions, or?
Akhilesh, do you want to ask? Akhilesh?
No.
Sir, no, we can carry on.
No. We are
Just
already behind schedule, so
just to add a point.
Okay.
Yeah, Dr. Amarnath, yes.
Yes.
Previously, we are just seeing bone marrow. Okay, in that we are counting 100 cells and we are seeing if there are no cancer cells or not. Now we are doing flow cytometry. In that we are taking 1 lakh cells. Okay, in that 1 lakh cells, if we are finding at least 1 cell, then we are thinking whether there is disease. If there is less than one cell out of 1 lakh cells, we think there is a disease, and then we'll give chemotherapy again and we'll reduce the disease burden, and then we are transplanting. With the advance of newer flow cytometry and the disease relapse very much significantly reduced. Okay. So the chance of giving back the disease is very less with newer techniques and MRD.
Can you add one point, Dr. Amna? Sorry to like, what is the related mortality? See, by doing procedure mortality or the disease, the original disease itself is causing mortality?
It depends on the disease which we are thinking, sir. If we are doing multiple myeloma transplant, the disease-related mortality is very less, and autologous related transplant is less than 1%.
Yes, naturally.
Okay.
Naturally.
Okay. If it is allogenous and if there is haplotransplant, so there will be a lot of neutropenia. At that time, there is the chances of infections are more, and with that, and the GVHD is also more. So there will be high risk of.
Otherwise, the mortality is mainly due to the sepsis.
Yeah, sepsis. Now with the advent of colistin, all these high and antibiotics and granulocyte infusion, the mortality has significantly come down.
Okay. Thank you, Dr. Amarnath, and also this Dr. Madhav. And
Thank you, sir, for the wonderful opportunity.
Okay. Can we go to second topic, Akhilesh?
Yeah, you can. But meanwhile, let us invite Dr. Lingareddy Garu.
Yes.
Dr. Lingareddy Garu, please come. Okay, you can go to the second topic.
Yes, sir. The next topic is management of the breast lump by Dr. P. Sarashchandra Garu, MS MCH, Manipal Hospital, sir.
Hello, Dr. Sarashchandra Garu.
Sir, unmute. Sikant sir, unmute.
Hello, sir. Am I audible?
Yes, sir. Yes, sir. Sarashchandra sir.
Yes,
I think Dr. Lingareddy sir wants to speak.
I will give 1 minute introductory speech, one talk.
Akhilesh.
Hello.
sir.
Dr. I think, I hope Dr. Chandra will talk both breast lump and also ovarian masses, whatever is written. Yeah, am I correct?
Yes, sir. But management of time, we shorted it to management of breast lumps. Sir.
Only breast
Akhilesh.
lump here.
Yes, sir.
Akhilesh.
Yes,
Akhilesh.
Yes, sir.
I think Dr. Lingareddy has left again. We'll after the session we'll call him back again.
Yes, sir. Yes, sir.
Right. Go ahead. Go ahead.
I think. Coming to the
Yes, sir.
yes. Hello.
Sir.
Yes, this is a very good topic, breast lump. Actually, now previously that we used to think the breast lumps are, especially so the carcinoma breast. Breast lumps are basically divided into benign and malignancy. Benign, it is not a big difficult, anybody will manage. Malignancy is very, very easy, very, very important. And we used to think it is more common in the European countries and advanced countries of the America and other things. But nowadays, we are getting more number of breast cancer patients in our region also. And not only in old age, whatever we used to think, we are getting 35, 40 years also, we are getting more number of breast cancers. And one thing, breast cancer is very good if we detect earlier, mainly at the T1, T2, or rather in T1, T2 stage. And the longevity is also very much. They survive more than 20, 25 years. Of course, 5-year survival rate is good if you done and 10-year survival. And also the people are able to survive for a long time. And if you there are many investigations, of course, within half an hour, I think Dr. Chandra will cover all these things, benign lumps and also malignant lumps. And with this little introduction, that is useful for many of our general practitioners and gynecologists and the surgeons also. Whenever they should send to a oncologist, whenever we should do surgery with this, and also when they should refer to the radio and chemo and radiotherapy, and what is the survival rates. Many people are very much afraid of breast cancer. With this little introduction, I invite Dr. Chandra to give details of management of the breast lump. Dr. Chandra,
before we start, Sarachandra garu.
Sir.
Amireddy garu, Lingareddy garu unnaru. Just invite him, sir. 2 minutes. Amireddy garu, please unmute and invite Dr. Lingareddy, sir.
Dr. Lingareddy garu, on behalf of Tenali IME, we invite you, sir, as an observer from APMC. Today and tomorrow we are going to conduct as 16 sessions.
Okay,
so you are welcome, sir. You are welcome. Please,
thank you, sir. Thank you very much.
Please give us a few valuable words.
Thank you, sir. Thank you, sir. Nice sessions are going on. Thank you, sir. Please continue.
Okay.
With this, I invite Dr. Chandra to start your topic.
Sir, am I audible, sir? And Dr. Sarachandra
here?
You are audible.
Yes, you are audible. Yes, you are audible.
Sir, as you said, sir, as you said, breast lumps are very common nowadays. And as you said earlier, it was thought that this is more of a disease of Western communities and of the urban areas. But of late, we see that the incidence in the urban areas as well as the rural areas is more similar. Like many people from rural areas are also coming with breast lumps which are malignant. And as you said, management of benign breast diseases is very easy and very simple. Whereas, and at the same time, it is very important to recognize breast cancer. It is important not to miss a breast cancer. What I mean to say is we should not operate on a breast lump thinking that it is benign and ultimately turning out to be malignant, and then the patient is being referred to the oncologist. So diagnosis is very, very important with respect to breast lumps. Now, in this, at the outset, I would like to thank the organizers for introducing me and giving this opportunity for me to clarify a few basic things about evaluation of breast lumps and management of benign and malignant breast lumps. So I will straight away start the topic without wasting time. As we discussed, looking at the epidemiology of the disease, earlier, few years back, this was thought to be more common in the urban areas. But nowadays we are seeing from all areas, urban as well as rural areas. The etiology of breast cancer. What causes breast cancer? One of the most important things, as we understand, which is the reason for breast cancer, is the advancing age of the patient. Other than that, I mean, various hormonal factors have been implicated in the causation of breast cancer, like early menarche, late age at menopause, and then being nulliparous, having no children, not having breastfed the children. So all these things in the textbook, they are mentioned as the causes of breast cancer. But surprisingly, when we see, most of the patients who come with breast cancer would have had many children. They would have breastfed their children. And this is a common observation. So as on today, all of us know that the understanding of this particular science is still incomplete, and we need to do further research into these aspects. Third thing, whenever the most important point in evaluating a patient with breast lump is not to miss a breast cancer. If we can do this, then we have met our requirement. So we should differentiate benign from malignant breast lumps. I will tell you how it happens in my subsequent slides. Before going for that, I would like to put in a word about breast cancer screening. It's been recommended that all women above 40 years of age undergo breast cancer screening. Screening is a word that is used as a test which is conducted in an asymptomatic patient. Patient does not have any symptom. Still, we are doing the test to find the lump at a subclinical stage. So there are varied recommendations with respect to screening, but in general, it is a good idea to get a mammogram done at least once in 2 years in those women who are above 40 years of age. The benefits of screening are obvious. The idea is to pick up the breast lump at a stage where it is not palpable, at a stage where it is a subclinical lump, thereby increasing the chances of curing the breast cancer. So coming to the actual topic, if some lady comes with a complaint of a breast lump, as we have all read in our general surgery lessons, classical triple assessment for breast lumps. The first part is the clinical examination, the proper history, the duration of the lump, whether it is painful or not. Breast cancers are more often painless to start with. And then we have to look at the family history, whether there is any significant family history of breast cancer. It is said that 5 to 10% of breast cancers run in families. Again, familial breast cancer, it could be syndromic or non-syndromic, but in general, it is our observation that most of the breast cancer patients are worried. The sisters of the breast cancer patient, mother of breast cancer patient, they are worried that if some lady in the family develops a breast cancer, then they are very much worried that the other ladies also have a high risk of breast cancer. It is not like that. What we should tell them at that point of time is only 95%, only 5% of the breast cancers have a tendency to run in families. Okay, when do we suspect a familial breast cancer? Suppose some index patient comes to us with breast cancer and she came with breast lump and on evaluation she is found to have a breast cancer. Now, when do we suspect whether this disease is running in her family or not? Generally speaking, it is said that when 2 or more first-degree relatives are having breast cancer, that too developing breast cancer at a young age, then that is the clinical scenario where we need to suspect whether this is running in the family or not. 2 or more first-degree relatives with breast cancer, more so if they develop the cancer at an early age, less than 50 years of age, then that is one clear indication for getting the genetic testing done. So this is with respect to the history. We have to also assess the reproductive history of the patient. And then coming to the physical examination, nothing replaces a proper physical examination. Many times it is our observation that some patient comes with a PET scan. It says that there is no evidence of metastasis. Suddenly we put our hand on the neck of the patient, examine the supraclavicular fossa. We find that there is a node, and on doing FNAC that comes positive. So however much science advances, nothing actually replaces the proper physical examination of the patient, which should be done completely in our OPD. So this is very important. We should examine the breast, the axilla, the supraclavicular fossa, opposite breast and axilla. We should palpate the abdomen. Okay, this is what we need to do. Next, this is the first part of the triple assessment for breast lumps. The second part is imaging. This imaging could be ultrasound of the breast. It could be X-ray mammogram of the breast or an MRI mammogram of the breast. So this is as far as the primary site of the disease is concerned. And then imaging also plays a role in staging of the disease. It could be a combination of chest X-ray or ultrasound abdomen, or it could be a combination of chest X-ray, ultrasound and a bone scan, or in certain clinical scenarios, PET CT scan. The third limb of triple assessment is the actual tissue diagnosis. Cancer is always diagnosed under the microscope. So this is very important. So the diagnosis of cancer is not confirmed until we get a pathology report. We should not reveal that patient has a breast cancer to her unless, we should not conclusively tell that unless we have a pathology report. This will have various implications as far as the patient is concerned. Giving a diagnosis of cancer without a proper pathology report could land us in trouble, because there are many mimics of cancer and there are many mimics of benign disease also. A cancer can mimic benign lump, and a benign lump can in some certain situations can mimic a cancer. So without a pathology report, we are not supposed to conclusively tell that patient has cancer. So this is a very important slide. The triple assessment for all breast lumps, which is all three limbs are compulsory part of evaluation of any breast lump. One is proper clinical evaluation, that is history and physical examination. Then the imaging. If it is less than 40 years of age, generally because of the density of the breast, it is suggested that we get ultrasound of the breast as a mammogram. And then for ladies who are beyond 40 years of age, it is a combination of X-ray mammogram and ultrasound mammogram. MR mammogram is done in very rare situations where there is a high chance of family history of breast cancer, and in known genetic syndromic cases, we do MR mammogram. Or post breast conservation therapy for breast cancer, we need to follow up the breast with annual or 2-yearly mammogram. In certain scenarios, in very selected circumstances, we use MRI for doing a mammogram. Next is the cytology or biopsy, which I will be elaborating subsequently. So I told you about the clinical examination. Now coming to the mammogram, the imaging. The imaging of the breast is called mammogram. It could be ultrasound mammogram, X-ray mammogram, or MR mammogram. Now this is once the mammogram is done, if there is any finding in the breast, it is assigned a particular category. So the categories are 0 to 6, depending upon the appearance of the breast lump on the mammogram. Here we can see that the general guideline is that any lump with a category 4 or above, the minimum that we need to do to tell that the patient does not have a cancer is to remove the lump completely. So anything 4 or above, the lump has to be removed. Even if the true cut biopsy is negative, the lump has to be removed. Even if the FNAC is negative, the lump has to be removed. Unless we remove the lump completely and have a conclusive evidence that there is no malignancy, we are not supposed to give a benign opinion for any lump which is category 4 or above on a mammogram. So what about lumps falling in categories 1 to 3? Here we see that the incidence of these lumps, the possibility of these lumps being a cancer is very low. So as per the recommendations, they can be followed up every 6 months. Many times, educated patients, they come and ask if it is a category 2 lump or a category 3 lump, they ask us whether it is a cancer or not a cancer. So we do the mammogram, it says BIRATS 2 category, and then we do a true cut biopsy, it says it's a benign lump, and clinically also it's a benign lump. So the patient wants 100% assurance. So it is our responsibility to be aware of the incidence of cancer in a category 2 lump, incidence of cancer in a category 3 lump. We are supposed to quote this percentage to the patient. We need to say that for a category 2 lump, there is a 99.9% chance that is benign. Chance of cancer is only 0.1%. But one thing we need to observe is the incidence of cancer in a category 2 lump or a category 3 lump is still not 0%. I will tell you why I am explaining this in this particular manner. I have come across one patient who is in her 30s, who is a well-educated patient. She has come, this patient I have come across when I was working as a senior resident in AIMS Delhi. She has come to the OPD. She was complaining of a lump in her breast. The oncologist has examined her and the oncologist could not make out any breast lump. So they advised a mammogram and the patient got a mammogram done. And then it has shown a small lump which is BIRADS category 3. So as per the guidelines of management of category 3 lump, the doctor has advised the patient to come back after 3 months or 6 months for a regular visit. So promptly the patient sincerely obeyed the doctor and she has come back after 3 or 4 months. And unfortunately, when she came back, it was found that it was stage 4 breast cancer. It is a breast cancer with bone metastasis. Now the doctor says nothing can be done much about the disease. She is in her 30s. So this is a very difficult scenario. So it is always better to tell that the chance of malignancy is very less and it is our responsibility to quote the exact percentage. And still, if the patient is worried about the lump, one of the indications for surgery for what appears to be benign breast lump is the patient being worried about the lump. We should never reassure totally and then send them back and later on landing in trouble. So this is what the point I wanted to make it clear. Excuse me. Like in any other cancer, looking at breast cancer, there are 3 important words: diagnosis, the staging, and the treatment. This is how most of the solid organ cancers are evaluated and managed. First, it is important to get a diagnosis. Then we do staging workup completely. And then depending upon the staging, we go for the treatment. This is what happens in most of the solid organ cancers. So coming to the diagnosis of breast cancer, it is always a tissue diagnosis. It is not an imaging diagnosis. It is not a clinically, it will suggest that most probably a breast cancer. Mammogram wise, yes, it suggests that most probably a breast cancer. But 100% diagnosis comes only under the microscope, that is by the pathology report. We can do a fine needle aspiration cytology, a true cut biopsy. True cut biopsy, we get a bigger core of tissue. The pathologist, the job is made simpler for a pathologist to give a diagnosis of breast cancer if we do a true cut biopsy rather than a fine needle aspiration cytology. Sometimes there could be fallacies with fine needle aspiration cytology, which are very less common with true cut biopsy. Sometimes we can, if the lump is easily accessible, we can do in the OPD directly without ultrasound guidance or imaging guidance. In certain scenarios, it is always better to do image guided biopsy, that is ultrasound guided biopsy or FNAC. Suppose there is a breast cyst, there is a cyst in the breast and there is a solid component again within the cyst. So to know that we are exactly getting the tissue from the solid component, it is always better to do under ultrasound guidance rather than putting a needle or the biopsy gun directly into the lump. We may just get some fluid which may be inconclusive. And then after doing a proper triple assessment and an attempt at a proper biopsy, still if we are not getting any proper conclusion or we still have a suspicion, then we have to go for excision biopsy. Excision biopsy means removing the lump completely. So that can either be sent for frozen section, which means the report will come back in 20 to 30 minutes, or it can be sent for a final histopathology. So this is how breast cancer diagnosis is made. So this is just the true cut biopsy guns. The left-sided one is a manual gun. Right-sided one is an automated gun. The only difference is the cost. Otherwise, both are equally effective. So comparing the various methods to diagnose breast cancer, the FNAC, true cut biopsy, and the excision biopsy. Of course, all of us know that excision biopsy gives a 100% accurate result, but that does not justify doing an excision biopsy every time we get a patient with breast lump without doing FNAC or true cut biopsy. True cut biopsy is the initial method of choice to arrive at a diagnosis because it gives a bigger core of tissue. It makes the job simpler for a pathologist. The pathologist can feel more confident about the diagnosis. So FNAC, certain scenarios we use it, but more often nowadays we are doing true cut biopsy. So I already told about this. The true cut biopsy is better than the FNAC. And another very important point is, suppose somebody comes to us, suppose I am an oncologist, somebody comes to me with a true cut biopsy or a FNAC report suggestive of breast cancer, and then I do a staging evaluation, and if there are no distant metastases, if it is operable disease, if I do a mastectomy, suddenly after doing mastectomy, if the report comes back telling that it is just a benign disease, then it is an embarrassing situation for the surgeon. Most often we find it difficult to explain. So that is why we need to get a slide review done. Whenever somebody comes with a FNAC report or a true cut biopsy report, it is very important to get a slide review done. Whoever pathologist you rely on, whoever pathologist is working in your institution, whom you rely on, you show the slides to her or him and then get her opinion. If there is a doubt, it is always better to repeat the true cut biopsy. This is very important because this is a very embarrassing situation. After doing a mutilating surgery, if the pathology report comes back saying that benign, the entire discussion about breast cancer management is benign versus malignant. There is no third point in breast cancer presentation. We should not miss a cancer, or we should not overdiagnose cancer. This is very important. So always better to get a slide review report done. Some people have the practice of doing FNAC of the axillary node. When the primary site of the disease is proven, this does not have much role nowadays. And then if patient has a palpable axillary node or multiple nodes, we generally take them as metastasis. So in a patient with proven primary in the breast and palpable nodes in the axilla, it is generally taken that they are metastatic nodes for clinical management purposes. So we generally don't get an FNAC of the node. We get an FNAC of the node when there is a node in the supraclavicular fossa. There are no metastases elsewhere, anywhere else. If the node in the neck comes positive, then the disease is upstage, then we get an FNAC of the supraclavicular fossa node, not the axillary node. So when to do a surgical biopsy? After doing a true cut biopsy, I told true cut biopsy is the first line of biopsy. Which is the condition situation where we go for a excision biopsy? I told you the triple assessment is the main way of assessing breast lumps. Suppose clinical examination is suggestive of a benign breast lump, and mammogram is suggestive of a benign breast lump, and then biopsy comes back saying that this is a breast cancer. If all three parts of the triple assessment are in agreement with one another, then we proceed as per the impression obtained. If all three parts of the triple assessment are not in agreement with one another, then this is the situation where we need to go and do an excision biopsy, because here we cannot play around with diagnosis. It's always better to have a proper diagnosis. So when three aspects of triple assessment, one is contradicting another, mammogram wise benign looking lump, biopsy wise positive, clinically suspicious. So it's always better to excise the lump completely before we commit the diagnosis to the patient. So this is a picture, just I wanted to show. This is IV cannula placed in the patient came with nipple discharge. We placed the IV cannula in the duct, which is the putative duct having the nipple discharge. We did a wide excision of that particular system after localizing in ultrasound. This ultimately, such things can come out to be ductal carcinoma in situ. So this is what is called a microdocectomy. Now, all the while we have been discussing about palpable lumps in the breast, clinical assessment, clinical examination, physical findings. Now, what about non-palpable lumps in the breast? Now, first of all, what is the scenario where we come across a patient with non-palpable lump in the breast? Somebody comes for a general health checkup. Somebody comes for a routine mammographic examination, which is recommended beyond 40 years, at least once in 1 to 2 years. They come with some suspicious lesion, which is not felt clinically. Then how is it that we diagnose such lumps before offering any treatment? One thing is we can do an image-guided FNAC or a true cut biopsy. Usually these lesions, if we do it in ultrasound guidance, we call it ultrasound-guided biopsy. or sometimes the lump may be seen on an X-ray mammogram with microcalcifications, but it may not be visible on the ultrasound. So if it is not visible on the ultrasound, we cannot do ultrasound guided throughput biopsy. We have to do a stereotactic guided biopsy of a lump which is visible only on a X-ray mammogram and not on an ultrasound mammogram. Another way of diagnosing these subclinical lumps is by doing a wire localization of the lump. On the morning of surgery, the radiologist places a wire which expands out like a fan. The wire goes into the lesion and then expands out, expands out like a fan, and then it is held in position, and under guidance, we excise that lump and send it for intraoperative frozen section or for a permanent histopathology. So this is how we process, we obtain the lumps which are not felt clinically. It is basically by image guidance and image helping. So this is a stereotactic guided throughput biopsy. So coming to this is the diagnosis part. Now coming to the staging part for breast cancer. I hope I'm not taking more time. Sir, please let me know if I'm taking more time.
I think within 5 minutes, can you complete, I think?
Sure, sure, sir. I will just quickly go through the surgical aspects of the breast cancer. The breast cancer staging is clinical staging and the pathological staging. Clinical staging is what happens before the treatment is started. And then if we operate the patient and then we get the histopathology report after 4 days, that is called the pathological staging. AJCC has given both the clinical staging as well as the pathological staging. Basically, that is based on the tumor size, involvement of the skin, fixity to the chest wall, number of axillary nodes involved, the location of the nodes, whether intermental mammary, axillary, supraclavicular fossa, and then whether distant metastases are present or not. Now, what investigations to do to stage the disease? If it's a clinical early stage disease, generally it is said a chest X-ray and ultrasound abdomen are sufficient investigations for staging this particular cancer, because the chance of having distant metastasis is very less than 1% or so. For locally advanced breast cancer means it is either involving the skin of the breast in the form of pudgy orange or direct skin involvement or ulceration or a fungation, or it is not mobile over the rib cage. We call locally advanced breast cancer. Similarly, multiple ipsilateral axillary nodes, matted axillary nodes, fixed axillary nodes, without distant metastasis, we consider it locally advanced breast cancer. And then, of course, we know the metastatic breast cancer. So there are bone metastasis or liver metastasis or metastasis elsewhere. It is a metastatic disease. So for early stage disease, very few investigations are needed for staging. PET-CT is not mandatory, but it's optional. It is mentioned as an optional investigation. Locally advanced stage disease, either a combination of X-ray, X-ray chest, ultrasound abdomen, and bone scan, or a PET-CT if we want to do a single test. This is an X-ray showing lymphangitis carcinomatosis, a lung metastasis, ultrasound, and a bone scan, and the PET-CT. So either a combination of the above 3 investigations, or if you want to do a single test, PET-CT is optional. Whenever we order investigations, it is very important to see whether it is applicable, whether it is available, and also whether it is affordable or not. Just because some test has come, we should not opt for it. So if we find a single focus of disease at a distant focus, suppose breast cancer patient has come, there is no evidence of distant metastasis anywhere in the body, patient has got a PET scan done, there is a suspicious single focus of uptake in a, suppose say a lumbar vertebra. Now, whether to brand this patient as a metastatic disease or to label the patient as a non-metastatic disease, this question has to be answered only after doing a second form of imaging. For example, we get an MRI of the spine. We don't just brand the patient based on a single site of distant disease. We don't know whether that focus is a cancer or a non-cancerous focus. So it's always better to do a second form of imaging. If possible, definitely a tissue diagnosis at the distant focus has to be done. If that is not possible, a second form of imaging, either an MRI or another investigation has to be done. And then after correlating only, we are supposed to commit on the staging of the disease. Breast cancer is treated with a multimodality treatment. Now I will just, because I have taken time for evaluation of the breast lumps, I will just quickly brush through the treatment. Treatment purpose wise, early stage disease, locally advanced disease, and metastatic disease. These are the categories. For ductal, it could sometimes we could come across a patient with ductal carcinoma in situ. This is as opposed to infiltrating ductal carcinoma, which has breached the basement membrane. If it's not breached the basement membrane, we call it ductal carcinoma in situ. So the treatment depends on all these factors, whether it's an in situ cancer or an invasive cancer. If it is an invasive cancer, then whether it's amenable for breast conservation or not. If it is amenable for breast conservation, always we should give choice to the patient. When two treatments in cancer, when two surgeries in cancer offer equal cure rates, then it is our responsibility to give the choice to the patient. If one surgery is better than the other surgery, then the choice should not be given. The better method becomes the treatment of choice. If two treatment modalities are equally effective, always the choice has to be given to the patient. So I will just show you a few pictures of the modified radical mastectomy, commonest surgery done for breast cancer. So this is the incision, modified Stewart's incision. This is the upper flap that is raised, the lower flap, the medial flap, the lateral flap. What is shown is the lateral border of the latissimus dorsi muscle. And then we lift the breast from the pectoralis major muscle along with the pectoralis fascia. And then once that is done, we clear the tissue. What is being lifted with the Babcock forceps is the pectoralis major muscle. Beneath in the floor is the pectoralis minor. There is interpectoral tissue and fascia, the clavipectoral fascia in between. So that clavipectoral fascia is being reflected. What we are seeing in the bed is the pectoralis minor muscle. And then we enter the axilla. By incising the clavipectoral fascia, we can clearly see the axillary vein. So these are the standard axillary structures. This is the pectoralis minor tendon. In complete axillary dissection, the tissue lateral to, in front and behind, and medial to the pectoralis minor tendon till the Halstead's ligament, the corococlavicular ligament, is cleared completely in the axilla. What we preserve is the axillary vein, vessels in brachial plexus, and then the thoracodorsal pedicle and the long thoracic nerve. You can see the long thoracic nerve on the serratus anterior, the medial wall of the axilla. So that is the apex of axilla, the corococlavicular or Halstead's ligament. So this is the long thoracic nerve being pointed out. This is the specimen. So it's the closure with the drains in situ. So breast conservation surgery, we do a wide excision at the primary site and the axillary dissection. This is how it looks commonly after we do breast conservation. Now this one slide is very important because this lady came with the lump removed outside. They have just done an excision of the lump, and after removing only the lump, is not an ideal case for breast conservation surgery. So a patient who would have been otherwise a good candidate for breast conservation surgery may lose the chance of breast conservation because somebody did only an excision of the lump and not a wide excision of the lump. So somebody, as I said, doing an excision biopsy to get a diagnosis, it's always better to do a wide excision, label the margin with sutures, and then the pathologist has to comment on all the margins, the 4 radial margins as well as the deep margin. So such patients stand a chance of going for breast conservation subsequently. If we do only excision of the lump, leaving the lump partly or not giving adequate margins all around, then the lady would have had a chance for breast conservation, otherwise will lose the chance of going for breast conservation. There will be no option but to go for a mastectomy, that is complete breast removal. So sentinel lymph node biopsy has come up to avoid unnecessary axillary dissection in those who actually don't have pathologic disease in the axilla. If we can take out the first station node in the axilla intraoperatively and send it for frozen section intraoperatively, if it is positive, complete the axillary node dissection. If it is negative, withhold the axillary dissection. So this is one way of avoiding the morbidity of axillary lymph node dissection, long-term lymphedema of the limb. So this is one of the methods that has come up and now a standard practice. So this is based on the lymphatic drainage of the breast. I will not go into the details of the sentinel lymph node biopsy. So these are procedures done with wire localization. And then intraoperative frozen section is very, very important. Without this, we cannot do breast conservation surgery, because sometimes this is needed for diagnosis and also for surgical margins. If we are conserving the breast, we need to get a negative surgical margin report on frozen section intraoperatively. If we are doing sentinel lymph node biopsy, we need to have frozen section to assess whether the node, first station node, is positive or not, to know whether to proceed with complete axillary clearance or not. Breast reconstruction can be done at the time of the initial surgery itself, or after completion of all treatments. After 2 years also, patient can go for delayed breast reconstruction. Oncoplastic breast surgery means application of plastic surgery principles. At the same time, we do the breast cancer surgery, like any other surgery, breast surgery also has certain set of complications. Usually we don't come across major complications. Most of the complications can be handled without much difficulty. So when to do genetic testing, there are clear-cut indications for doing genetic testing. So this information is always available on the web. So, or we can consult the concerned oncologist. So a lot of technological advances are coming up. So this is the very important slide. I would like to conclude my presentation with this. If somebody says that all breast lumps are malignant, then definitely the statement is a wrong diagnosis. It is a wrong statement. But we can also say that it's the right way of management. So never excise a lump without giving a margin. So we can have pathological surprises. The preoperative diagnosis can change after we excise the lump. So what we think as benign may come as malignant after doing the surgery. So somebody has said that all breast lumps are malignant is a statement which is a wrong statement, but a right way of management. This lump, when I saw this patient, I thought 100% is a breast cancer, but the report came benign. It is a solitary fibrous tumor of the breast. So just to emphasize the point that we can have pathological surprises once the surgery is done. In cancer, oncological clearance, complete doing a proper surgery stands the first place. Second is the function preservation of the organ concerned, whether it's a breast or whether it's a tongue or a hand or a lower limb. We try to preserve the function. And then the third thing is the appearance. So the first priority has to be given for oncological clearance, which is directly related to the lifespan of the patient. And for the sake of preserving the function or for the sake of making it look good or beautiful, we should not compromise on the oncological clearance.
I think we are crossing time too much. Other people.
Thank you very much, sir.
Thank you, Dr. Sarasandra, for covering the entire breast cancer in a short span. And of course, this breast surgery has become very prominent, and people have come, breast surgeons. They have started Breast Surgeon Society of India, like that. And of course, previously, breast conservation means many people are used to be afraid of. Nowadays, that concept has come up, and people are accepting breast conservation and reconstruction of the breast. And one thing is clear: many people have come forward with the just millimeter clearance is good enough in the breast surgery. Of course, as you are rightly as with this thing. Thank you, Dr. Sarasandra. I will hand over this session to Dr. Akhilesh for next third topic. Dr. Akhilesh?
Yes, sir. Yes, sir.
Okay,
Thank you, sir. Thank you very much, sir.
Thank you.
Thank you, Samjudu.
Thanks, Samriti. Right. Okay.
Thank you, sir.
Okay, thank you. Okay, next. I think
yes, sir.
I will.
Next. Yes, sir.
I will leave the video and you will go to Stepan. Okay.
Yes, sir. Next session, chairpersons, I invite Dr. K. Surya Teja Garu and Dr. N. Nandakishore Garu. Madan?
Hello.
Hello, Madan?
Sir. Yes, tell me, sir.
Surya Teja Garu, Kishore Garu. Dr. K. Surya Teja Garu, Dr. N. Nandakishore Garu, chairperson for this session.
సూర్యతేజ సార్ అయితే కనెక్ట్ అయ్యారు. నందకిషోర్ సార్ రెస్పాండ్ అవ్వడం లేదు సార్.
సూర్యతేజ గారిని మొదలు పెట్టమనండి.
You go ahead with Dr. Surya Teja. Dr. Surya Teja can continue.
Yes. Surya Teja sir, welcome to the conference, sir.
Unmute, Chairman.
Yeah, hello.
Sir. Sir, good evening, sir.
Yeah, good evening.
Welcome, Suriteja.
Yeah, hi, uncle. How are you?
Fine, fine. Continue.
Sir, we will start with the first session, sir. Management of intracranial aneurysms by Dr. G. Sudhir Kumar Garu, Manipal Hospital, sir.
Yep.
Sudhir, sir, start. Sir.
Hi, Dr. Sudhir. How are you?
Hello, hello, sir. Fine.
This is Dr. Surya. We have my
Hello, sir.
clear.
Yeah. Am I audible? Is the voice clear, sir?
Yes, sir.
Yes, sir. Yes, sir. You're audible.
Shall I proceed then? Yes.
Yes, sir.
Is it clear, sir?
Yes, sir.
Yeah, it's clear.
At the outset, good afternoon, everyone. I would like to thank the IME Tenali for giving me this opportunity, and also everyone who's made this program a successful program. Good afternoon once again. I would present a topic which not many people are familiar with, the surgical management of intracranial aneurysms. I'd be presenting only the surgical aspect, not the endovascular aspect. So coming to the aneurysms as such, by definition, they are basically abnormal outpouchings of vessel wall, usually found at the arterial bifurcations. Wherever you see an arterial bifurcation, usually those are the areas which are prone to develop aneurysms. Aneurysms, again, are of various kinds: saccular, fusiform, mycotic, dissecting. Most commonest ones being the saccular aneurysms, which we encounter in our daily practice. Almost 90% of the aneurysms are saccular aneurysms. They usually consist of a neck, body, and a fundus. And if you take distribution-wise, almost 85 to 90% of the aneurysms are found in the anterior circulation, and only 10 to 15% are found in the posterior circulation. That means anterior circulation is usually constituted by branches of internal carotid artery, and to some extent by branches of the basilar artery also. They form the circle of Willis basically. The circle of Willis almost constitutes 85 to 90.
Yes, sir.
Okay. So coming to the incidents, it's found in.
So there is with this topic, I will not be speaking in the middle.
Okay. Can I proceed? Yeah.
So this, sir, we need to introduce you first, right?
Okay.
Yeah, that will take 2 or 3 minutes, sir.
Okay. Okay. Should I continue, or will you be doing it now?
Yeah, I will be doing it if the others are.
Okay. Then I'll stop sharing the screen. Is that what you want?
No, you can, Sudhir.
You can share the screen, sir. I'll just introduce you, and you can go on.
Okay. Okay. Please.
Yeah. Dr. Sudhir works as the consultant neurosurgeon in Manipal hospitals. He has done his MBBS from JIPMA Pondicherry, his MS from Goa Medical College, and MCH from JIPMA Pondicherry. He is well versed in neurotrauma, minimal invasive spine surgery, endoscopic neurosurgery, neuro-oncology and skull-based surgery, vascular neurosurgery, pediatric neurosurgery, and epilepsy surgery. He has published in various journals on various topics in neurosurgery, endoscopic skull base, and minimally invasive spine surgery. He has worked as a consultant neurosurgeon at MMHRC Madurai and SIMS Hospital Chennai for 2 years. Am I audible?
Yes.
Yes, sir.
Yeah. Now he's working as a consultant neurosurgeon in Manipal Hospital since the past 5 years, and we welcome him to give his to give the lecture on his topic, surgical management of intracranial aneurysms. Sudhir sir, it's on you.
Yeah. Okay.
Thank
Thank you, sir. Thank you. So coming to the incidents, almost 2% of the general population, if screened, will have some sort of aneurysms in their brain, out of which only 1%, 50% of the population present with rupture. And of the people who present, almost there's a mortality of 50% if timely intervention is not given. Plus, I'll let you know further. There's a familial predisposition. Almost 7 to 20% of the patients are likely to have first or second degree relatives who would have undergone treatment for aneurysms, or who are likely to harbor aneurysms if they are screened. So usual age that we see these aneurysm patients are between 40 and 60, but now we have seen younger patients and older patients also beyond this age. Coming to the sex predominance, it is usually the females who have who are likely to present. It's almost 2.5 to 1 if you compare females to males, and almost 15 to 20% of the patients are likely to harbor another aneurysm when a particular aneurysm is detected. The ruptured aneurysm, probably the patient comes and presents with ruptured aneurysms, and
Hello.
Hello, am I audible?
Yeah.
Yeah, almost 15 to 20% of the patients are likely to have multiple aneurysms. And there are some diseases like genetic diseases which have increased risk of developing aneurysms. That is like autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, alpha-1 antitrypsin deficiency, neurofibromatosis, etc. And there are few risk factors: hypertension, smoking, old age, hypercholesterolemia. Coming to the pathology, they are basically acquired lesions. They are never congenital. So as basic pathology involves repetitive damage to the internal elastic lamina by hemodynamic variations at arterial bifurcation. And why only in the CNS? Why don't we see these aneurysms elsewhere? Is because the arteries in the brain, they usually lack external elastic lamina. Coming to the hemodynamics, the size, usually they rupture when they reach a size of greater than 4 millimeters, below which they are usually incidentally detected. They are called blood blistering aneurysms. The common sizes that we encounter usually are 3 to 7, because based on the size of the aneurysm, we need to plan for the size of the clip or the amount of coils that we need to insert. And usual site of rupture is distal apex. Almost 85% it's a dome that ruptures. Very few incidences where you see the neck rupturing in an aneurysm. And giant aneurysms are aneurysms which are larger than 2.5 centimeters. They usually manifest with either thromboembolic complications like thrombosis of the parent vessel, or pressure symptoms like on the optic chiasm or on the floor of the third ventricle, resulting in hydrocephalus. And previously, it was thought that giant aneurysms are less likely to rupture, but recent studies have shown that they are likely to rupture more frequently than the smaller ones. It's almost 6% when compared to the 1 to 3% rate quoted for smaller aneurysms. So coming to the symptoms, generally they present with severe sudden onset headache. It's called thunderclap headache. Patient would have never experienced such kind of headache in his life. So that is usually the typical history. And depending on the extent of bleed that has happened, patient might present with loss of consciousness. There is usually associated vomiting along with headache. And depending on the extent of bleed, patient might present with seizures, focal neurological deficits if there is an intracerebral hematoma. Coming to the investigations, there are non-specific and specific investigations. Non-specific, generally, what happens is if a patient presents to any doctor with headache, they undergo a plain CT scan or a brain scan. Lumbar puncture is almost mentioned for academic purposes. So once the CT shows subarachnoid hemorrhage, we assume that it most likely is from an aneurysmal rupture, unless until it's ruled otherwise, because there are other causes of subarachnoid hemorrhage like vasculitis and all. But before that, we confirm that there are no aneurysms seen. So for that, we need to do specific investigations. The gold standard investigations are CT angio, which is non-invasive, rapid, cost-effective, and it is widely available. Plus, it is surgeon-friendly because we can plan surgery based on the pictures that we get on CT angio. Because vasculature in relation to the bone, most of the time they arise from the circle of Willis, so they are at the skull base. So we need to see the position of aneurysm with relation to the surrounding bone. Usually that's what we see in the skull base. And the other specific investigation, which is most often, which was most often used before, but now it's being less often used, that is digital subtraction angiography of 4 vessels. And there are some ancillary investigations which we use mainly to see whether we'll get additional information for managing the patients further. Like in case of giant aneurysm, sometimes CIS-3D MRI helps. MR angio sometimes helps in thrombosed aneurysms, wherein we need to delineate the surrounding structures clearly. So once a patient has undergone a scanning and diagnosis of subarachnoid hemorrhage secondary to aneurysmal rupture is made, we usually place them into various scales to prognosticate. Basically, how is the patient going to be with the treatment, or if we don't treat, how is it going to be? So that's what we need to know. So once the diagnosis is made, we put them into various scales. So the WFNS scale is most commonly used scale. This is based on Glasgow Coma scale and presence or absence of motor deficits. It's a simple scale which can be followed anywhere. So depending on which grade the patient is, the prognosis immediately can be told. Like grade 5 is usually associated with graver prognosis and patients are unlikely to recover. So the other scales are Fisher scale, which is based on CT scan appearance of subarachnoid hemorrhage. And the modified Fisher scale, which is most commonly used now, has come into vogue only for the past few years. This is also CT-based scan, CT-based scale based on the presence or absence of intraventricular hemorrhage and also the thickness of subarachnoid hemorrhage. Based on that, we allot the risk. So starting from 0 to 4, the risk keeps on increasing. Here's a picture of one of my patients who are presented with dense subarachnoid hemorrhage in all the cisterns, sylvian cistern and the basal cisterns everywhere with evolving hydrocephalus. So according to modified Fisher scale, he would actually go into grade 3 because there's no intraventricular hemorrhage seen. So this is how we place the patients in the different scales to prognosticate, basically. Coming to the management, it involves mainly the first aspect that is more important is the obliteration of aneurysm. Whether you do clipping or coiling or stenting, first we need to obliterate the aneurysm. That is because we need to prevent the rebleed, because rebleed rates are very high. If patient is not has not undergone any obliteration of aneurysm, almost, if you can see that 50% of the patients bleed within the next 6 months. That is, out of the 100 people, 50 people are likely to bleed if untreated. So why rebleed? Because rebleeds are associated with very high mortalities. Usually, you can say that almost 100% patients don't come out if patient has a rebleed. So within the first 24 hours, you see that 4% of the patients who present to you bleed. And within 2 weeks, it increases significantly to 20%. And within 6 months, it becomes 50%. Thereafter, it's an annual risk that is 3% per year. And the other aspect is, once the patient has bled, the management of hemorrhage and its complications like hydrocephalus, intracerebral hematoma, that's a second aspect which we need to manage in a patient with aneurysmal bleed. So coming to the first aspect, the obliteration of aneurysm, there are two options. One is the surgical clipping, which has been there for almost 80 years now, because the clipping process was started in late 30s by Dandy. It was in 1938, and the endovascular coiling, which was started in 70s, but picked up pace, significant amount of pace in late 90s. So now, initially when endovascular coiling was introduced, they thought that both are likely to be complementary. Like surgical clipping, patient if he is not eligible for surgical clipping, he can go for endovascular coiling. That was the initial premise with which the endovascular coiling came into vogue. But slowly, as the experience increased, people have realized that, the surgeons have realized that the aneurysms which can be coiled can also be clipped, and vice versa. Like aneurysms which can be clipped can also be coiled. So eventually, in the current scenario, both have become mutually exclusive options rather than complementary options. They become complementary only in very few scenarios, like in middle cerebral artery aneurysms or giant aneurysms, wherein coiling could not take care of the complete aneurysm. Then they might have to go for clipping, or if after clipping, if there's a residual neck, and they have to go for coiling. So in very few scenarios, they have become complementary options. In the current scenario, they have more likely to be totally mutually exclusive. That is, patient can be either placed into a group which undergoes clipping, or he can go for coiling. So based on that, there are a lot of studies which have come into work. Out of them, the one which significantly changed the practice methodology in aneurysmal bleed was ISAT trial, International Subarachnoid Aneurysm Trial, which was purely based in Europe. So the ISAT trial, after the study has finished, it gave a major boost to the endovascular surgeons, because it showed that the outcome in terms of survival free of disability at 1 year was significantly better with coiling rather than clipping. But then there was a lot of criticism that was raised regarding this trial, because of the patients who were screened for the study, only 22% of the patients were enrolled into the study. Almost 78% of the patients were excluded. So the criteria for exclusion was not. They mentioned that only 10% of the patients, 10% of the patients were excluded because the patients had not given consent for inclusion in the trial. Then rest of the 68% of the patients were excluded. The results were clearly mentioned. And also, it was early findings that published. So they said, what was the long-term outcomes? And when compared with the clipping group, the coiling group patients had more chances of rebleed. That was almost 2.6 times higher than the surgical limb, which was not really highlighted. So what they have done is they have gone and they have published a long-term follow-up. So in the long-term follow-up, whatever benefit, the initial benefit that coiling of aneurysms had given seem to have disappeared. And they have found that there is an increased risk of recurrent bleeding with coiling when compared to clipping. Follow-up, they said that, okay, clipping is better. Then came another study, Barrow ruptured aneurysm trial, which initial findings showed that a substantial number crossed over to the clipping side. So they could not give a really conclusive results. But what they showed was clipping showed fewer poorer outcomes than coiling. So this was like a slight setback for coiling. Then again, they went on, went and said that, okay, the initial findings were those, and here results again showed that hello, am I audible?
Yes, sir, you're audible.
So the BRAD trial, the 3-year results showed that this recurrence rates were significantly lower in the clipped arm, and also the degree of aneurysm obliteration was better with clipping. And again, they have published the 6-year results in 2015, wherein they have shown that both the modalities have almost similar effect. With the coiling group, initially, though they showed that they were faring better, but in the long run, rebleed rates and also the retreatment rates were higher in the coiling group. So what they said was, it's the end of 6 years, coiling and clipping both are mutually exclusive alternative procedures if a patient presents with aneurysmal bleed, and we need to investigate further. So there are ongoing trials multiple trials are ongoing. So we need to await those results also. But as of now, coiling and clipping both are shown to be equally effective in treatment of aneurysmal rupture. So this is the final conclusion. They found that there was a slight attenuation of benefit gain achieved by endovascular treatment in the long-term process. Though at the end of 1 year, they seem to be faring better endovascular group. Now, in the long term, they have shown that both coiling and clipping are equally effective. So coming to the surgical aspect, I'll just run you through the basic steps that we take during the aneurysm surgery. Lumbar CSF drainage is an optional process. We do it on a case-to-case basis. We see whether the ICP is elevated or not, the extent of hydrocephalus and all that. Usually the craniotomy that we do is a terional or a frontotemporal craniotomy. And it is followed by opening of the dura, then sylvian opening, either the medial or the lateral aspect. And there is wide arachnoid opening. Wide arachnoid opening is very significant because we need to clear as much subarachnoid hemorrhage as possible to prevent the possibilities of vasospasm later on in the period of treatment. And then we identify the vessels, dissect, identify the aneurysm, apply a temporary clip on the parent vessel that is supplying the aneurysm. And then we do a meticulous dissection on the neck and preserve the surrounding perforating vessels. Then we select an appropriate clip and clip it. After the clipping, we make sure that the fundus is dissected away from all the structures and it is decompressed and there are no blood clots left. So coming to few case scenarios, which I've done in the past few years, I would like to run you through the three most commonest. The first being the left ICA bifurcation aneurysm. These are the CT images. You can see that in the first image, there's a big aneurysm here, directed superiorly. This is a 3D reconstructed image, which is clearly showing that the bifurcation has an aneurysm. So these are the close-up views of the left middle cerebral artery aneurysm. This is a short video. So the first step that we usually do is try to drain as much CSF as possible so that brain becomes lax and there is no retraction induced trauma on the brain. So here I'm draining the CSF from around the optic nerve. You can see that the optic nerve is clearly seen now. And the lobe that is being retracted is the frontal lobe. This is the temporal lobe. This is the frontal lobe here. Sorry, it's the other way around. It's the frontal lobe on this side, and this is the temporal lobe. You can see that this is the optic nerve, and this is the ICA that I'm dissecting. Okay, slowly once the ICA is dissected, I'm trying to look for the ICA bifurcation here. So the aneurysm is at a bifurcation. So I'm slowly dissecting around the ICA. I'm doing arachnoid. Basically here I'm cutting the arachnoid so that as much CSF can be drained, blood-stained CSF it is. So slowly I'm isolating the ICA. This is important because we need to isolate the parent vessel completely so that we can apply a temporary clip when we are dissecting around the aneurysm. This is the anterior cerebral artery that is coming to the view now. I'm retracting the frontal lobe to see the anterior cerebral artery, and this is a middle cerebral artery, beginning of middle cerebral artery, and this is a bifurcation. You can see the neck of the aneurysm now. So the next process would be for me to dissect around the ICA to gain enough space to apply a temporary clip. So here I'm applying the temporary clip on the internal carotid artery. This will basically limit the blood circulation to the aneurysm. Thereby, in case if we encounter a rupture, it will be easier for us to manage. So here, once I've dissected the neck, I'm applying a permanent clip. So while applying the permanent clip, you need to see that there are no structures behind. So we dissect completely around, then apply a permanent clip. And once the clip is applied, here I'm dissecting the dome of the aneurysm. You can see I dissected the dome of the aneurysm from the surrounding parenchyma neural structures. And then what we do is we decompress the aneurysm. Here you can see that I'm rupturing the aneurysm. remove the clots. And final step would be to see that there are no perforator vessels or any structures which are passing by are not caught in the clip. And the temporary clip here is removed. It's a permanent clip. The final step. Okay, this is a post-op CT angio. You can see the clip in here with the aneurysm obliterated. There's no filling of the aneurysm. You could see the aneurysm bleb in the pre-op images. This is a 3D reconstructed image. This is another aneurysm which is commonly encountered by neurosurgeons. These aneurysms are as varied as anything because the anterior communicating artery aneurysms are the commonest aneurysms that we encounter, and the projection of aneurysm usually means how the prognosis is going to be. It might be anteriorly directed and inferiorly directed. These two are relatively easier aneurysms to clip, and there are superior and posteriorly directed aneurysms which are more difficult to clip because posteriorly and superiorly there are a lot of perforator vessels which surround the aneurysm, which make it very difficult for us to clip. Here you can see that the aneurysm is inferiorly directed, and it is basically sitting on the optic chiasm. You can see that there's a bleb here. This is a inferiorly directed aneurysm. I'll go through the video again. Here you can see the brain is very angry, not like the previous scenario wherein the brain was slightly yellowish. Here you can see that it looks angry and bulging. This is because of the extensive subarachnoid hemorrhage that you see a bulging brain like this. Again, the same steps. Here I'm retracting the frontal lobe and I'm trying to make way to the optic nerve and the ACA by coagulating the bridging veins. Once the bridging veins are taken care of, again arachnoidal dissection. Once arachnoidal dissection is done, here I'm slightly opened the medial sylvan fissure also. So once the arachnoid dissection is done, we try to drain as much CSF as possible to make the brain lax. And once that is done, you can see that here's the ICA. This is the optic nerve. I'm dissecting around the optic nerve and the ICA, and again you can see that the ICA is giving of the anterior communicating artery. So what we do is we go to the ICA bifurcation, start tracing the anterior communicating artery to the anterior cerebral artery to the junction of two anterior cerebral arteries, anterior communicating artery. Here, once I've reached the anterior communicating artery, I'm applying a clip on anterior cerebral artery. This is a temporary clip which can be taken off later. This is being applied on the parent vessel, which is supplying the aneurysm. So once the clip is applied, we go more confidently onto the aneurysm. See here, you can see that the aneurysm is embedded onto the optic chiasm. This is the right optic now. It's embedded there. You can see that the dome is embedded there. So once the parent vessel is clamped, once the blood supply is minimized, that's when we go and dissect the dome. So here I'm dissecting around the dome. Once the neck is dissected 360 degrees, I'm applying the clip. It's a titanium clip which is curved around 7 mm. So once the clipping is done, again the same process starts. Dissect the dome from surrounding structures. Here it is the optic chiasm and the right optic now. And once it is dissected from all the surrounding structures, we see that no other structures are caught in the clip. And the final step would be to again decompress the aneurysm and evacuate the hematoma, so that we are confident that the clip has gone across and there's a complete obliteration. Here's a post-op CT brain. He's on follow-up. I am yet to do his CT angio. So here you can see this is the pre-op CT. You can see that extensive subarachnoid hemorrhage. This is a post-op CT on post-op day 2. You can see that the systems are all cleared up. This is one big advantage of clipping and clear all the blood. The vasospasm, which is more morbid. The top you can see that the clip is in situ. Coming to the third case scenario, it's a right middle cerebral artery aneurysm. I'm basically presenting to you few commoner aneurysms which we encounter from the anterior circulation. So this is the pre-op aneurysm. You can see that the aneurysm is a trilobed aneurysm here. Usually middle cerebral artery aneurysms not only require clipping, but to some extent parent artery remodeling. So I'll show you in the video how it's being remodeled. This is a trilobed aneurysm here. And this is a post-op aneurysm, a post-op image, which I'll come to later. So here's a short video of it again. Again, the same step. I've retracted the frontal lobe. It's the optic nerve that is being dissected. I'm trying to open up as much arachnoid as possible to drain the CSF, which is blood stained. So again, you can see that this is optic nerve and this is the ICA. I'm trying to trace the ICA to bifurcation. And once the bifurcation is found, we open up the Sylvian fissure to trace the middle cerebral artery to the site of aneurysm. So here I'm retracting the frontal lobe here, temporal lobe there, opening up the Sylvian fissure as much as possible. Usually the fissure dissection is very messy because there are thick clots which need to be drained. Again, once the middle cerebral artery is totally bared, we see the area where we don't have any perforators. Apply the clip there so that blood supply to the aneurysm is cut off to an extent. Here you can see that two lobes of the aneurysm are seen.
Dr. Sudhir?
Yes.
Sir, we are running out of time.
Yeah, it's almost over.
Conclude, yeah.
I'll be just quickly, I'll run through this. This is an interesting case. So to include the two lobes, I have put one clip. Since it's a trilobe, there's another lobe for which I have applied another clip. This is a modified tandem technique wherein we do arterial remodeling with clips so that parent vessel doesn't get occluded in spite of applying the clips. So once the clip is applied, again the aneurysm is dissected away from all the surrounding structures. This is at the end of the procedure. After confirming that no other critical structures are included in the clips. Okay. So this is a clip. This is a post-op image which is showing two clips here. So coming to the other aspect of it, it's the vasospasm, hydrocephalus, and the fluid and eloculate imbalances. Vasospasm is also called as delayed ischemic neurological deficit. It is a #1 killer after prevention of rebleed. And usually what happens is once the vasospasm sets in, clinical graphic vasospasm is more commoner. Clinical vasospasm sets in, almost 30% of the patients die, 30% of the patients develop permanent deficits, 35% only 1/3 of the patients come out with good outcomes. So instead of giving treatment for the aneurysm, either clipping or coiling, if vasospasm sets in, this is the usual outcome. So treatment of vasospasm generally includes three aspects: hypertensive therapy, hypervolemic therapy, and hemodilution. The hypertensive therapy has been found to be the most important. So the only drug that has shown class 1 level of that has been recommended at class 1 level with the level of evidence A is nimodipine. No other drug has been found to be effective in prevention and minimizing the effect of vasospasm once it has set in, other than nimodipine. So nimodipine is a drug of choice, and we start the patient on nimodipine the moment he presents to casualty with the subarachnoid hemorrhage and CT. Steroids and all have not much of an effect. So here I've shown you that surgery has some beneficial aspects. It reduces ICP. Once the blood is cleared, it reduces the extent of inflammation, thereby minimizing the risk of vasospasm. Extensive arachnoidal dissection results in better circulation of CSF, again thereby minimizing the extent of vasospasm. And towards the end, we have some procedures in endovascular also, like endoluminal balloon angioplasty, intraoperative papaverine injection, if all other treatment processes fail. Hydrocephalus is one more complication that we regularly see in patients with subarachnoid hemorrhage. Only 20% of the patients usually require some sort of permanent procedure, ventriculoperitoneal shunt or thecoperitoneal shunt. Fluid and electrolyte imbalances, usually we see SAIDH or cerebral salt wasting syndrome, and less commonly diabetes insipidus. So to conclude, 1/3 of the patients with ruptured aneurysms die even before getting to a hospital, and 1/3 die after reaching the hospital because of poor grade, or because of surgical complications, or because of the complications associated with bleed. Only 1/3 of the patients have a good prognosis, and they get discharged from the hospital in the current scenario. So the take-home message is anti-circulation aneurysms, which constitute almost 85% of the aneurysms. MC aneurysms, clipping, arterial remodeling is the treatment. Usually it has to be decided on patient-to-patient basis, because a young patient who has come with an aneurysm is likely to benefit from clipping than coiling, because clipping causes complete obliteration, and there's a less chance of rebleeding at the follow-up of 5 years to 10 years. Whereas coiling is likely to be more beneficial in patients who are not going to be fit for surgery, that is the elderly age group. Though the complexity of the aneurysm also dictates to some extent what procedure needs to be implemented in a particular scenario. So the posterior circulation aneurysm, there's not much of a controversy because they are associated with a lot of mortality and morbidity. Coiling has been found to be more preferable than clipping. But in the anterior circulation aneurysms, both have been shown to be equally effective, and it needs to be decided based on a case-to-case basis. Thank you. With this, I would like to conclude my talk, hoping to have your continued support. And once again, I would like to extend my thanks to all the people involved in the IME Tenali CME program. Thanks a lot.
Yeah, thank you, Dr. Sudhir, sir. And a very nice and meticulous presentation you have given, and also the meticulous surgery videos you have shown us. Thank you for your time. And
thank you.
Sir, any questions? Any questions from the participants? Okay, I think we'll shift to the next speaker.
Okay, thank you.
Yep, yep.
Yes, sir. Next topic will be acute invasive fungal sinusitis by Dr. VVK Sandeep Garu, Manipal Hospitals. Suriteja, sir, a few words about the speaker, sir.
Yeah, just once, please. Am I introducing Dr. Sandeep too?
Yes, sir. Yes, sir.
Just once.
Sir, yeah.
Am I audible?
You are audible. Unmute, Surya.
Hello. Am I audible?
You are audible now.
Yeah. The next speaker will be Dr. Venkat Krishna Sandip. He has done his. Hello. Yeah, he has done his MBBS from Katuri Medical College and his MS from Kasturba Medical College, Manipal. And he has passed out with the gold medal in the Department of ENT. He is the best outgoing student and university topper KMC Manipal. Gold medal for best paper presentation at the Andhra Pradesh State Conference, Anantapur. And he has publications and paper coverage for various number of rare surgeries in the field of ENT. And he has been working as a senior consultant at Manipal Hospital since the past few years. Yes, sir, Dr. Sandeep.
Yeah, good evening, sir. Can you hear me?
Yeah, you're audible, Dr. Sandeep.
Okay, sir. Can I first I would like to thank IME Tenali for giving me this wonderful opportunity, and I would like to share my experience in dealing with fungal sinusitis, which is now turning out to be a big problem secondary to this COVID-19. So, with your permission, can I start, sir?
Yes, sir. Please do.
Yeah, I'm sharing my screen. So this is my topic, which is acute invasive fungal rhinosinusitis. Before jumping into the topic, I would like to share little basics of sinusitis. I won't be wasting much of time. I would like to wind it up fast, just for the sake of audience watching this. We basically have four group of paranasal sinuses, which is frontal, which is above the eyebrow, and ethmoids medial to the eyelid and eyeball, and one below the orbit, which is maxillary sinus, and one in the occipital region, which is sphenoid. So every sinus will secrete mucus, and the mucus will drain slowly into the nose like this. So whatever pathology that causes obstruction of this ventilatory pathway will result in accumulation of the mucus, eventually inflammation and disease. So that is what we call it as sinusitis. Then coming to the causes of sinusitis, as we all know, there are multiple causes, and just to highlight a few of them, first comes the infectious part, which includes virus, bacteria, fungus, and inflammatory, which includes allergy, some few medications like NSAIDs, and dehydration will also aggravate it. So this is very important slide. It seems to be simple, but it's very important, because whenever a patient comes to you with a cold, so don't get confused. There is a three basic things like sinusitis, cold, and allergy. So sinusitis, the predominant complaint will be facial pain and pressure, and duration is always more than 10 to 14 days, and you get a thick yellow or green color discharge. And whereas common cold, which is predominantly caused by influenza virus, we always have a duration of symptoms very less, and discharge will always be thin whitish discharge. It will not be like yellow or green color. Yellow and green suggest that it's an infectious condition, which is predominantly bacteria, and thin whitish discharge will always go in favor of virus. And these patients, viral rhinitis, will always have sneezing, nasal congestion, and cough as a predominant symptoms. Whereas coming to the allergic part, allergic rhinitis, patients will have a clear, thin, watery kind of discharge, and even sneezing, cough, nasal congestion will always be very less. So predominantly they will have a discharge. Coming to our topic of interest, fungal sinusitis, it's a broad term. We basically divide into two main varieties or variation, which is a non-invasive and invasive. As the name suggests, non-invasive, it doesn't involve the surrounding structures. What are the two important things in non-invasive are like allergic fungal sinusitis and fungal ball. Coming to the invasive part, as the name suggests, invasive is like
Madan, is there? Madan, is there any problem?
Nothing, sir. From internet problem from Sandeep, sir.
Sandeep, sir.
Sir, can you hear me?
Yeah, we
Yes,
can
Yes,
hear
yes.
you, Doctor.
Yeah.
Now we can hear you.
Sorry for the disturbance, and I would like to proceed with my presentation. So we have done a lot of cases of acute fungal sinusitis before. Now, after COVID-19, we have done around 30 patients in a span of 90 days. And almost all the patients are having uncontrolled diabetes mellitus. And age group of these patients were between 38 to 62 years. And predominantly out of 30, 25 patients are males.
Sir, net problem है sir.
Yes, seems to be a net problem.
Sandeep sir, connect with your mobile, sir.
Dr. Sandeep? Dr. Sandeep?
Yeah.
Sir, we are not able to hear you properly. Can you connect with your data pack? That's your cell phone. Dr. Sandeep seems to be offline. Yeah, yes, come on online now.
He's coming in, sir. He's coming in.
Yeah.
Sorry, I have a issue with my
Changing the gadget.
Okay.
Sorry with that. I have a issue with my internet over here. Sir, can you hear me?
Yes, Dr. Sandeep, we are able to hear you.
Sir, I have a big issue with my internet over here. So
we are not able to see your video,
sir?
sir. We are not able to see your presentation.
No, I started sharing.
Yeah, please. Madan?
Yes, sir.
Are you able to see sir's presentation?
No.
Sir, we are not able to see your presentation, sir.
Sir, can you WhatsApp me your presentation? I will open from here.
Dr. Sandeep?
Internet issue, sir.
Yeah, we can see you, sir. Yeah, we can see you.
Unmute, sir.
Dr. Sandeep, please unmute. Dr. Sandeep?
Yes, sir. Can you
Yeah.
see my screen
Yeah,
right?
now, yeah, we are seeing you on the screen, and now your presentation is also visible.
Yeah, thank you. Yeah.
Go
Can I
ahead, sir.
continue,
Go ahead.
Can I continue? Yeah.
Yeah,
So,
please.
total patients are around 30 in a span of 90 days, and majority of them are having diabetes mellitus uncontrolled. And the age group included 38 to 62, and predominantly they are males. And almost all of them took remdesivir and steroids, and dosage varied from person to person because of treatment in different places. Among the 30 that we have treated, 3 patients haven't received any treatment for COVID, and they were not aware of this COVID infection until we did an antibody test for them. So then there is a doubt which got erased that the COVID itself be an immunocompromised condition leading to these fungal infections. We never know. So coming to the presentation, almost all the patients presented between 15 to 25 days after documented infection, and the symptoms varied from vision loss, blurring of vision, proptosis, facial pain, swelling, numbness, tooth pain, and CNS symptoms like headache, drowsiness, delirium, paralysis, hemiplegia, hemiparesis. But in our experience of 30 patients, we got blurring of vision and vision loss as a predominant symptom, followed by facial swelling, proptosis, and palatal erosion, followed blurring of vision. 2 patients presented with predominant CNS symptoms like disorientation. Here is one patient. She presented with proptosis, ptosis, and also swelling of the face with a palatal erosion. For her, we did a maxillectomy and orbital exenteration. He is one more patient he is also post-COVID, presented within 15 days after documented infection, and he had a proptosis, fungating eyeball, and a swelling of face. Here is one more patient where he presented with only palatal erosion like upper alveolar necrosis. Here is one more patient. There's a big palatal. These are the different presentations we encountered. And coming to the investigations, as we all do, we did a complete blood picture, and most importantly, we want to rule out the diabetes status and C-reactive protein and LFS from day to day. Urea creatinine, because of this diabetic status, many are having early CKD. And coming to COVID investigations, we did antibody test, RT-PCR, and HRCT test. Coming to the lab values, almost all the patients are having hyponatremia, where sodium levels varied from 115 to 124. And as I told you, everyone are having uncontrolled diabetes. HbA1c of all the patients were over 10, and high CRP levels and decreased WBC count. This is a typical nasal endoscopic picture. There will be a lot of black colored necrotic crust. Coming to the CT scan, here you can see the involvement of maxillary sinus, erosion of the orbit, extension into the eyeball, and also the erosion of the floor of nose and everything. This is an MRI picture of one more patient where there is an intracranial extension. Here you can see the intracranial extension. So coming to the treatment part, surgery, depending on the extent of disease, I would like to keep it very simple. It varied from endoscopic removal to the total maxillectomy, so depending on the extent of disease. If it is confined to nose, we did an endoscopic approach. If it extended to palate, we did a total maxillectomy. And coming to the eye, if the vision is intact, we did a decompression. If the vision is not there, optic nerve involved, we did an exenteration. So as I told you, endoscopic removal for disease confined to nose, maxillectomy for the disease extending to skull base and palate. Similarly, if there is a functioning optic nerve, we did a decompression. If the optic nerve is not functioning, fungating eyeball, we did an exenteration. Here is one patient where he has a complete loss of vision and facial swelling. For him, we did a maxillectomy and orbital excitation. This is how we did a lid sparing surgery, removed the eyeball and sutured the lids for future reconstruction. There is one more patient where we have did a maxillectomy and orbital excitation. This is the fungating optic nerve. This is the orbital excitation part. This is how we have sutured the eyelids. You can see the eyeball with the optic nerve damaged. This is the damaged optic nerve fungating. So coming to the medical management, which is also equally important as a surgical management, we treated almost all the patients with lipid emulsion of amphotericin B, which is reasonably cost effective. For the patients with intracranial extension, we gave liposomal amphotericin. So that daily dosage dependent on their body weight, which is around 3 to 5 milligram per kg body weight. So ideally, we started with 250 milligrams of ampho mixed in 250 ml of 5% dextrose, and we gave over a period of 3 hours for first 4 days, and slowly we increased it depending on the tolerability of the patient. Total dosage was around 3 to 5 grams depending on the disease. Patients who have a limited disease, we gave a total dose of 3 grams, and with extensive, we gave a total dose of 5 grams, and maintained these patients on syrup posaconazole 5 ml BD suspension till we felt that patient is free of disease. So this is the sensitivity. Since we got majority patients with mucormycosis, it has a very good sensitivity to posaconazole, amphotericin B, and liposomal amphotericin. So we opted amphotericin B as a primary treatment, and we maintained the patient on posaconazole as a maintenance drug. So coming to the antibiotics, major people had E. coli, which was resistant. So we sent the tissue for culture, and depending on the culture report, we started on antibiotic, which is like we gave piperacillin and tazobactam to majority of them. Fungal culture, out of 30, we got mucormycosis in 27 patients and aspergillus in 2 patients and cryptococcus in 1 patient. Patients who had aspergillus and cryptococcus gave directly posaconazole instead of amphotericin to avoid a toxicity on kidneys. So coming to follow-up, 26 patients under follow-up and are free of disease. Sadly, we lost 4 patients. 2 patients whom we lost are having pre-existing chronic kidney disease secondary to diabetes, and those patients died during treatment in our hospital. Whereas the one patient with who actually recovered from the infection but developed secondary lung infection, where it led to pulmonary artery aneurysm and aneurysm and massive hemoptysis, and patient succumbed. And one more patient was free of disease, and she was on follow-up for 2 months almost. So suddenly she had a massive cardiac arrest and collapsed at home. These were the 4 casualties we had out of 30 patients. Coming to reconstruction part, after doing a maxillectomy, palate was reconstructed with an obturator, dental obturator, by the help of a dental surgeon. And orbital reconstruction after doing orbital excitation with the forehead flap with the help of plastic surgeon and ocular prosthesis. Coming to the challenges associated with this treatment, as any challenge, the most important thing is the cost factor. The morbidity associated with their disease is too much. Patient requires a prolonged hospital stay, costly antibiotics, and the cost factor of amphotericin itself is huge. So cost, financial burden is a big thing, and prolonged hospital stay, as I told you, which always add on to the financial factors, and controlling the immunocompromised status. As such, patient got COVID, recovered, and they had uncontrolled diabetes. With such a poor immunocompromised status, it's very difficult to treat such infections. And preventing renal failure and side effects associated with this medical therapy. and managing the post-op morbidity. After you remove the eyeball, palate, there will be a lot of morbidity associated, which has to be managed. And coming to the keys to success, it's always an early diagnosis. If you can diagnose disease within 1 week, it gives you tremendously good result and also saves a lot of money for the patient. And surgical treatment and medical therapy should always be so aggressive. It should not be conservative in such conditions. Fungal sinusitis should always be treated like a malignancy. So you should be always aggressive with your treatment. And the most important factor is improving the immunity, as I told you. Since they are all immunocompromised, we should work on the immunity levels, good nutrition, rest, and good, finally, last but not the least one, good team support. Since it's a complex condition, it involves the support of endocrinologist, nephrologist, critical care expert. And if you have a good team, dedicated team, you can always give a very good result in these conditions. And final, my message would be controlled steroid usage in treating COVID. Very important. It should not be aggressive steroid usage. Always keep in check. COVID and post-COVID aggressive management of diabetes at most important. And last but not least, early identification of symptoms and signs to prevent morbidity and mortality. Nothing is more important than early identification. My message would be to uh, any patients post-COVID, if they come to you with eye swelling, facial puffiness, tooth pain or something, please aggressively investigate it so that we cannot, there will be minimal chance that we will be missing this fungal sinusitis. Very important. Thank you once again, IMA, for giving me this wonderful opportunity to share my experience.
Yeah,
Thank you,
Dr.
sir.
Sandeep, very nice presentation. And
you,
we wish that the internet didn't play any spoiled sport with you. Anyways, a very nice presentation and a very nice topic. And any questions from the audience? Okay, sir. On behalf of IME Tenali, thank you very much.
Thank you. Thank you, sir.
Yeah. Can we call on the next speaker?
We have to wait. This is over, I think.
Sir, this session is over, sir.
Yeah, this session is
Thank
over.
you, sir. Thank you, Suriteja,
Yeah.
sir.
Yeah. Thank you.
Thank you, sir. Thank you.
Thank you, Surya.
Thank
Sir,
you,
we
sir.
will-
Thank you for the opportunity.
Sir, we will continue after half an hour, sir.
We'll start again at 6 p.m.
Yes, sir. We will start at 6 p.m., sir. A short break for 25 minutes.
Sandeep will take over.
Yeah, yes, sir. Thank you, sir.
Hello.
రావు గారు 6 గంటలకి నేను టైప్ చేయాలరా, నాకు ఓపికలేదు టైప్ చేయడానికి. పొద్దున్న టైప్ చేసా కానీ టైప్ చేయాలి. ఇప్పుడు మళ్ళీ మధ్యలో వస్తారు కొంతమంది. మనకు 500 సర్టిఫికేట్ సరిపోతాయి మరా. మన డూప్లికేట్ సర్టిఫికేట్లు వేయిద్దామా కొన్ని?
హలో మదన్.
ఎస్ సార్.
వచ్చారా? నెక్స్ట్ స్పీకర్ వచ్చారా?
నెక్స్ట్ స్పీకర్ సార్ వి హావ్ లింగారెడ్డి సార్.
అనిల్ కుమార్ వచ్చారా?
నో సార్, నాట్ దేర్ సార్.
అనిల్ కుమార్ ఉండాలి చూడు అక్కడ. ఒకసారి అనిల్ కుమార్ కాల్ చేసుకుని తర్వాత డాక్టర్ కృష్ణారావుని శ్యామ్ ప్రసాద్ గారు వచ్చేటం చూడండి చైర్పర్సన్స్. అది నువ్వు అడ్మిట్ చేస్తున్నావా మదన్?
Yes, sir. Doing, sir.
సరే ఒకసారి చూడు, ఒకసారి మిగతా వాళ్ళని కూడా.
Okay.
Hello, can you hear? Srikanth?
Yes, sir. Yes, sir.
You are audible.
Okay.
మదన్ ఒకసారి మిగతా కృష్ణారావు సార్ చూడు.
సార్ కాల్ చేస్తాను.
ఇతను సందీప్ నుండి చూడు ఒక అతను డాక్టర్ గారు.
సార్.
టైం ఎంత? 5 minutes ఉన్నాయి.
Sir, Krishna sir also in, sir.
Yes, Sandeep has come. సందీప్ సార్ వచ్చారా చూడండి.
No, sir, no.
సందీప్
Good evening, everyone. Sir, is it audible? My voice is clear or not?
Yes, clear.
Hello.
Audible.
Is my voice audible, sir?
Yeah,
very much clear.
Yeah, okay, sir.
Sir, Sandeep sir also in, sir.
Yeah, no problem. We'll wait.
Hey, Sandeep sir is there.
Yeah, okay. So can I start now?
Just 1 minute, Dr. Anil.
Srikant, can I start now?
Welcome to the second session. Dr. Krishna Sandeep will join shortly. He is the moderator for this session. Anyhow, Dr. S.V. Krishna Rao Garu, one of the leading physicians and senior most physicians of... yeah, Sandeep, are you in? Dr. S.V. Krishna Rao Garu, senior physician of Tenali, and Dr. K. Shyam Prasad, physician and cardiologist from Tenali. And Sandeep, am I audible, Sandeep? We'll take over from now. Sir, take over, sir.
Okay. So it's a nice evening.
Just 1 minute, Anil. Dr.
Shyam, sir.
Yeah.
Shyam.
Okay. Yeah.
Yeah, take over.
We like to thank Dr. Anil Kumar for accepting our invitation to give a talk from IME Tenali, and he is the young dynamic cardiologist, and he has pursued his medical education from some of the prestigious institutions, MBBS from NTR University and MD General from KVG Medical College, Mangalore, BA Cardiology from NTR University of Health Sciences, and he has pursued from Europe AFESC, and he worked as ex-consultant cardiologist in Andhra hospitals and ex-assistant professor at NRI Medical College, and he is a specialist in intervention cardiology like pacemaker, complicating stenting, angioplasty. Is a specialist in peripheral interventions also, and managing well the cardiac emergencies, and giving excellent results in primary PCI and pediatric cardiology procedures. And now we'd like to invite him for give his talk on PCI and its complications. Over to Dr. Anil Kumar.
Yeah, good evening, sir. Good evening, Shyam Prasad sir and Dr. Sandeep and Dr. Srikant sir. And it's a good initiation from IME Tenali conducting this virtual meet CME during this COVID situation. It's really appreciable thing. So today I want to start my topic, that is introduction to PCA and its complications. So coming to the epidemiology of the coronary artery disease, if we take this epidemiology, the major cause of the morbidity and mortality all over the world is mainly due to the coronary artery disease. And in 2016, that American Heart Association reported that 16 million persons, that is above more than 25 years of age, have coronary artery disease, and the prevalence increases with the age. If you see in the Western countries and all, this coronary heart disease mortality has declined. Whether compared to our developing countries like India, it's increasing. If you take the cardiovascular disease death rate, it's around 272 per 1 lakh population in India, whereas it's higher than the average other global cardiovascular death rate of 235 per 1 lakh population. And epidemiological study shows prevalence of coronary artery disease around 7 to 13% in urban areas and 2 to 7% in the rural areas. So treatment modalities in the coronary artery disease generally, if we take lifestyle modification and risk factor management first, like quitting smoking and alcohol, doing regular exercise and weight control, and management of diabetes, hypertension, dyslipidemia. And coming to the pharmacological therapy, as we know, antiplatelet therapy and anti-angiogenic therapy and antithrombotic therapy. And coming to the revascularization, PCIs and coronary artery bypass grafting. So I am dealing with this PCI, what we are doing actually. So what is PCI? That is percutaneous coronary intervention. Include PTCA with or without stent insertion. What is PTCA? It is a percutaneous transluminal coronary angioplasty. That means only with balloon dilatation. We will do the balloon dilatation at the lesion. This was first performed in humans by Grunzig in 1971. These days, we are doing most commonly these interventional procedures. Generally, in the primary PCIs, we do the PTCA and stent placement within 90 minutes of onset of the STMI. So we can see here the layers of the coronary artery, that is intimal area, internal elastic, and the tunica media, and external elastic lamina. So generally in the primary PCIs and all, just or any in the NL2 PCIs, generally this is the coronary artery cross section. If you see, this is the plaque area, and this is the balloon. So we will dilate the balloon so that the plaque circumferentially it distributes the plaque, so that we can place the stent easily there. So what are the indications and contraindications? Indications, as we know, ST elevated MI and non-ST elevated MI, unstable angina, stable angina, even in angina equivalents, even in stress test who are at high risk, we can do the stenting. And contraindication, severe coagulopathy, in decompensated congestive heart failure, uncontrolled hypertension, pregnancy, patient who is not cooperative, and active infection, renal failure. So if we take the terminologies and all, what is primary PCI? Whichever the patient with STEMI coming to the hospital, we can do the primary PCI within 12 hours after onset of symptoms. Even if the patient is symptomatic and ECG changes are still persisting, we can do up to 24 hours primary PCI. What is rescue PCI? If thrombolysis failed, we can do the PCI within 1 hour. It is called rescue PCI. And what is facilitated PCI? That is after thrombolysis, the thrombolysis is successful, then after 3 to 24 hours, we will do the PCI. That is called facilitated PCI. So this is the STEMI chart. That means what to do in the patient of STEMI patient, what to do in peripheral center or a tertiary care center or in any nursing home, anything. So if any patient comes with STEMI in primary PCI capable center, we can do primary PCI within 60 minutes. And if the STEMI patient comes to any non-primary PCI center, like if we don't have any cath lab centers, any nursing homes, so we have to see whether we can send the patient to the hospital, including transport delay. Can we do the primary PCI within 2 hours? Means we can transfer to the cath lab center. So within 120 minutes, we have to shift to the cath lab center and we can do the primary PCI. If not, do thrombolysis, immediate thrombolysis within 30 minutes in the nursing home itself, and immediately transfer to the PCI center. If the thrombolysis is successful, that is chest pain is not there and the ECG changes have subsided, then within 3 to 24 hours we can do the coronary angiogram and we can do the facilitated PCI. Otherwise, if the thrombolysis is not successful, then we have to do the PCI. That is called rescue PCI. So what are the equipment we need? So we need guide wire, mainly coronary guide wire, balloon, and stent. So we know the stent. So there are different types of stent. Just I'll give you a brief introduction about the stents. So we know there is a bare metal stents and drug-eluting stents. So nowadays, from the last 10 years, everything is drug-eluting stents. So these drug-eluting stents advantage is it has reduced the restenosis and the target as revascularization rates. So these drug-eluting stents are famous. In United States, currently they are using everolimus drug-eluting stents and jatolimus drug-eluting stents. In India, we are using sirolimus also. So there are two types of stents generally. So we are using currently bioabsorbable polymer stents. That is, the polymer will be absorbed, but the metal will be there permanently. But in the bio-reabsorbable scaffolds, even the metal also will be reabsorbed. There won't be anything if you do the angiogram. So we can't see anything. But these bioabsorbable bio-reabsorbed scaffolds is not that much, the studies are showing not that much beneficial, or it's not successful, we can say. And stents are conventionally placed after balloon peridilatation, but in selected coronary lesions, we can do the direct stenting. So procedure, just I will explain about the procedure. So these are the routes: femoral, radial, and brachial artery puncture. From this brachial artery puncture or radial artery puncture, femoral artery puncture, we send a catheter through up to the coronary ostium. Just I will show the video. So this is a patient. We are doing angiogram. So this is the left main. This is the catheter I'm showing about the catheter. So this is the right coronary catheter. I am hooking to the ostium of the right side sinus. See, we can see, but this is anomalous anomaly. This is a LCX coming from the right sinus. This is the right coronary artery. So we can see the occlusion here. So this is the coronary guide wire. This is the coronary guide wire. And I have dilated the lesion, that 100% occlusion I have dilated. At the distal RCA, there is 100% occlusion where I dilated with the balloon. And after balloon dilation, we can see the PD and PLVB branches here. So I decided to stent there. So this is the stent from the distal RCA to the PDA. So after stenting, I did the post dilatation also. So after stenting, you can see the vessel. And this is another patient who came this 2 days back. This is the right coronary artery. And this is the left side system. We can see LAD is 100% occluded here. This is LCX and this is LAD. So this is LMCA. We have hooked the EBU at the left main ostium, and LCX LAD is occluded 100%. So this is the primary. This is the anterior wall of my patient. So she came within 2 hours of the window period. So we did the primary PTC. I did the balloon dilatation. See balloon dilatation. So after balloon dilation, we can see the vessel completely. We can visualize the vessel, and I kept the stent there. So I inflated the stent. So and I post dilated also. And after post dilatation, we can see the vessel. We can visualize the vessel. So it's TIMI3 flow. So this is the procedure generally we do. So what is the anticoagulation we use it during the PCI? So as usual, in acute MS, generally we give clopidogrel around 300 mg and aspirin of 325 mg. Before PCI, we can give clopidogrel 600 mg, aspirin 325 mg. If you want to give ticagrelor, means we have to give the loading dose of 180 mg. That means 2 tablets stat. But we should not use prasugrel, because without knowing coronary anatomy, we should not use prasugrel, because prasugrel has a long-acting drug. It's a long-acting drug. So if the patient, after doing angiogram, the patient has to send for CABG, means emergency CABG, means he has to wait for 7 days. So that's why we should not give prasugrel as a loading dose. We can give only clopidogrel and ticagrelor. And we use other glycoprotein 2B3 inhibitors like tirofiban use normally in the acute MS situations. And stent types, the recent new stent is dual therapy stent. That means, as earlier I told that is sirolimus, everolimus, jatolimus stent we are using nowadays. But recent new stents are like dual therapy. That means sirolimus with albuminous stents. These we have to wait still. These studies are going on. We have some studies are telling it's beneficial, but still more studies we have to see whether it's really beneficial or not. What is the advantage of drug-eluting stent than bare metal stent? In the drug-eluting stent, it was coated with the medications to prevent the growth of the scar tissue in the arterial lining. Because what happens when we inflate the stent there, the raw surface of the artery will be exposed. So that is the area where the stent thrombosis or thrombosis occurs. So for that only, we have to give the antiplatelets more cautiously in the first year. And increases of chance of blood clots and stent thrombosis more with the drug-eluting stents because of that. But in bare metal stents, what happens? As the artery heals, tissue grows around the stent because there won't be any drug on the stent. So that's why the instant restenosis are more with the bare metal stents. So complications, if we see, as we know, allergic and adverse reactions, contrast-induced nephropathy, hematoma at the puncture site, and retroperitoneal hemorrhage, mainly with the femoral artery punctures, and pseudoaneurysms, and arteriovenous fistulas and ventricular arrhythmias, and CVAs and radiation injury, and hypotension, that is vasovagal attacks, hypotension, hypoglycemia, death, and infections, rarely stent infections. So detail, if you see the PCA complications, if you see the statistics, generally in overall almost 2 million PCA procedures are done worldwide. In India, it's around 6 lakhs procedures done up to now. And angiographic success rate of around more than 95%, and overall complication is around 1 to 5%, including small complications also. So when we call it successful PCA, generally if we do a PCA in a 80% stenotic lesion, after doing the stenting, the enlargement of epicardial vessel to a minimal lumen diameter of less than 10% stenosis or near to 0% as possible, and a TIMI 3 flow without any clinical complications. That means the stenosis should be less than 10% or 0%. Then we can call it a successful PCA. So what are the characteristics that carry the increased risk for the complications? One thing is advanced age and urgent or unscheduled intervention, like in acute MI settings, and hemodynamic in unstable patients, heart failure patients, already known renal insufficiency patients, diabetes patients, electrolyte imbalance patients, and having arrhythmia at the time of procedure. And procedure complication categories, like they can go into stroke, acute MI, and ischemia requiring emergency CABG, and vascular site complications, and contrast-induced nephropathy, excessive bleeding, and even death. So if it is in the percentage of all these death at 1 month post PCI and cardiac perforations and emergency surgery, stent thrombosis at 1 month, and renal failure, hemodialysis, all these are almost less than 0.5%. Even 1 month death with stent thrombosis or without stent thrombosis is around 2 to 3%. So the overall complication is around 3.36% with these procedures. So what is the common complications with the femoral access for PCA? Main dangers is retroperitoneal hemorrhage. If we puncture the femoral artery above the level of that as anticipated area, these retroperitoneal hemorrhage can occur, and pseudoaneurysms, AV fistulas, hematomas, neuropraxia, and lower limb ischemias and dissections. So what is the ideal site for the puncture of the femoral artery during the femoral access? So this is the in the fluoroscopy, if we do, we can see the femoral head here, and this is the center of the femoral head. Below this, around 15 to 14 mm, this is the target zone for the femoral artery puncture. So this is the femoral artery, common femoral artery, and this is the femoral artery exact zone for the puncture. So what are the angiographic characteristics that can cause complications? Mainly calcification vessels can lead to severe complications, and tortuous vessels, left main stenting, bifurcation stenting, and saphenous vein grafting stenting, and doing procedures in CTOs, chronic total occlusion cases, and multi-vessel PCI. So all these can cause, we can anticipate the complications with these characteristics. So we can see the angiogram here. We can see here there is a dissection. See, we can see a white patch like here, some lucency we can see here. This is called coronary dissection. What is coronary dissection? It involves the plaque fracture and intimal splitting and tear, which may extend to the media for varying distance. So these are the types of the dissection we can see. So type A to type F. Type A is minor radiolucency with dye injection, with clears with the injection. And another B is appearance of double lumen lucency, which rapidly clears with the injection. Type C, but it extravates outside the lumen, but it persists after the dye clears. And this is spiral dissection, and this is the persisting filling defect within the lumen, and a dissection leading to the complete occlusion of the vessel. And this is a dangerous one, which we can't again, we can't cross the lesion with normal wires. We have to go for the different wires, for like CTO wires, we have to go with this. And coronary perforation, it's an anatomical breach in the integrity of the tunica adventitia of an epicardial artery, leading to extravasation of blood either into the myocardium, pericardium, or other cavities. So these are the like classification of the perforation. In the class 1, the crater is extending outside the lumen, and it's just a crater extending the outside the lumen of the vessel. That's it. In the type 2, there is a myocardial blush and pericardial blush, but the exit hole is less than 1 mm. And it's printing mistakes. It's not. Oh, okay, without it. Okay, it's less than 1 mm. And the grade 3, it's more than 1 mm exit hole. And in grade 3 with cavity spilling is perforation into an anatomical cavity chamber or coronary sinus.
Sorry to interrupt, Anil. 5 more minutes. Can you wind up and so that questions can be 5 more minutes. 6:30 next session to start.
Okay, disruption of the vessel wall through the intimate media and adventure. In the distal perforations and all, it caused by the guide wires generally. In the lateral ruptures, it's due to balloon during the time of balloon inflation and during the catherectomy procedures and during stent inflation. Generally, it causes. So, what are the indications for the emergency cardiac surgery following PCA? One is extensive coronary dissection or perforation or tamponade, recurrent acute vessel closure, hemodynamic unstable patients, aortic dissection, and guide wire fracture. Even guide wire fracture also we can, even guide wire also, if the small guide wire fractures, we can leave it instead of going for surgeries. So how can you minimize PCA complications? First thing, self patient and lesion carefully and anticipate the problems before doing the procedure. And do not fall victim to the oculostenotic reflex. That means after seeing the lesion, it's around 80%, so we can go for stenting. No, whether the patient is symptomatic or not, because whether patient is symptomatic due to that lesion or not, we have to think. Then only we have to do stenting. And select a good guide catheter for support. And adequate angiographic views pre and post intervention is very important. And the procedure should be kept as simple as possible. We should not complicate the procedure. And one must have excellent knowledge about the equipment and know our limitations. And we should know when to stop the procedure. And always maintain the highest level of concentration and learn from one's own mistakes and others' mistakes. Thank you.
Thank you, Dr. Anil Garu, for giving an excellent talk and brief talk on PCA and its complications.
Sir.
And now I ask Dr. S.V. Krishna Garu.
Finish up. Right.
Dr. S.V. Krishna Garu, any comment?
Hello, is it audible?
Yeah,
yes, sir. It's clear, sir.
Okay.
Sir, any comments? No, any questions? Some few questions. Can anybody ask Dr. Anil Garu regarding PCA and its complications from the floor? Sandeep, sir, any comments and questions? Srikanth.
Okay, I will ask one question.
Sir.
In 2019, one ischemic study is there. Compared to the medical therapy with PCI,
sir,
advantage or is there any advantage, percentage of advantage over medical therapy or PCI?
Sir, generally PCS guidelines suggest, sir, if any lesion more than 70% stenosis, we can go for stenting. But thing is, whether patient is symptomatic with that lesion or not, means we have to do the FFR, sir, fractional flow reserve, to see the whether ischemia is causing, whether the stenosis is causing ischemia or not, we have to see. So if we do the FFR, if the FFR comes positive, that is, it shows that stenosis is causing ischemia, means we can go ahead for stenting, sir. Otherwise, if the stenosis, even it is 90%, if the FFR shows negative, we can leave the lesion, sir. So in that sense, we can keep medical therapy. Even for many patients like triple vessel disease patients who are having diffuse disease, like diabetic patients having the diffuse disease, or patient who are unable to go for bypass or unable to do stenting means, generally we keep in the medical therapy, sir.
So even asymptomatic patients, even 90% blockage.
Asymptomatic patients, 90% blockage without causing any ischemia. If you like FFR, if you do, sir, or FFR or IFR, if there is no ischemia, then we can leave it, sir. We can keep him follow up with medical therapy also. It's proven, sir.
Yes, yes.
Yes.
Okay, thank you.
Thanks.
I like to ask one question.
Sir.
How did you face this COVID situation, and how did any guidelines? There are very vague guidelines and regarding the stenting in the COVID patients. And you bravely has worked and faced the situation. And can you throw some light on it?
Sir. In COVID situation, actually difficult time, sir, because one thing is so many people are presenting with acute MIs at that time. We do 3 to 4 people of COVID patients primary PCI, sir. Thing is, in the first day when they came with acute MIs, we do the CT scan because there is no proper guidelines because of unavailability of RT-PCR in the hospitals, private hospitals, and initially we know, no, sir, there is a we don't have proper kits with us, so they have to go for the government hospital for the testing and all. So in the primary primary acute MIs and all, we can't send the patient. So in that time, we did the CT scan, sir, for initial screening. So we see the CT scan. If the CT scan is normal, we did the primary PCI in that patients. But in the second day, third day, they developed the symptoms slowly. So like we are using the PAPR, doctors we are using the PAPR, and the sisters are using N95 mask. But the prognosis is good, sir. Even in the COVID patients, even in the STEMI as prognosis is very good, sir. Same as like non-COVID patients.
Yeah, along with this, because it's a hypercoagulant state, this corona, all whole body is clot impacted.
Yes.
So the complications, did you face any after post-stenting within 10 days, after 1 month, did you face any stent-based stenosis?
No, sir. 4 cases we did, sir. 4 cases, no stent thrombosis as recorded, sir. Up to now they are in follow-up only. So, but we kept 7 days heparin, sir. Even with brilliant ticagrelor, if the patient's age is less than 70 years, we kept heparin and ticagrelor loading dose. If it's more than 75, generally we avoided heparin because of some bleeding complications. But we kept heparin and ticagrelor both, sir.
Post follow-up also are giving what medications you are giving post-COVID?
Sir, post-COVID, as usual, same medications, sir. Ticagrelor, aspirin, and beta blockers. If the LV dysfunction is there, means AC inhibitors, ARBs, and diuretics. And some vitamin C, zinc we are giving, sir, 2-3 months, sir. And we have given the course of COVID also, sir, like doxy, ivermectin. Some patients, they have received remdesivir also.
Nice. And now can we any more questions to the
Sir.
Sir.
Sir, what is the incidence of stroke during angioplasty, sir? Incidence of strokes?
Less than 0.5%, sir. Very rare, sir. Less than 0.5%. That too because it occurs because the plaques in the aorta and all, we just manipulate there, no, sir, to engage with the coronary ostium. In the aorta and all, plaques will be there. So that plaque may rupture and the thrombus can move to the brain and it can cause CVA. Generally, most common is atheroembolic, sir. Most CVS during coronary is because of atheroembolic.
any more questions?
Sandeep, go ahead with the second presentation.
Yes. Thank you, sir. Thank you very much for your valuable thing. And I'll thank like Dr. Anil Kumar for his broad lecture about what about the PCI and its complications. And next, I would like to invite Mr. Dr. S. Viswanath Karthik garu.
Thank you for giving the opportunity. Thank you, sir. Thank you. I'm sure Okay. I stopped the sharing the screen.
Welcome to sir. Welcome to evening session.
Welcome, Dr. Vishwanath Karthik Garu. Sir,
Yeah. Good evening, sir. Good evening.
Sir, he pursued his medical education from some of the prestigious institutions. Sir is some DM cardiologist and also some ex-associate professor department of cardiology from Trivandrum. And he did his DM from Sri Chitra Tirunel Institute from Medical Sciences and Technology. And also he's worked as an ex-assistant professor at Sri Chitra Tirunel Institute for Medical Sciences and Technology. So I'd like to start about the mitral regurgitation, an overview, and it's in detail.
Good evening, everyone. Thank you for giving me this opportunity. Today, I'm going to present a topic on the natural history and an overview regarding the management of the mitral regurgitation. Able to see my screen, sir?
Yeah, yes. Yes, it is visible.
Yes, sir. Good evening, everyone. Today, I'm going to present a topic on the natural history and management of mitral regurgitation. And thank you for giving me this opportunity. So the scope of my presentation will be the introduction, and I'll be discussing the natural history of the mitral regurgitation in unoperated and operated patients, and briefly regarding the management of mitral regurgitation.
So what happened? It is not audible.
Karthik?
Karthik?
Madan, you just look into Dr. Karthik's presentation. There's some technical issues there. టైం పడుతుందా?
Hello.
Madan, what happened? Madan?
Relogging in, sir.
Where is the problem?
That's the, I think, internet problem అనుకుంటా సార్ అక్కడ స్పీకర్ దగ్గర.
కార్తీక్ దగ్గర.
కార్తీక్ దగ్గర.
మరి స్టార్ట్ అయ్యాక ఒకసారి స్పీకర్కి చెప్తే సెషన్ ఎంత టైంలో పెట్టాలో సరిపోద్ది సార్, క్వశ్చన్ టైమింగ్ ఎంత.
లేదు మన టైం ఉందిలే శ్యామ్, హడావిడేళ్ళు.
ఇప్పుడు ఇంకా 6:34 అయింది, ఇంకా హాఫ్ అన్ అవర్ టైం పర్లేదు.
రాజ్యలక్ష్మి గారు లైన్లో ఉన్నారా? శ్రీకాంత్
మ్యారేజ్ అనుకోండి సార్ మేడంది.
ఓ ఎప్పుడు?
ఇవాళ నిన్నో చెప్పారు సార్, కరెక్ట్ తెలియదు.
ఓ ఇవాళ కాదే నాకు తెలిసి 29 ఉన్నారే.
రాజలక్ష్మి గారు
ఇట్లా తారక్ కూడా రాకపోతే ఎవరు ఉన్నారా?
ఐ విల్ టేక్ ఓవర్ సార్, వాట్స్ ఓకే.
Hello.
Vishwanath, your presentation, please. Vishwanath, go ahead.
So this is a study which I am discussing, where the Rappaport et al. Study, where they reported an 80% 5-year survival and a 60% 10-year survival in those patients with medically treated patients with MR. Okay, so this is one more study which reported that the overall 5-year survival was approximately 70% in those patients with a medically managed mitral registration. So the survival in the medically treated patients was strongly linked to ventricular function, and a short-term survival is poor in those patients with a subnormal ventricular or RV function, irrespective of the symptoms. So it's always better those patients who are developing or about to develop LV dysfunction, it's always better to send for surgery. And one more thing is, patients with chronic severe MR who have a high likelihood of developing symptoms or LV dysfunction over a course of 6 to 10 years. So chronic severe MR patients also we should be always monitoring for the symptoms. And also the mortality rate with symptomatic severe MR caused by flared leaflets is around 6 to 7%. So this is the case where those patients with who are associated with heart failure, you can see there is the incidence of heart failure and the years of diagnosis. You can see those patients who develop heart failure, the incidence was really worse, and the surgery or death is also very high. And also those patients with atrial fibrillation also who develop in a case of mitral registration, these patients will also have a very bad prognosis. So a symptomatic severe MR, you can see those patients who are having symptoms of class 3 or class 4, their survival is decreased to only 20% at 5 years. And also those patients who are having LV dysfunction, their survival also is decreased. And here, these are the graphs which show this one study where the asymptomatic patients with moderate to severe MR and normal LV function, where they compared, and those patients with an effective regurgitant orifice of more than 40 have a high incidence of cardiac events and asymptomatic LV dysfunction. This is one study where I already told the LV dysfunction those patients, suppose if the ejection fraction appears normal, and on echo, if we see the LV end-diastolic dimension, if we see the LV end-diastolic dimension is gradually increasing, it means it's like more than 40 millimeter, then we should, in those patients also, the survival is reduced. And the incidence of complications in MR as the time and also the severity of MR increases, there are high percentage of complications. So the natural history of operated patients versus in repair versus replacement, where there is and those patients who have here you can see this graph where the red one is the mitral valve repair and the blue one is the mitral valve replacement. As much as possible, always we should try to do repair only rather than replacement, because those patients whom we do replacement, there is always a risk of various complications related to prosthetic heart valves, anticoagulation related complications. These all are very common. So always we should try to do repair, and always we should prefer repair to the replacement if the valve is suitable. And this is repair versus conservative management, where again, those patients who are having severe MR, we should not manage them conservatively if they're having symptoms. We should always go for a early repair in those patients, because the incidence of developing LV dysfunction is high. These are the surgical outcomes where in this study where those patients in whom the posterior mitral leaflet is prolapsed, those had a better outcome, and even after repair also, these patients had better outcomes, those patients with a PML prolapse. These are the various other studies which show that the LV dysfunction is associated with high mortality, and also and this is one study associated with symptoms. It means the predictors of surgical late outcomes. In this study, they showed the predictors of worse outcome, that is a reduced post-operative LVEF, and the older age, or the elevated serum creatinine, or elevated systolic blood pressure, or presence of CAD, or advanced functional class. These are all associated with the worse surgical outcomes. So the effect of timing of surgery on outcome in symptomatic hemodynamically significant MR. So as I already told you before, the early surgery is always preferable in these patients with a rather than a conservative management. And you can see the 10-year survival is 79% versus 65%, a gross difference with a significant value. And the atrial fibrillation outcomes after the mitral valve surgery, where you can see those patients who develop atrial fibrillation have a reduced survival when compared to those patients who are in the sinus rhythm, because of the loss of the pump effect of the LA. So definitely these patients will have a worse outcomes. And the percutaneous methods of chronic primary MR like mitral clip, these patients are still, the primary mitral clip is still having only a 2B indication for the repair in the chronic primary MR. So the management, if you see, I'll discuss as acute MR and chronic MR. If you see the hemodynamics of acute MR, what is there? There will be sudden, if the acute MR means usually there is a sudden papillary muscle rupture or caudal rupture or something like that. So there will be a large volume of blood imposed on the LV. So it will be a rapid rise in the LV end-diastolic pressure and the left atrial pressure. So this results in the pulmonary edema, and the patient will go into hypotension. So these patients, the degree of hemodynamic deterioration depends on the etiology, and it's very rapid. And one more thing is the left atrial compliance, which is normal unless acute AR is superimposed on chronic MR. So those patients who are having chronic MR, suppose if they suddenly develop some papillary muscle rupture, it will go into, they'll go into pulmonary edema. Okay. So the acute MR etiology, two things we can tell. One is either it can be ischemic MR, it can be non-ischemic MR. So ischemic MR is because of the ischemia to the papillary muscle causing MI. Whereas non-ischemic MR is because of the ruptured mitral chordae or an infected endocarditis or a rheumatic heart disease, or it can be a spontaneous rupture. So acute MR ECG, if those patients who are having ischemia, suppose in these patients, I will show one more slide. Yeah. In this, those patients who are having ST elevation in inferior and posterior leads, it means the posterior papillary muscle rupture, it usually, they can present like a pulmonary edema. Whereas those patients with the anterior location, they present with shock because of the massive involvement of the myocardium. But just remember, even if there is MR also, the severity of MR is most important in acute MI setting, because those patients with a severe MR, they'll have very worse prognosis. But even if there is ischemia to papillary muscle, MR need not be there. That is what is observed in the shock trial. In the shock trial, they did not have ST elevation new Q waves, and in many patients it was recognized that complete vessel occlusion was there, but they did not have a ST elevation. So acute MR, echo is the first thing to confirm, very easily available, and it can be done bedside very fast. And also associated with MR, we have to see, are there any other mechanical complications like a VSR, that is a ventricular septal rupture. Transesophageal echo, the TEE, that we won't do usually in these kind of acute settings unless the patient is very much hemodynamically stable. So acute MR cardiac catheterization also we won't do, because the coronary angiography, only if hemodynamically stable only we'll do coronary angiography, or else we won't do. We should directly take for the surgery. And acute MR medical management, that is the primary goal is to stabilize the patient first prior to surgery. And we can give intravenous nitroprusside, which can reduce the mitral regurgitation, so that it increases the forward cardiac output and diminishes the pulmonary congestion. And definitely the diuretics are the first line, because these patients will be in the pulmonary edema, so that we can use the diuretics to reduce the filling pressures in this patient. So this is one study where reduced systemic vascular resistance as therapy for severe MR of valvular origin. That is, those patients who are having severe MR, the afterload reduction is much useful, and it reduces impedance to the forward output of the LV. If those patients who are severe and hemodynamically unstable, we can use IABP, and we can temporarily stabilize these patients. This is a table showing various modalities, that is the medications which we discussed, and the mechanical ventilation, and the IABP, or temporary LVS devices, which are very rare and available only in very few centers, or else and surgical options, the ECMO can be used. So whereas the acute MR presents like a pulmonary edema, sudden hemodynamic collapse, those patients with a chronic MR, they have a long duration of mitral regurgitation. So the LV-EDP and LA pressure are very gradually increased, and there is a compensatory dilatation of the LA and LV. And because of this, there is LV hypertrophy and and because of this, there will be there's a saying where MR begets MR. It means the more MR, it leads to more LV dilatation, and leads to further MR. So that is what happens in the chronic MR, which gradually results in the contractile dysfunction. There will be reduced ejection fraction, and gradually there will be pulmonary congestion and a reduced stroke volume. But all this happens over a very gradual period. Everything happens in a very gradual period. So this patient's management is the primary abnormality should be corrected, like the repair of the wall leaflets, or suppose if there is any caudate tendinae issues, we should fix the caudate tendinae along with the repair of the mitral registration. And the secondary MR, we usually won't operate unless there is associated CAD. So the management of chronic primary MR, again, the echo is the first line of modality, which shows really helps in the severity assessment of the mitral registration. And whereas in those patients who are having any doubt on the transesophageal transthoracic echo, or some patients will be having posteriorly directed jets, which cannot be seen properly on a transthoracic echo. So in those patients, we'll be doing a transesophageal echo. And those patients who are having asymptomatic LV dysfunction, we should be periodic echocardiography. It means we should periodically, every 3 months or every 6 months, we should monitor their mitral registration. What is the LV function? What is the LV and systolic dimension? These all we should monitor in these patients. So, and those importance of exercise testing. Suppose patients sometimes they'll tell like, I don't have any symptoms, but actually they'll be having symptoms when they do some stress. So we'll be doing exercise testing in those asymptomatic patients, and we will be assessing their symptoms. So the exercise echocardiography we can use to quantify the exercise induced changes in the MR. It means like a patient will be asked to do exercise, and at that time we will be doing the echocardiography, and we'll be assessing the pulmonary pressures. Is there any increase in the pulmonary pressure and all? So in asymptomatic patients, the significant rise of pulmonary artery pressure with exercise has been reported to be of a prognostic value in for mitral registration. So one more thing is BNP also can be used in asymptomatic patients. If the BNP levels are very high, definitely we can consider for sending for surgery. So the principles are mainly identifying the cause. We should know the severity of registration, and we should treat the underlying disease process, and we should be preventing the complications. And the main thing is educating the patient who are asymptomatic. So this is my last slide, where we can see the primary. Suppose is first, if you come across any mitral registration patient, first we should know the cause. Is it a primary MR, or it's a secondary MR related to some ischemic cardiomyopathy or other causes? So is the MR severe or less than severe? So suppose if the MR is severe, and if the patient is symptomatic, and if the LV ejection fraction is more than 30%, the mitral valve surgery is a class 1 indication. Here you can see, if suppose the LVEF reduces to less than 30%, it is becoming a class 2B indication. So always any mitral registration patient, we should always continuously monitoring for the LV ejection fraction, especially in the asymptomatic patients. So in asymptomatic patient group, we should see the LVEF. Suppose if it's gradually increasing of LV and systolic dimension, we should offer them surgery. And as much as possible, always we should offer them a mitral valve repair rather than replacement. So these numbers are important here. LVEF more than 60%, and LV and systolic dimension less than 40. This is very important. Those patients who are having LV and systolic dimension less than 40, and we should definitely send for a mitral valve repair. Okay. And also AF, those patients who are having AF, definitely we should send for surgery. And those patients who are having secondary MR, here you can see it's only a class 2B indication, unless surgery is indicated in patients with severe secondary MR undergoing CABG and LVEF more than 30%. So those patients who are undergoing associated CABG, we can do a mitral valve repair or replacement during the time of CABG. That is the only class 1 indication is for repairing the mitral valve at the time of CABG. So I'll conclude my presentation. So there is a natural history of MR is helpful in deciding the time of intervention. So the MR is very common, and we'll be seeing many patients with mild to moderate MR. So those patients and all, we should keep on medical follow-up, and we should just observe the patient. And survival is good in patients who are asymptomatic with normal LV function. And acute MR is a medical emergency requiring stabilization and early surgery. And as I told, the LV ejection fraction, the LV end systolic dimension, and the systolic pulmonary artery pressure are the main determinants in the management of chronic MR. And the mitral clip for primary degenerative MR is still having only class 2B indication. And in future, definitely we can expect the mitral clip may one day replace the surgical open mitral valve repair or replacement. Thank you.
Thank you, sir, for giving a brief and detailed explanation about the mitral regurgitation and its overview. And I'd like to ask for the chairpersons for any questions regarding this thing. Sir, any questions?
Hello, Karthik Garu. I want to ask a question.
Yeah, Chapan, sir.
This non-ischemic MR is one purely missed. What is how many cases are dealt and post complications? How are they managed? What is your experience in that?
Non-ischemic MR, sir. Non-ischemic MR, usually the most common cause is either a rheumatic heart disease involving a mitral valve, or it can be a mitral valve prolapse. So those patients who are having this either a rheumatic MR or mitral valve prolapse, the management will be like mainly based on symptoms only. So those patients who are having even moderate MR or even severe MR also who are asymptomatic will keep on medical follow-up only. But those patients, if they develop initially symptoms, means definitely we'll be sending them for surgery for a surgical replacement. And these patients, even I am monitoring some patients who are having severe MR, and as their LV and systolic dimensions, if they are increasing, definitely I'll be sending them for surgery. And complications, if we see these mitral valve prolapse patients, usually many of them are free of any complications, except suppose if they develop any atrial fibrillation, then definitely there is a risk of thromboembolic complications, and we'll be starting them on anticoagulation, either warfarin or acetron. Or those patients, suppose, and these mitral valve prolapse patients especially, they'll have a risk of arrhythmias. Sometimes they'll be presenting with other arrhythmias like NSVTs or some other supraventricular tachycardias. So those patients we should be dealing in those arrhythmias. We should deal in those patients. And one thing main I want to stress in this presentation is I have seen many chronic MR patients or who are having moderate MR will be giving them AC inhibitors so that it will reduce the peripheral vascular resistance and MR is decreased. But there are no studies till now or no randomized control trial which showed that by decreasing afterload there is increased survival in the moderate MR or severe MR patients. So in chronic MR patients, it's even better to give a low dose of beta blocker than giving an AC inhibitor. That is what I want to tell.
What is the role of newer anticoagulants in atrial fibrillation?
Yes, sir. In atrial fibrillation, suppose if it's a non-rheumatic AF, non-valvular, the non-valvular AF, definitely we will be giving the newer anticoagulants like either dabigatran or apixaban. Commonly we will be using. Suppose if it's a valvular AF, definitely the acetron or the warfarin is the drug of choice.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Shyam Prasad, Dr. Vishwanath Karthik, and Dr. S.V. Krishna Rao garu. We'll go to the neurology part of this session. Any more questions, sir? Any in this to Dr. Karthik? Krishna Rao garu maatladala?
No, nothing.
Sir, okay.
Thank you, sir.
Thank you, the chairpersons and the speaker.
Thank you, sir. Thank you. Thank you for giving me this opportunity. Thank you.
Thank you. Thank you very much.
Okay, now we will move on to the next session, the neurological session. We invite Dr. Tarak. Tarak, you unmute yourself.
Yeah, good evening,
Good
everyone.
evening, Tarak.
Good evening, Sambireddy. Come on, tell me.
Dr. Ram Tarak Nath will be the chairperson for this session.
Okay. Yeah, I'm sorry. I have some other engagement, but I will sit through the session as far as possible. Even if I have to leave in the middle, please don't think otherwise, but I will see. I'll manage to sit through the session, okay?
Okay,
Right.
okay.
Go ahead,
Srikanth will take care of it.
Go ahead, go ahead.
Sandeep?
Yes, sir.
Go ahead.
Next, we'll discuss about this is about the concepts and scope of keyhole neurosurgery by Dr. T. Ramesh Garu. So he's from Anu Institute of Neuro and Cardiac Sciences. Dr. T. Ramesh Garu is Dr. Ramesh received his MBBS and Masters of General Surgery from Banaras Hindu University in Varanasi, and he pursued his medical education like neurosurgical residency, MCH training from All India Institute of Medical Sciences, New Delhi, and he's recipient of International Fellow of American Association of Neurological Surgeons in 2014. So after obtaining his MCH, he worked as a senior research fellow at AIMS and also as an assistant professor of neurosurgery at Amrita Institute of Medical Sciences, Kochi, one of the best trusted organizations of India. So now I'd like to ask Dr. T. Ramesh Garu to tell about the concepts and scope of keyhole neurosurgery.
Thank you, Dr. Srikanth. Can I share my screen?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Just a minute.
We have very impressive speakers today. I was going through the CV, very highly achieved at a very young age.
Okay, sir. Thank you. Can you see my screen?
No, sir. No, sir.
No, no?
No.
Not yet.
A minute. Now?
Yes.
Okay. Can you see now?
Yes, sir.
Yes,
Yes, sir.
Dr. Ramesh. Yes,
Okay.
go ahead. I can see it.
Yeah. Good evening, sir. Good evening,
Good evening.
chairpersons, and good evening, Professor Tarak Nath Garu. It's a great opportunity to present my work in front of you. So it's basically concept and scope of keyhole neurosurgery. Unlike like any other surgical specialty, keyhole neurosurgery or a minimal invasive surgery is a main area of surgical field which is evolved over a period of last few decades. So basically, my disclaimers are like this presentation is based on my post-MCH experience of 15 years. And my previous workplace are like AIMS, Kochi, Ashram, Eluru, and Anu. Presently, I recently joined. I have an experience of over 4,500 major cranial and spinal cases operated, out of which 50% of these cases were managed through minimal invasive surgical principles. Okay. So these are a bit of my work experience related data. So the basic principle of surgery never changed actually over the
thousands of years, the surgical principle is the same: to effectively treat the pathology with minimal disturbance of normal anatomy, leaving the smallest footprint of the surgical scar. This is the definition of the surgery, which is true for hundreds of years. However, with the change in the new technology, the dimensions of the surgical scar are changed, that give to the new nomenclature called minimal invasive or minimal access neurosurgery. So among all the surgical specialties to adopt the minimal invasive principles, neurosurgery is the last one actually. Last 2 or 3 decades only the major work has took place in neurosurgery. That's where now the maximum amount of neurosurgical work will be done through these principles in advanced neurosurgical setups. The minimal invasive means it's a blend of technique as well as the technology. Without any of these two, like you are a very good skillful person, but without the aid of instruments or the equipment, you will not able to do these things very well. And nowadays, like as I said, like in advanced centers, almost most of the surgical cases can be done through these principles only. The main goal of this minimal invasive procedure is to operate through a minimal trauma while achieving the maximal surgical efficiency. Like through a small scar or small craniotomy, we can remove the complete tumor. The craniotomy should be as adequate as possible to give an access into the brain, as well as least as possible to give the minimal scar. That is what is the main aim and goal of the surgery is. So if you see the literature over last 2 or 3 decades, gradually, day by day, the minimal invasive procedures are picking up, whereas the open surgeries are coming down and down. Almost it is touching to the base level nowadays. So if you take a armamentarium of any modern neurosurgical theater, it looks like equipped with a lot of modern advanced gadgets like microscope, endoscope, drill, navigation system, neuromonitoring, QSA, and some kind of intraoperative aids like fluorescent technology and intraoperative microvascular Doppler kind of system, which will be helping us in removing the tumors or doing the pathological corrections. So if you are fortunate enough to work in even more tech theaters, it will be like a state-of-art theater is called the brain suit, where an intraoperative MRI will be there, which will be used to check your surgical work, whatever you have done on that particular case. Immediately shift the patient back into the MRI and get an MRI within the theater itself and see how much the tumor you have removed and what is left out, and then you can take up the patient back on the table itself in the same theater and finish the rest of the work if at all it is anything is left out. So this is present only available in very few centers. I think in India, only AIMS New Delhi and probably in MANS Bangalore, they have the intraop MRI nowadays. So if you go to the literature, around 1,000 years back, the primitive surgical technology, which is available across the globe, people can only make small holes like this. So with technology developed over last 1,000 years, now we learn to do the same advanced surgical procedures through the same burr holes or same craniotomies which people used to done 1,000 years back. So the 1,000 years, what we learned is to adapt to the same small craniotomies, where we can do the most complex surgeries performing through these small craniotomies. So that's what the advancement is brought us to that stage. So if you take the concept, it was popularized by Fernanski as German neurosurgeon. So if you see the simple concept, the conventional surgeries, you open a broad to reach the small area of the tumor, whereas it is like a funnel shape. If you come to the keyhole surgery, it's like a reverse funnel. You open a small area, go to see the wider areas inside the cranium with the help of a microscope or endoscope or exoscope, which is a hybrid instrument of the microscope and endoscope. This picture suggests if you have a tumor here, somewhere in the deep inside the brain, you can make a small craniotomy to reach to this area. Whereas if you have a surface tumors like meningioma, we need to make at least a size of the lesion to access this tumor through the small incision. So that's how we need to prioritize or select the cases independently according to the case scenarios. So why we need to adapt to these things? Because the demand of the people are increased. People are opting to go for a minimal invasive procedures nowadays. So this is the demand of the day. So we need to adapt to the technology and give the best results with the help of this technology. So the like as I described already, the MINS, like a minimal invasive surgery itself, is a small craniotomy with a greater need for precise planning and exact implementation to reach to the target and remove the tumor without adding any added postoperative deficits. So I want to just give a glimpse how it works. Like if you take a 3D animated image with a tumor in previously, maybe without these minimal invasive surgical principle, we used to give such a big incision to reach to the tumor area which is located inside. Whereas these incisions were now changed with the small linear scars to reach to the same size as the lesion present within the brain. So I will describe this is a cingulate gyrus lesion on the right side, just adjacent to the motor cortex. So what we do as a routine case, we use the navigation to reanimate the patient along with the tumor markings. We do a surface marking, give a small curvilinear incision, make a small burr hole along the parasagittal area, and then do a small craniotomy around 3 by 2 centimeters in size and open. When you go there, we have a facility called the image injection facility through the navigation system. This is the marking of the tumor. These are the fiber tracks situated from the motor cortex. So we can select the safe corridor, how to reach from this area. Once you have identified your corridor, then go inside to the tumor. After reaching the tumor, what we do with the help of suppose if it is a tumor, with the help of the standard instruments like suction, bipolar, CUSA, you try to decompress core out the internal tumor, whatever is available, without causing any problem. With the other additional aids like navigation, intraoperative ultrasound, tumor fluorescence, neurointegrity monitoring, or in some cases like awake craniotomy or a brain suit, we can take out the capsule, whatever is safely feasible to access without adding any deficits. So intraoperatively, you can monitor the help of a neuro monitoring, or in some cases, we can use the awake craniotomy where patient is talking to us during the surgery, where we can monitor the deficit if at all if it is happening, anything with the patient continuously throughout the surgery. You keep talking to the patient and listening to the patient, and you can check the response, either the speech or a motor weakness. That's how we decide how much tumor to be removed, especially from an eloquent cortex area. Eloquent cortex is an important brain areas where they have a vital functions like speech, movement, and intellectual performance. So that's how the poster scan looks like, complete excision without any added deficits. So we need to have a technology as well as a skillful techniques to do this kind of precise job. So to briefly divide these, briefly give a glimpse of what it is like. A minimal invasive neurosurgery is talking complete neurosurgery. So they can be divided into microscopic or endoscopic assisted microsurgery or endoscopic surgeries. So the microscopic can be like broadly, these minimal invasive principles are nowadays applied to operate through a supraorbit like a eyebrow incision or a mini craniotomy, where we do the international consensus says that the definition of mini craniotomy is around 2 to 3 centimeters in diameter size. If you can able to operate the lesion through that kind of small lesion, it is called the mini craniotomy. Or in some cases, it can be transfalcine or transtendural. Suppose if a lesion is on one cortex, you can approach the lesion through the other side of the brain. So as you know that brain, two hemispheres of the cerebrum are separated by the falx, and the two cerebrum and cerebellum are separated by the tentorium. So sometimes because of the gross edema or anatomical location, if you can't access the tumor directly through the same side of the brain, so you can take the opposite route or inferior or superior cerebellar route or a cerebellum route to reach to the cerebellum, or cerebellar route to reach to the cerebrum. So you can select in very selective cases to go through these areas. So the second subset is the endoscopic assisted microsurgeries, where we randomly use an endoscope to look around the corners of the operative field, where the microscope, you can't reach to the corners or the blind spots of the area. So you can use the angled endoscopes to reach those areas and remove the tumor without adding any deficits to the patients. And the endoscopy itself is a big topic. So they can be transnasal endoscopic surgeries, or a transventricular or intraventricular tumors or hydrocephalus can be managed through this. In view of the time and the limitation of our talk, so I want to skip this endoscopic procedure. I will concentrate on the conventional microscopic or endoscopic assisted microsurgical keyhole procedure. So I will take you through few important illustrated cases from simplest to the most complex, and the spectrum of the cases I will take you through that. So I will start with the microscopic procedure, that is the supraorbital keyhole craniotomy. That is through a small eyebrow incision. We can make a small craniotomy around 2 by 3 centimeters, or roughly you can say that a size of a rupee coin. You can make this craniotomy to reach to the any lesion within the anterior part of the middle cranial fossa. It could be tumors, it could be intraparenchymal lesions, It could be aneurysms, it could be craniopharyngiomas or epidermolysis. So any variant of the tumor situated in this area could be easily approached through a supraorbital keyhole cranial approach. This is also called the SOCA. So I will take you through a few of the illustrated cases through this. So this is an elderly lady, around middle-aged lady presented with the SH grade 3 with an ACOM aneurysm, that is anterior communicating artery aneurysm pointing anteriorly and posteriorly and inferiorly. So this was operated through the same supraorbital keyhole approach. So this is after opening the craniotomy and reaching on to the basal arachnoid case. You can see this is the optic nerve, and we are opening the distal sylvian fissure with the help of the micro instruments. So once you open that, you will be reaching the optic nerve as well as the carotid artery will be seen soon. So this is the anterior cerebral artery here, and this is the anterior communicating segment junction. We are separating out the aneurysm from the rest of the brain parenchymal structures and applying the clip and checking for the patency of the other vessels like opposite A1 and A2. So this is the post-op, this is the post-op scan showing the linear scar and the nicely decompressed ventricle and the clip artifact here. So this is another case of middle-aged lady presented with the grade 4 SH. This is the PCON, that is a posterior communicating artery segment aneurysm. Patient already presented with the ptosis. So after the surgery, the ptosis actually improved. I didn't have the recent image in my presentation, but she came with the improved ptosis and she was completely intact without any deficits. You can see the X-ray showing the bone defect here. So this is another case of a small third ventricular craniopharyngioma, a young girl, around 18 years girl, presented with a gross hydrocephalus. We operated through the same supraorbital keyhole incision. After reaching to the basal systems, we are opening the basal arachnoid to drain out the CSF to relax the brain. So this is the prefix chiasma. Chiasma is pushed anteriorly and the tumor is behind. This is one side optic. So this is area called the lamina terminalis. Behind and between the two optic tracts is the chiasm, and this is the optic tract here. This is the tumor. You can see the mission color IL fluid coming from the tumor cyst. So with using all the microsurgical principles, this tumor was completely removed, and we are dissecting out the last bit of the tumor behind the optic nerve, and it was removed completely. You can see at the end of the surgery, we are trying to take out the capsule and slowly peeling off the tumor from the optic nerve and optic chiasm, and patient came out well without any deficits. So this is the post-op scar. This is around, I think, 1 month post-op scar and the post-op CT showing without any evidence of the tumor there. So this is another case of meningioma. Planum meningioma is an elderly 68 years old male. He is a priest by occupation and is intact without deficits. He just came with an headache and minimal blurring. He came with, this is around 2 by 3 centimeter size of the tumor situated in the planum meningioma. So this was also operated through the same principles. So this is reaching to the base. You can see the tumor. This is an optic nerve here at this area. This is the optic nerve. So we are trying to open the arachnoid between the tumor and the optic nerve with the micro scissors. And once we open up the arachnoid, we are peeling up the arachnoid from the tumor surface and trying to separate the normal brain parenchyma. And this is the opposite optic nerve here. So we are first defining the tumor margins and try to preserve the normal anatomical structure, because this is a very crucial area. One side is the optic nerves, and behind there will be carotid arteries, and behind the tumor will be basilar artery. So we are working with a very complex area of the brain. So we are using the same microsurgical principles to tumor decompression. Bit by bit, tumor is being excised, coagulation and cutting. And tumor was, I made it fast forward to gain some time because it's a 6-hour surgery. So at the end of the surgery, you can see there is a tumor piece left out behind the optic nerve. So I'm working through the optic nerve and carotid artery. It's called the optico-carotid triangle, separating these crucial junctions and trying to identify the tumor left out piece. We are opening the falciform ligament where the optic nerve enters into the eyeball here. The falciform ligament was opened and the part of the anticlinoid process was drilled to remove the small piece of tumor left out here. So the last piece of the tumor was took out from the optic canal. You can see the beautiful anatomy at the end of the surgery. This is a pituitary stalk, right optic nerve and right carotid artery, and this is at the hemostasis. So this is the patient nicely seen scar at the time of the discharge. This is a tumor completely removed following the surgery. This is a post-op scan showing the complete removal of the tumor with an intact optic. This is the pituitary stalk, and the optic chiasm was intact. So there is another case of planum sphenoidal meningioma, elderly patient, completely removed. This actually is the gross part of the tumor base was calcified, so there's a thin rim of the tumor was left over the calcified dura here, because so dealing with this part was a bit crucial because of the injury, anticipated injury to the optic nerve. So we have to leave the small tumor. We are following up this case without any added deficits following the surgery. This is a police constable, came with a giant pituitary tumor. This is around 8 by 6 centimeters in size, occupying the bifrontal areas. The small size of the tumor was in the cellar portion. Probably if I go transnasally, I may not be able to remove this. So I decided to go in 2 stages. First stage to the supraorbital craniotomy. The complete supratentorial compartment was completely removed without any added deficits. Patient maintained his vision, and the second stage we removed this part of the tumor also. And another case is a very crucial case or extent of the supraorbital craniotomy. This is a thalamopeduncularis. This is the midbrain glioma, which is extending on to the right side of the thalamus. Patient roamed around many places. Because of the scarcity of the added complications, many people didn't dare. With the help of the neuronavigation and neuromonitoring, we took up the case through the same supraorbital keyhole craniotomy. So this tumor was done under the neuronavigation as well as the intraoperative monitoring. So we have an intraoperative monitoring to, we map the SSCP and the MEP, that is the somatosensory evoked potentials intraoperative, is the motor evoked potentials intraoperatively. So as we are dissecting out the tumor, after doing the internal tumor decompression, while we were reaching to the capsule, we can see there was some dip in the motor evoked potentials. So that is the time when we were checking our boundaries, inferior medial boundaries of the tumor, where we are reaching to the normal brainstem. That is the time when we saw that there is a dip in the lower limb motor evoked potential. So we waited for 10-15 minutes time, and after doing an hemostasis, on table itself, we regained the motor evoked potentials back. You can see these waves are coming back. So that is the time when you should know when to stop in these crucial cases, especially dealing with these kind of things. This is a post-op CT showing a nice decompression of the tumor. And this is a third post-op day. Patient was completely intact without added deficit. She already presented to us with the diplopia and hemiparesis, and this is 2 years post-op scan seen just last week. The patient is still intact after post-op radiotherapy, and there's no added deficits to the patient. So there is another extreme levels of the supraorbital keyhole craniotomy. That is a pediatric case of a 9-year-old baby who presented with the large third ventricular craniopharyngioma, which was removed through the same supraorbital keyhole principles. At the end of the surgery, child is doing very well without any added deficits to him. So that's how we select the cases. With your experience, you start taking challenging cases day by day. So in a nutshell, I operated around 117 cases. This is a split of the cases, which include aneurysm, tumor, CSF, leak, some intraparenchymal brain lesions, and the brainstem lesions are all there in the supraorbital armamentarium. Coming to the next level, that is a mini craniotomy, where we use any part of the vertex of the cranium or lobar areas of the brain can be approached to the mini craniotomy around 3 by 2 centimeters. This is a small left-sided motor cortex meningioma. Patient, young lady, presented with the seizure, so we have to operate. So if you precisely plan, you can see exactly the size of the tumor. We made a craniotomy, and the whole tumor was excised along the cup of the dura, so without deficits. This is another case of premotor cortex ganglioglioma, vulvodendroglioma, operated through the same process. You can see the size of the craniotomy, and the directly tumor was exposed onto the surface. So same thing was removed without added deficits. So this is another case of premotor cortex glioma done with the same neuromonitoring. So these are the intraoperative MEP recordings. So based on the recording feedback, we have to leave a small cup of tumor here. And this is a post-op scan showing a small cup of tumor, but patient was intact. That's what is the main aim of this patient. So this was subjected subsequently to the radiotherapy. This is another typical case of epilepsy surgery that's called medial temporal or mesial temporal sclerosis. This was done through a small keyhole temporal craniotomy under the neuromonitoring. The anteromedial temporal lobectomy with amygdaloidocampectomy was the standard procedure. which we do for a mesial temporal sclerosis, which was done in a kid without any deficits, is around 12 years old kid. So another extreme of this case where we did a small cranial, this young girl presented with a diploc and a severe headache. You can see a large bifrontal basifrontal tumor extending across the falx with an extensive edema. We thought it is an high-grade glioma. Surprisingly, when I did the surgery, this turned out to be a meningioma. It is good to the patient. So you can see the patient is completely intact after 4 months. Recently it was done. The recent post-op scan is not showing any evidence of enhancing lesion. So completely removed. This is an operative cavity, which is still there at 4 months of time. So going to the transfalcine, transtentorial, as I said, we know there is a tumor with a gross edema. Suppose this is situated in the left paramedian area. There is a sizable tumor around 2.5 centimeters. If I go through the ipsilateral left side, I'm going to add a lot of brain handling because of the gross edema. So I can do a small opposite side craniotomy with almost half of the size of the craniotomy, which is needed to be done on the ipsilateral. I can make a small craniotomy on the contralateral side to reach this lesion across the falx. So that was the same. This is the illustrative images, how we make a small craniotomy, make a small window through the falx and then reach the tumor with the help of a microscope and endoscopic assistance to look around the corners of the lesion. So this is the same lesion which we operated. Initially, we thought it was a high-grade glioma, but during the surgery, it turned out to be early cerebritis stage of abscess. So anyhow, we removed the abscess completely without any deficit. And this is the post-op scan showing a complete excision of the lesion. You can appreciate the small craniotomy size. So going to the endoscopic assisted microsurgeries, usually they are done to the cysternal spaces lesions. So this is a CP angle, right CP angle epidermal tumor, which was operated to a small craniotomy around 1 inch in size. So after reaching to the cysternal space, you can appreciate this is the 5th nerve, this is the 7th nerve here, and in between the tumor. So tumor will be completely done under the observation of the endoscope. So it is completely encasing the 5th nerve all around. So tumor was extending into the creeps of the CSS spaces in the CP angle cistern. So every bit of the tumor was looking around. This is called the Meckel's cave here, where the 5th nerve enters into the skull base and coming out of the Meckel's cave. So the tumor attached to the basal dura was also removed with the help of the micro dissector. This is the 5th nerve. You can see the 6th nerve present here. So the complete tumor was removed without any problem. You can appreciate the size of the skin incision here. It is less than 5 centimeters of the skin incision. So this is another case of a standard microvascular decompression for the 5th nerve trigeminal neuralgia. So you can see these lesions. When we see through the microscope, I can't see the extent of the superior cerebral artery, which is grossly stretching the 5th nerve. If I use the endoscope to look around, you can see the 5th nerve is getting stretched. There's the vein covering over that. And if I pass the scope little anterior to this area, you can see nicely the extent of the 5th, that superior cerebral artery extending. And based on that, you can easily dissect out this nerve away from the artery and put a Teflon patch. This is the standard surgical procedure. You can appreciate the post-op scar. It is less than 2 centimeters post-op skin incision. So there's another variety, that is a stroke intracerebral bleeds. Usually we need not to operate if the volume of the blood is less than 100 cc and patient doesn't have a raised features of ICP. In some cases where patient presents with the raised features of ICP, some people do a decompressive hemicranectomy, but in some cases where we see the gross brain edema is there, we can, without any gross brain edema, we can take out the acute blood to avoid the ongoing consequences. This was done through a small 2.5 centimeters craniotomy with the help of endoscope. Complete hematoma was evacuated. Anyhow, patient presented with the hemiplegia, so there's nothing we can add to the complication. But patient came out very well with the improved sensorium immediately next day of the post-op surgery. And these cases, they help in early extubation of the patients and speedy recovery and early discharge from the hospital. So going to the next level, that is spinal cases. The whole spectrum of the spine nowadays can be managed with the minimal invasive spine surgery or a minimal access spine surgery. The armamentarium can include the degenerative disorders like disc disease, listhesis, deformity, or osteoporosis. are some tumors called intradural extramedullary tumors or some extradural tumors. In rare cases of the spinal trauma, these principles can be applied to do this with a very small incision. So if you take a standard extruded disc at lumbar level, this can be removed through 3 different approaches. That is one subperiosteal dissection and placement of a small tubular retractor, or a in transmuscular tubular retractors or transforaminal endoscopic discectomy. These are the standard 3 approaches used everywhere. This is a whole gamut of the retractors available in the world and market, and many people have their own ways of customized retractors. I did develop one retractor some 13 years back, and I was using this without any problem to do more than 1,000 of these spine cases, and getting the same results like you can achieve with any other internationally reputed retractor system. So this is due for publication. So this is the standard interlaminar fenestration and discectomy technique. We place my retractor here. We are doing a fenestration, and after that you can see the root is being moved away with the help of a small retractor. This is an extruded disc which is pushing the root up. So we are mobilizing the extruded disc fragment and removing it just like a delivery of a baby. The extruded fragment is removed, and whatever the free disc fragments there, we can remove that, and completely patient will be pain-free immediately after the surgery. So the standard procedure, like a 1-level disc, 1-inch incision, 1 hour of surgery, 1 suture can be used to close the whole wound, and 1 day of hospitalization is what is a standard microdiscectomy, can be summarized in 1 slide. So you can see the 1-inch incision. It is a subcuticular incision, so patient need not to stay in the hospital for suture removal. You can be discharged next day morning. So extending the same principles to the intradural extramedullary tumor. This is called the schwannoma in a L1 level. So this was done through the same surgical principles. We are doing a small hemilaminectomy through the my own retractor. So this is exposed dura. We are doing a small durotomy through the paramedian exposed area. So once you expose the durotomy, you find out the attachments of the roots to the tumor. So we are excising the attached root superiorly as well as inferiorly. You make sure that the tumor is completely free. And if it is a small in size, you can deliver it as a in toto tumor, or if it is a large size, you can do an internal decompression and remove the tumor. So this is a case of pot spine where you don't have a deformity more than 30 degrees of corpse angle. The large paraspinal or a psoas abscess can be done through a small keyhole decompression so that you can avoid a major fixation in them. So you drain out the pus and you drain out the granulation tissue, whatever it is there, without adding any damage to the patient, and the thecal sac can be decompressed so that the nerve compression will be reduced and patient weakness can be prevented with this approach. This is a case of L1 fracture, patient presented with the paraparesis, young patient, done through the same principles, a transpedicular corpectomy with the case placement and the percutaneous screw fixation using the same minimal invasive principles. Whole big surgery, around 8 to 10 hour surgery, was done through the same minimal invasive principles without adding any major deaths to the patient. So in nutshell, this is the gist of the minimal invasive neurosurgical procedures, what I talked to you. This is only illustrated cases. The whole neurosurgery can be it is very difficult to summarize in 30 minutes time. So this is, even though looks quite fascinating to see and listen, but there's a hard work in this, in planning, execution, and doing a meticulous surgery. However, as we are depending on a lot of techniques and technology, there are going to be some limitations of this. There is a failure of the machinery or navigation machinery and neuromonitoring. You need to abandon the procedure and come back with the re-registration or re-establishment of the instruments. So there can be failures in the technology. And when you're trying to do a very small craniotomy, this can land up in a very awkward situation where you can't go to the targeted lesion without adding a brain damage. So you should be very clear. You should select the cases based on your experience and expertise. So adding to the same limitations, you need to have a very determined pre-operative surgical evaluation and a predefined surgical corridor. So you can't mess up once you open up the small area. You should be very precise, and you need to know which direction to go in to avoid the eloquent cortex or some kind of long tracks based on your navigation and all other equipments what we use in the theater. You need to pre-plan every possible surgical steps, and the difficult intraoperative orientation sometimes can lead to abandoning the procedure. So insufficiency or availability of micro instruments is a big limitation. You need to have an appropriate instruments to do the surgery, and decreased illumination in deep-seated lesions. Suppose if you don't have an endoscope available with you, so trying to operate these lesions only with the microscope sometimes may be compromising your quality of surgery. So you need to have all the available technology available in the theater to have a safe surgery and the best maximal safe dissection in the least possible complications to the patient. In conclusion, like minimal invasive surgery or keyhole neurosurgery is the demand of the day. It is rapidly evolving and needs technique as well as the technology, and to be individualized based on the patient and the pathology. So your expertise, patient pathology, and the size of the lesion is very important to select based on the individual basis, and should know the advantages and limitations of this technique. You can't jump in for every case. So based on your expertise, as I said, you need to really judge the individual case to go in or not to go in through the same minimal invasive principles. So microscope, endoscope, or exoscope. Exoscope is a small tool which is a hybrid of microscope and endoscope, which will be used in routine surgical theaters to have an illumination. So these are the complementary to each other. You can't replace one with other. You need to have everything based on the complexity of the case. Thank you very much. And before I conclude, I want to thank all my teachers with whom I got trained and have an exposure with them, and all my patients who they gave me opportunity to operate on them. Thank you very much. Thank you, Tenali IME, for giving me this opportunity. Thank you very much.
That was an excellent talk, Dr. Ramesh. I'm impressed.
Thank you very much, sir.
I'm particularly impressed with that thalamic and peduncular cerebral peduncle glioma. That was a good result you got. I just have one question. Have you had the occasion of any time a patient, supposing patients of TB meningitis while on treatment, they improve apparently, and then they develop lot of opticochiasmatic arachnoiditis with lot of granulomas around the optic chiasma and optic nerve? Have you had the opportunity to operate in any one of these with your
sir? Actually, I did had some 5 or 6 cases like that.
Good.
So we tried to decompress 1 or 2 cases, but the results are not appropriate. Okay. So the literature also says that if they developed severe visual compromise, so most of them they don't recover with the surgery.
Yeah, but
they don't recover with the surgery.
You can't just. Sometimes I feel we just can't leave them with treatment and hope for the best. Sometimes they may go blind.
Sir.
So I was always thinking of whether is there any way you can decompress this damn thing and then leave them free.
See, because if you go transcranially, how many times you do an arachnoid dissection, that's going to add to the scarring
inflammation
and re-station. So sometimes we can go the transnasal and decompressing the optic nerve, which we did in 1 case, but it didn't show much of improvement.
Okay, good. That's a very nice talk. I'm impressed. Very nice. And
thank you very much.
Congratulations.
Thank you very much. Thank you.
Thank you.
So, any questions from anybody? Sambriti, is there a co-chairperson here? I saw a neurosurgical co-chairperson in the...
No. She is other way occupied. She's getting married.
Fine. Oh, congratulations to her. Convey congratulations from Tenali IME and myself. Anyway, right. That was a nice talk. Any questions? Can we move on to the neurology talk?
Yes, sir.
Next one.
By Dr. Naveen.
Yes, sir. Next it's the talk by Dr. Tota Naveen Garu. So he's the first movement disorder specialist in Andhra Pradesh, and he did his DM neurology from SIMS in Tirupati, and he had wide exposure in management of neurological disorders and extensive clinical experience in treating Parkinson's. And he's performed the first DBS for Parkinson's disease in Andhra Pradesh, and he did a total of 50 patients. And he has a great experience, and he also is an associate professor in SWIMS from 2016 to 18, and now he's working in Anu Institute of Neuro and Cardiac Sciences in Vijayawada. So today he's going to detail about the role of Botox in neurological diseases. So I request sir to start the thing. Thank you.
Welcome, Dr. Naveen.
Okay, sir. Thank you, Sandeep, for the kind words. And good evening, everyone. And my topic is the role of Botox in neurological disorders. And I would like to go through this topic in the following headings. First, briefly, the introduction, pharmacology of the botulinum toxin, how it works, and common indications in neurology and injection techniques. And I will enumerate some of the cases that we have done. And introduction, botulinum toxin is derived from
Your screen is not visible, Dr. Naveen.
What screen is not visible?
Yeah. Share your screen.
Yes, please. Just a minute, sir. Is that okay now?
Yeah.
Oh.
Now we can see.
Thank you. And mechanism of action of botulinum, briefly, I won't go into details. And we have to know that normally the acetylcholine is transmitted into the neuromuscular junction through exocytosis. It has a protein itself that is a membrane protein that is synaptobreverin, and it has two other proteins which are on the external surface of the internal surface of the neuromuscular junction. That is the plasma membrane. There are syntaxin 1 and SNAP25. So all these proteins twine together, and exocytosis of the acetylcholine will happen. Then with the adequate amount of acetylcholine in the neuromuscular junction, the action potential is generated and propagates. So this is the way the action potential generates and propagates. So the mechanism of action of the botulinum toxin, you can see that the same thing that I'm saying is by attacking these snare proteins. So most often they attack the SNAP25, and they prevent the exocytosis of the acetylcholine, and it is largely reversible. And most of the patients will revert to their normal phenomenon, that what they are previously having within the next 3.5 to 4 months. But the average time they respond is 3.5 months, most of them. And history of clinical development in brief, in 1989, it was approved for blepharospasm and strabismus. And in 2000, it is approved for cervical dystonia. And 2010, it was approved for chronic migraine. And 2010, it is also approved for upper limb dystonia, detrusor overactivity, and lower limb spasticity. There are many offline indications as well that we use in the day-to-day practice. So these are the things that are available in India. We don't have this neuroblock here. We have botulinum toxin A, and we have Xeomin, and we have Dysport. So I don't want to go into details of these things, but so actually the Dysport, 1 unit of botulinum toxin A or Xeomin is equal to 3 units of Dysport. Suppose if the 100 units of botulinum toxin A efficacy is equal to 300 units of Dysport. So generally for botulinum toxin, for cervical dystonia, we use Dysport, and for botulinum toxin, all the other things, including cervical dystonia, can be used. So blepharospasm, it is an involuntary contraction of periocular muscles. It's almost like a functional blindness, and these are two types, where the eyes contract constantly, that is a tonic blepharospasm, and if the eyes blink is increased, then it is a clonic blepharospasm. If it is too much, it becomes a functional blindness. The patient can see normally, but because the eyelids closes, it is almost equal to functional blindness. So the muscles involved primarily is the orbicularis oculi muscle, that is around the eye, and the axillary muscles are the corrugator and the procerus. So primarily, if the patient comes to us, and the first time we primarily target them with a 25 units that is distributed on both the eyes, that is orbicularis oculi. And if the patient doesn't respond, we will go up to 50 to 100 units in the later on doses. So these are the targets. You can see briefly. The preseptal, this is the pretarsal area, and above this one line, that is the preseptal area, and this is the orbital part of the orbicularis oculi. The patient has sustained contraction. We target the orbital part and the preseptal part, and the most safest is the pretarsal part, where you can avoid ptosis. And this is effective for clonic. That means if there is increased blink, then you can target the pretarsal. But if the patient is having tonic phase, that is the sustained contractions of the eyes, then we have to target the preseptal part of the orbicularis oculi. If the patient is not responding, then we will go to the axillary muscles, that is corrugator supercilii and the process. And this is the method grossly where we inject it into the orbicularis oculi muscle. Already I spoke about the injection doses, and the precautions is that you should avoid injecting, especially in the lower eyelid. You should avoid injecting into the. You should not cross the midline so that to avoid dryness of the eye, so that lacrimal gland won't be affected. In the upper eyelid, we should take care that you should inject to the edges so that if the Botox seeps to the center, there can be ptosis. So this should be avoided, and the patient end up blepharospasm subsided, but the patient will end up with ptosis. Even if you take care also nearly in the first doses, especially in the first doses, 10 to 15 patients present, percent of the patient present with ptosis. So we have to tell the patient that this complication can happen, especially in the initial doses. So this is the patient. You see, this is the clonic type of blepharospasm. Some tonic, predominantly a clonic type of blepharospasm. We are just seeing the increased blink here. So for this patient, preferably we target the pre-tarsal area of the orbicularis oculi, and they do well generally. And this is another indication which we most common of the blepharospasm and the hemifacial spasm which we inject in the day-to-day practice. And this is involuntary irregular clonic tonic. It means you can see the facial muscles, facial nerve which supplies on either side, so half of the muscles, right from frontalis up to the platysma. So one half of the face, the patient, primarily hemifacial spasm is contraction, involuntary contraction of the muscles that are supplied by facial nerve. Normally, it generally starts in the upper half, that is orbicularis oculi, and generally spreads to the lower half. Generally, so as the time goes on, in the first year, it can evolve from starts generally with orbicularis oculi, and the later on platysma is also involved. So initially, the patients will be okay with 25 units of Botox, but later on, as the disease progresses, they might require about 50 units of Botox in one half of the face. Sometimes platysma itself takes about 50 units of Botox. So up to 100 units also, some patients require injection. So this is the technique, injecting the orbicularis oris and orbicularis oculi is the same technique that we use for blepharospasm, and this is for the zygomaticus. Generally, we should avoid injecting into the corner of the mouth so that the patient will end up drooling from that corner because of the paralysis of orbicularis oculi and difficulty in closure of the mouth. But above the lip and below the lip, and we can inject this one, and the mental part also we can inject. This is the patient, you can see the pre-injection patient. This is sustained contraction of the left half of the face, and post-injection you can see there is some amount of weakness. That is 3 weeks after the dose. Generally, this happens, and this stays for 2 to 3 weeks post-injection, and later on this disappears. The patient will be okay for the next 3 months, and again we have to inject one more dose. Generally, we should maintain at least 4 months between the two doses, so that patient doesn't develop antibodies. We know that Botox is basically a protein; it can develop antibodies with time. So at least 4 months of time we should maintain between 2 consecutive doses. And this is one more patient. And this is the right half of the face, and similar patient. And you can see this is 3 weeks, and there is a mild twitchings of the right half of mouth and some hemifacial spasm, orbicularis oculi contraction as well. And there is weakness as well. So this weakness, generally, we have to mention the patient that during the injection itself, after 3 weeks, you can have some weakness on the face, which hemifacial spasm can occur, but it disappears over 2 to 3 following weeks, and the patient will be okay for the next 3 months. And cervical dystonia, this is involuntary contraction of the muscles that involve the movement of head to right, left, and anterior and posterior. And it broadly, I won't go into detail, but it can be a primary or a secondary cervical dystonias. And 4 types are there. That is, torticollis is rotation to one side is torticollis, the right or left, and Other is the lateral pollice. If the head bends to one side, then that is lateral pollice. The head bends forwards, that is anterior pollice and retropollice. And most often, a combination of all this can happen in some patient. So we have to see which muscles are contracting, which are the original movements that are occurring, and which are the original compensatory movements that are occurring, and we have to target the original movements itself. For this, the video helps. You have to all the patients you have to take a video and observe the video, and then you have to take a decision which muscles you have to inject. So over a span of time, the muscles, the primary muscles which we inject atrophy and they become weak. Brain always remembers the movement, it's not the muscles. So the axillary muscles will take over of the initial doses and the same movement will occur. So we have to take a video and see which, so that we can phenomenology, we should catch the phenomenology of cervical dystonia and target the muscles appropriately. Otherwise, after 5 to 6 injections, the primary muscles will become weaker and the secondary muscles, axillary muscles will take over the movement. So we should know that what is the primary movement that is occurring. So always take a video before giving the first dose, so that the following doses it can help targeting the muscles. And the most often just a antagonist, that is characteristic trait that occurs, that patient can have relief by touching. Suppose the patient is turning the head to the left, then he will touch the chin and there will be a relief. That is the occurs in the initial stages, but later on if the disease progresses, just antagonist disappears. Most of the patient, they will have an honeymoon effect during the morning hours. That is post sleep, there is decreased movements, and as the time runs, the movement becomes more prominent. And these are the muscles. If there is grossly, I will tell the primary muscles itself. And if the head is moving ipsilaterally, the primary muscle is that to the left side, the primary muscle is splenius capitis, and the sternocleidomastoid of the opposite side. There is opposite sternocleidomastoid and ipsilateral splenius capitis will turn the head to the left side, that is ipsilateral side. And if the predominantly the movement is back, then it is splenius capitis on the back side, that is, and semispinalis. The movement is predominantly anterior, then it is sternocleidomastoids on either side, along with the flap muscles of the neck. So we have to target these muscles. And there are multiple axillary muscles. This is torticollis, that's turning to the right, and it's the same thing. I don't want to go into details of these things. And you can see this young lady on the left side. You can see. So always while sitting, the patient can be at rest. So you should always observe while walking as well to see the predominant movement. And you should tell the patient to let the movement go on, so that we can categorize the phenomenology and see which muscles are involved. You can see there is lifting of the shoulder on the left side along with turning of the head to the left. That is prominently the splenius capitis on this side, that on the left side, and sternocleidomastoid and the trapezius are the muscles which we have to target initially for this patient. And you can see post-injection into these muscles, there is significant reduction after 3 weeks. And you see, this is the classical case of torticollis. You can see the overlying spasms as well. My head is turning to the left. So see the patient while walking, it is repeatedly turning to the left. The patient looks fine. The muscles that we have targeted is the right sternocleidomastoid and the left splenius initially. And these are a complex type of dystonias, that is oromandibular dystonias. The most common thing that we are seeing now is the levosupride that is being increasingly used for gastritis. And this is causing the oromandibular dystonias nowadays. And most of the patients, at least in my practice, at least 50% of the patients who are presenting in the middle age have taken this levosupride drug. So before giving levosupride itself, we have to think whether to keep this drug or not, and we have to notify the patient as well. And oromandibular dystonias, primarily jaw closing, jaw opening dystonias, jaw deviation, that is to the one side, and lingual dystonia and pharyngeal and mixed, and all the combination can occur. That is, so we should know the muscles which close the jaw, which open the jaw, to target the muscles. So for the jaw closing dystonia, the muscles that are primary muscles are the temporalis muscle on either side and the masseters. These are the primary muscles that cause jaw closing. And the medial pterygoids as well. They are the jaw closing muscles that is there inside the mandible, in the medial side of the mandible. Generally, medial side of the mandible, we target these muscles using EMG guided botox. Whereas jaw opening dystonia, that is the opening of the same dystonia, jaw opening, the primary is the lateral pterygoids. They open the jaw along with that strap muscles of the neck also assist in opening the jaw. These are the muscles which we target in jaw opening dystonia and jaw deviation based on the movement. Either there is a mixed deviation, the jaw you push it to the opposite side, then it is the masseter on one side, and the lingual dystonia, that is jaw tongue protrusion or tongue retraction. This is a complex type of dystonia that can occur. Generally, the tongue protrusion dystonia occurs, that is target genioglossus for this one, and pharyngeal and mixed varieties of dystonia can happen of all these combinations. So this is what this is the temporalis and the masseter, which occurs for jaw closing dystonia, and the opening of the dystonia, the lateral pterygoids, and it opens the jaw. And these are the flap muscles that assist in opening the jaw. So you can see this person. He is primarily recurrent tongue bites, non-healing ulcers of the mouth, and all those things with loss of reflexes and some choric movements. See, the patient is biting continuously. You can see the hyperactivities of the temporalis and masseter. And primarily, you have to target the temporalis on the other side, masseters on the other side, and medial pterygoids muscles in the post injection video. See, they has kept these things cap for avoiding tongue bites. So the patient also had significant weight loss. This occurs because of these patients, general neuroacanthocytis patients, they have difficulty in swallowing. That is feeding dystonia. They have feeding dystonia. They typically push the food inside the mouth along with the features which I have covered. So you can see this patient on the gentleman on the left side. He's trying to talk, and he's telling that while he's trying to feed, open, the jaw opens and the food falls out. So food falls while eating. Also demonstrating his problem. I didn't have the display of this patient while giving. Typically, EMG guided injection to the lateral pterygoid. Similar lady who is having jaw opening dystonia. This is post Botox after 3 weeks. He has sent his video from his phone. Much better now. He says that he is able to eat chapati better than before. He requires some effort to eat as well. And the most common focal dystonia that we see, these are primary dystonia that we see. These are writer's cramp. This is a task-specific dystonia, and this dystonia doesn't occur in other activities, but while they're doing a specific task, only these dystonias occur, and these are called as task-specific dystonias. And the most common that we see in our day-to-day practice is the writer's cramp. That is, while writing, there will be inward flexion or curling of the fingers or extension of the fingers. That is flexor deformity, flexor type of writer's cramp or extensor type of writer's cramp, or a complex type where you have a combination of flexion and extension as well. You can see one of the case. While the patient is writing, you can see there is extension of thumb, and there is also some extension of the index finger while writing, and that is extension of thumb is by extensor pollicis longus, and extension of the index finger extensor indicis proprius. These are all the small slender muscles that pass through the forearm in the extensor aspect. So we target generally through EMG. This is for extensor pollicis longus is targeting, and this one is the extensor indicis proprius targeting. See, now it has become clear that his thumb has extended too far, and there is some extension of extensor indicis proprius as well. And I want to show some complex cases as well. And this gentleman is a 40-year-old gentleman, and he's having blepharospasm, involuntary closure of the eyes and opening of the jaw and protrusion of the tongue. See, and intermittent backward posturing of the neck. There is retrocolis, tongue protrusion, jaw opening, and blepharospasm. This is the combination. This is a craniocervical dystonia. And there is a history of gesture. There is some relief by keeping, generally patient having oromandibular dystonia, keep various things like toothpicks and all those things. You know, some keep their clothes in their mouth so that this due to gesture this subside, and there is significant sleep benefit as well. And basic, all the workup was negative, and the patient can't afford. We didn't do further workup of the genetic testing. And this is the pre-procedural video. You can see how bad this patient is. The continuous jaw opening, protrusion of the tongue, and see what happens when he walks. So he's trying to cover it up with the gesture. That is, by touch, there is some relief of dystonia. People used to throw stones at him thinking that he is mad, especially children. This was a very complicated case that I was the science films. And we have targeted the muscles, that is jaw opening, blepharospasm, and genioglossus, along with semispinals and splenius capitis muscles. These are the muscles which we have targeted. Post Botox after 3 weeks. Says that he is pretty good. But, his response was very short lasting. Each dose lasts only for 2.5 to 3 months only, and we have to maintain that interval so to prevent antibodies. So every 4 months he receives one injection. And that means proper planning and meticulous execution can give good results and bring a lot of relief to this patient. And my second case, this is one more complicated case. This is a 54-year-old gentleman, abnormal posturing of the head, right upper limb since 2 years. That is, there is right torticollis, protrusion of the tongue, and closure of the eyes since 6 months. That is, this is also a craniocervicobrachial dystonia. It has involved 3 segments. See, well, patient is, there is a right torticollis, and there is elevation of the right shoulder. I'm not sure of the brachial component, whether it is just a gesture, I think. So we didn't target that muscle. And there is some retrocollis as well. There is a combination of torticollis and retrocollis. Torticollis to the right and retrocollis combination. Elevation of the right shoulder as well. And there is blepharospasm. And there is mild protrusion of the tongue as well. So we have targeted these muscles. There is orbicularis oculi, genioglossus, bilateral semispinals, and splenius cavity. There is muscles at the back of the neck to prevent retrocollis, and left sternocleidomastoid, so that there is a right torticollis as well, and the right trapezius to prevent elevation of the shoulder. The post-Botox procedure is much better now. we have to, before giving the injection, we have to see the patient at rest while speaking, while doing activity, and most importantly, while walking. And take-home message from this case is the differentiate between a dystonic movement or a gesture or a compensatory movement. And video prior to procedure always helps. We have to see which movements are occurring and which are the compensatory movements and which are the movements that the patient try to compensate using gesture. So we have to target the muscle specifically. And these are the references. And the time when I have spent my time with the movement disorder team in IMAS, Dr. Paul, Dr. Aviado, and my colleagues, and movement disorder colleagues in the movement disorder lab in IMAS.
Hello. Are you done, Naveen?
Yes, sir. Yes.
Yeah. Good. Very nice talk.
Thank you, sir.
It was excellent and most complicated cases. Is there a limit on the dose, how much you should give? Because you had so many muscles to inject, you do it in the same sitting?
No, sir. Some patients, especially if you do for spasticity, some patients require about 1,000 units also.
Yeah.
It depends.
And have you had the occasion? Yeah, go ahead.
Especially initially we do with the low doses only, sir, and we try due to titrate or a second or the third dose, we know specifically which how much the patient requires for a particular movement. Sir.
Have you had the occasion to give Botox for a patient of palmar hyperhidrosis? Because we see sometimes patients, they can't write the exam also. Continuously, they have hyperhidrosis of the hand. Have you had the occasion to use this?
Yeah. Yes, sir.
Yeah.
One case we have did it in NIMHANS, but not in the practice.
Okay.
And because generally these patients' response lasts long for 6 months to 7 months. Typically, these muscle movements patients only last for only about 3.5 to 4 months.
I know. Yeah, because that's sometimes a problem. These patients, everything they touch becomes wet and they can't write the exam. And I do get patients, I really don't know, but sometime back, some people are doing ganglion blocks. I was wanting to try this palmar injections of...
Definitely, sir. It takes 100 units each hand.
Yeah. It will take 100. Anyway, that's an excellent talk. Yeah, I've heard you before on DBS. And this is another thing. Are you doing for other conditions DBS other than Parkinson's?
Yes, sir.
Like
DBS,
essential tremor,
dystonia, and all those things.
Yes. Are you doing very good?
Dystonia, tremor, and Parkinson's we are doing. So not for psychological disorders.
Oh, you are not getting any patients for OCD?
No, sir. We don't want to try because we can't manage them anyway.
Okay. Right. That's very good talk. Any questions? I'll hand it over to the organizers.
Hello.
Sambireddy? Yeah.
Hello.
Sambasiva.
Hi, sir.
Sambasivudu, come on, tell me.
There is about the oromandibular dystonia that is secondary to levosulfide intake. See, levosulfide is centrally acting rather esophageal gastroesophageal muscle sphincter coordinator. And if you stop that, if that is oromandibular dystonia is secondary to levosulfide, after stopping the drug, it should disappear.
No, sir.
So, is it necessary to give botulism to pterygoid other muscles?
No, sir. Actually, liver suppress have a host of movement disorder complications, sir. It can cause Parkinson's, and most of them, actually, those movement disorders secondary to liver suppress remain for lifetimes because it causes permanent changes in the dopamine receptors and dopamine mechanism, metabolism.
How much dosage is required to permanently damage that neuromuscular receptors?
Permanently? No, sir. This is only a temporary phenomenon, sir. It occurs
if it is temporary phenomenon, there is no necessity to give the botulism injection. You see, these many people nowadays, they are bringing the levosulfide. I do accept that it is centrally acting that causes sedation. Okay. Unlike ketopride and other domperidone and other things. That is why, of course, I am not using that much levosulfide. But if it is causing temporary, there is no necessity to botulism injection.
No, sir. It is not temporary, sir. Botulinum toxin only acts for 3.5 months. Actually, the secondary effects of the side effects of levosulfide will be like most of the patients will be for lifetimes.
Is it fully documented? Is a permanent? See, I want a little clarification because levosulfide, many companies are propagating it.
Yes, sir.
Levosulfide tablet, levosulfide intakes tablet. They are coming in tablet only along with the rabiprazole and other things. They combination they brought it. And
Yes,
if
sir.
they causes permanent damage in the neuromuscular effect causing the dystonias, then it should be banned and we should not use much. Basing on incidents also. If it is causing temporary, then there is no necessity to go for botulism injections. Stop that levosulfide. It is caused by the levosulfide. Stop that. Then they should come down. They should improve.
Actually, Movement Disorder Society is putting up a paper, sir, very soon.
And that we also should see. If somebody writes paper, doesn't take it granted, but we also should have experience and also observations.
Okay, sir. Not all the patients
use generally gastrointestinal surgeons or gastroenterologists, they use levosulfide. See, this is mainly used for the esophageal GERD, what we call gastroesophageal.
Nearly 75 mg per day they use, sir.
Yeah, I see. Sambasivudu, we see a lot of patients of levosulfide-induced movement disorder. Actually, I see more of these now. I'm always worried. మేము గ్యాస్ పిల్లలు వాడుతున్నామండి, ఏంటి వాడుతున్నాం, ప్యాంటసిడ్ అంటే అది తీసుకురా అంటారు. తీసుకొస్తే ప్యాంటసిడ్ ఎల్ అని ఉంటుంది. That L is a very treacherous drug.
Yes,
see,
that
now,
is why
I'll tell you. Now, most of they can be reversed if you stopped. But in some patients, like what happens is we give antipsychotics for so many patients in psychiatry for years. We have been giving for thousands of patients. Now, what happens? All do not develop tardive dyskinesias.
Okay.
Got it? So in some patients, it may be like that. When the receptor changes, then you can get. Most of the times it is okay. It goes off with when you stop, you're lucky to get away with it. But sometimes what happens is like what we see so many times we prescribe D2 blockers, psychiatric haloperidol for years they take. Most of them are all right. And if they develop dystonia, you stop, they become all right. But some patients, when they develop tardive dyskinesias, then those patients all may not recover, and even if you stop it, they may not recover.
The oromandibular variants, they doesn't recover much, sir.
Yeah, that's it.
Okay. Thank you.
Now after psychiatry medicines, even now more than psychiatry, now we are worried about this L. I have seen so many. Every patient of Parkinson's, give me what medicines you are taking, it is L.
Tarak, I accept when they introduce generally, I will also take now and then the tablets. When I have taken, I felt sedation. From then onwards, I don't take the levosulfide. I don't write also for anybody.
No.
Levosulfide. Just stop that. Okay. Thank you.
I think I have never seen a neurologist prescribing most of the levosulfide, actually.
Yeah. I don't prescribe. Nobody prescribes.
No neurologist prescribe levosulfide.
Then we should come forward to all the medical conferences, mainly gastroenterological conferences, that levosulfide combination is not good. So then they will stop. The company people also, they will stop.
See, we will say it is not good because the patients will come to us. But for several, you must be giving it in lakhs and lakhs of people. If you take that, the percentage may be less. But what we see is, we always come, when we see the drugs, it is L. So when you ask a neurologist, he will say, no, that's a very bad drug.
We see many patients of Parkinson's who are diagnosed.
Parkinson's.
They are treated for gastritis.
And the other drug that commonly overused is the sibelium, flunarizine. They take for months for migraine. They come with Parkinson's disease. So I always ask, what medicine I've been taking
like
for 6
Stemtil
months,
also
1 year.
produces. Like
Not just antipsychotic medications. These are the drugs which are, and for vertigo, I see patients taking lot of days Cinarizine. That's another thing that produces. So among the drugs which normally practitioners does not suspect of D2 blockage and development of movement disorders is, one is sibelium, that's your flunarizine, 2 is Cinarizine, and 3rd is, the most common is of course levosulfide, which we spoke about.
Okay.
These 3 drugs, be careful.
Everybody knows about these ones, antipsychotics, but there is very little education about the levosulfide.
Yeah, that is what I'm trying to tell you.
Non-neurological fraternity.
This is a practitioners forum. I think we'll impress on that.
Okay.
Thank you. Thank you. We
Question,
particularly
Naveen.
from IMA, I would just like to thank Dr. Tarak Nath, in spite of having a very personal work. he is obliged to take some time for us. Thank you, Tarak.
For old time's sake, man, you're my friend. Thank you.
Thank you. Thank you.
So
I
one
thank the,
small question,
yeah.
Naveen.
Yes, sir. Naveen.
Come
sir.
One small question. Congratulations, nice talk. When do you consider your hemifacial spasm cases for surgery? That is a microvascular decompression.
Which one, sir? What is that one?
Hemifacial spasm cases. When do you consider them for surgery?
All the patients who are secondary and very resistant cases, we give them option of both Botox and these things.
Okay.
Especially
How many
if the
of them
patient is an older patient, most of the patients are old. But if the patient is having complications like diabetes, cardiac problems, and all those things, generally we advise them Botox only.
Okay.
The patient is a young patient and doesn't have any complications, and there is a definite evidence that there is a microvascular compression over the facial nerve. We give both the options. It's up to the patient to decide which way to go.
Thank you.
Especially young patient, it's better to go with microvascular decompression because long-term Botox injection can cause
exactly.
Yeah.
If
Actually,
I think
many
it's a
people,
permanent cure.
Can happen.
Yeah, sir. Why I ask this question is we do get cases, but they come up in very late stages.
Yes,
especially trigeminal also. I've seen few cases they come with a lot of scleral scar, scleral ulcer.
Yeah, when the nerve is
and
already
lost
damaged.
vision. Yeah, especially because of the sensory loss, they do get eyeball damage, and this even the hemifacial spasm also patient they do present with atrophy of the muscle also. So especially those cases who require a long-standing repeated Botox or those who are affordability is not that good, they should be the cases to go for immediate evaluation with an MRI, with a Fiesta scan, and probably the microvascular decompression gives a very good results.
Yes,
so I have done many cases and they really do well with microvascular decompression following the hemifacial spasm.
Even today also I saw one case of trigeminal neuralgia, definite vascular compression. I advised them this one, but the patient is afraid. They have studied somewhere that Botox.
Yeah, many patients actually this is training them actually. See, many patients were directed for gamma knife, which have operated 2 cases with failed gamma knife. See, even though the literature says, but they are not the very good cases for radiation actually. So if you really counsel them, they really turn up for decompression. Especially many cases they come with the dual pathology like trigeminal neuralgia associated with hemifacial spasm. So 99% of the cases, the surgical results are really good if some experienced person does, and it is almost like a cure for them for many more years.
Exactly. It's curative and it is less expensive than Botox given over
and
period
it's quite
of time.
safe surgery, sir. It is a cysternal surgery. We don't damage any brain actually. Many people were scared like brain surgery. People are scared with the brain surgery.
That is the whole
brain
matter.
surgery, but it is a safe surgery. That should be the message conveyed, like because a lot of referral doctors are there, so they should know that there's an alternative.
Well taken.
Yes, sir. Because thank you very much. Thank you, Dr. Naveen. It's a nice talk once again.
Thank you, sir. Thank you very much.
Thank you.
Okay.
Thank you.
Okay, then can I leave the meeting, Sambireddy?
You can. Thank you. Thanks once again.
Thank you, Naveen. Thank you, Dr. Ramesh. It was an excellent.
Thank you very much, sir. Thank you. Thank you very much.
Thank you, all the IMA members. Thank you.
Thank you. Thank you, sir.
Thank you very much.
Okay, for today.
Yes, sir. We thank all the speakers and delegates who have participated in this CME 2020 first day, 26th December. And we have completed 2 sessions. Tomorrow we'll be having 3 interesting sessions starting at 9 a.m. Thank you and good night.
Thank you once again, IME Tenali, for giving us the opportunity. Thank you once again.
Thank you, IME Tenali.
Thank you,
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.